esteemed doctors, honored dignitaries and participants. A very warm welcome and pleasant welcome to each one of you. It is my privilege and honor to welcome you all to today's CME program behalf of Kamalnayan Bajaj Hospital, Chhatrapati Sambhajinagar, a primary care institution committed to excellence in patient care, medical education and research. My name is Tanaya Mahesh Gowde. I feel truly delighted to be your host and master of ceremonies for today's academic program. Every question sparks a thought. Every lesson leaves its mark. Today, we gather not just to learn, but to inspire the future of healthcare. Medical science is constantly evolving and learning a lifelong journey. CME programs like today's provide an excellent platform to exchange knowledge, share experiences, and stay updated with the latest achievements in healthcare. With a great enthusiasm and gratitude, I extend a heartfelt welcome to all of our respected speakers, faculty members, delegated, and participants. Your presence has truly added value to this academic gathering. Without any further delay, let us begin today's enlightening session and make the most of this wonderful opportunity to learn, interact, and grow together. With these inspiring words, let us begin today's academic journey. It is now my honor to invite today's CME Organizing Chairperson, Senior Consultant Nephrologist at Kamalnayan Bajaj Hospital, Chhatrapati Sambhajinagar, Dr. Samir Mahajan Sir, to kindly come on stage and deliver the welcome address for today's CME program.
Hello, good morning everyone. Welcome everyone, all respected physicians, intensivists and nephrologists gathered here to this conference which is dedicated for renal replacement therapy, particularly conventional as well as modern extracorporeal therapies. And I would like to begin the session, scientific sessions, without wasting much time. So welcome everyone, and let's start the scientific session.
Thank you, sir, for your valuable information. It is now my great pleasure to invite our esteemed faculty speaker, Consultant Nephrologist at Kamalnayan Bajaj Hospital, Chhatrapati Sambhajinagar, Dr. Nikhil Ingre sir. Please come on stage to deliver our first academic session of the CME topic, Expanded Hemodialysis. May I also request respected chairpersons for the session, Dr. Yogesh Devgirikar sir, Senior Physician and Intensivist, Oregon City Care Hospital, Chhatrapati Sambhajinagar, Dr. Pankaj Gote sir, Consultant Nephrologist at Shakuntala Hospital from Washim, and Consultant Nephrologist at Sanjeevani Hospital from Jalna, Dr. Shalik Zadhav sir. May I all requested to all of you, please grace the dais. Ladies and gentlemen, please welcome our faculty speaker and chairperson with a warm round of applause.
Hello and good morning everyone. I am Dr. Nikhil, Consultant Nephrologist at Kamalnayan Bajaj Hospital. So let's begin this academic feast. For the first topic we have something very interesting and very advanced, that is expanded hemodialysis. So as in a study in 2020 we saw that approximately 210,000 patients become end-stage renal disease every year in India. And approximately 94% of those patients rely completely on hemodialysis as the renal replacement therapy. But this renal replacement therapy, that is the low flux dialysis, comes along with many problems like incomplete uremic clearance, bioincompatibility, hemodynamic instability, and persistent metabolic abnormalities. What happens because of this is it creates a chronic inflammatory state which leads to increased morbidity and mortality amongst these patients. So what exactly causes this increased morbidity and mortality? For this, we need to understand the unfolds, and we have to unfold the story of uremia. So basically, uremia is caused because of certain toxins, which are grossly divided into three parts: the small molecules, the middle, and the large molecules. What we usually test and identify are the small molecules, which are actually not of very prime importance when it comes to uremic problems. It is mainly the middle and the large molecules that cause the systemic inflammation, the cardiovascular complications, and amyloidosis-like complications in patients with CKD. So from low flux dialysis, there has always been an ever-growing research to find certain dialyzers that can help us clearing these middle molecules. So where we come now here is to a point where we have two main types of dialyzers: the high flux dialyzers and the medium cutoff dialyzers. So what extra these dialyzers do is they add convection to the primitive diffusion method that is used in the low flux dialysis for convective clearance. And that is how it brings us a step closer to the native kidney clearance. So to understand these two dialyzers, the high flux dialyzers and the medium cutoff dialyzers, and how are they different, we should understand the sieving coefficient curve. So for this, we need to know what are the certain terminologies like the sieving coefficient, which basically means the permeability of the membrane. Second terminology that we should know is the molecular weight retention onset, which is the molecular weight basically at which 90% of the molecule will be filtered, but 10% will be retained back. And the molecular weight cutoff, the MWCO, at which 90% would be retained and only 10% will be filtered. So if we see this curve, the high flux dialyzer curves, when it comes to the range of the middle molecules, we see a steep fall in the permeability of the membrane, which means that the middle molecular clearance will not be that good. If we see the curve of the medium cutoff dialyzers, what we see is the curve is quite plateauing in the middle molecular range, and so that is why if there will be a more effective clearance of the middle molecules using this dialyzer. However, if we see albumin, which is a very important parameter for the longevity of our patients with CKD, both the dialyzers are efficacious enough to preserve the filtration of this albumin. So what makes the medium cutoff dialyzer so special? So there are certain characteristics of this medium cutoff dialyzer that makes it so special. So it has a special fiber geometry, it has certain special internal fluid dynamics, and they have a reduced inner diameter. What happens because of this is the fiber, basically the dialyzer is divided into two parts. The initial half of the dialyzer acts as the filtration part, and the latter half of the dialyzer will, because of the convective forces, will help us in the back filtration. I'll tell you what is the importance in the coming slides. So if we compare the conventional hemodialysis with online hemodiafiltration with this new type of dialysis, that is the expanded dialysis, we see that the online hemodiafiltration and the expanded hemodialysis use the method of diffusion and convection for their clearance, and they are both excellent modalities for middle molecular clearance as well. However, if we see the setup, the online hemodiafiltration is a kind of a complex setup to create in a particular institute, whereas the expanded hemodialysis is quite simple, and it could be easily set up in a rural areas also. So as I said, the expanded hemodialysis is very easy to set up, so it does not require any technical backup. It can be used on a standard 4008S machines also, and it does not require any replacement fluid, which is main problem that is seen with the online hemodiafiltration. So what we require for starting an expanded hemodialysis is basically the standard hardware that is needed for the standard hemodialysis. We require water purity which is as good as the standard hemodialysis. We don't require ultra pure water for performing expanded hemodialysis. What two major requirements for this performing expanded hemodialysis are a good vascular access. The patient should have a vascular access which could be in the form of AV fistula or an AV graft with a flow of more than 300 ml per minute. Second important requirement will be the economic burden that this expanded hemodialysis will incur on the system. Because if you see the traditional high flux dialyzer, it will cost around 700 rupees for the patient to buy it from a shop, pharmacy, whereas this dialyzer will cost them 2800. But if we compare where we are comparing online hemodiafiltration and expanded hemodialysis, to create a whole setup of online hemodiafiltration, the cost required for that will be comparative to that required for expanded hemodialysis. So which are the patients whom we need to select for the considering expanded hemodialysis? So firstly, patients will be those who are having a long dialysis vintage, who have been on dialysis for approximately 5 to 6 years with no residual renal function remaining. They are the patients who can be prioritized for expanded hemodialysis. Other patients could be those patients with multiple comorbidities and those patients with persistent hyperphosphatemia, despite giving phosphate binders. Also, we can do this for restless leg syndrome, which is a rare complication that we see in CKD patients, and to help patients prevent from amyloidosis. So, after seeing the theoretical and the practical points, we also need to back it up with certain clinical evidence also. So, there was a randomized control trial that was done in the US in 2020, which was done across 21 centers, and they enrolled 172 patients for the trial. They divided these patients into two basic groups, the medium cutoff dialyzer group, that is the Theranova 400, and the Eliseo 17H, which was the high flux dialyzer. What they did is, they gave a therapy of 24 weeks and they followed up the patient after that period. The cohorts were quite well matched. That was the mean age for the patients in either of the group was 59 years, with diabetic status, diabetic being the cause of CKD in 60% of them, and mean dialysis vintage was approximately 5 years, and 80% of these patients had either AV fistula or AV graft as the primary axis. So efficacy and safety analysis was done for the expanded hemodialysis in this trial. The efficacy analysis of the trial was done on the basis of the lambda free light chains, and the safety analysis was done by assessing the change in the albumin after a period of 24 weeks. So what they found in the study was that the expanded hemodialysis provides a quite high efficacy as compared to the normal high flux dialysis. And as we can see, there was almost twice more reduction percentage of the lambda free light chains, which is a very important parameter that can lead to multiple complications in CKD patients. Secondly, when we see the safety outcomes, they were seeing the change in the mean albumin value after a period of 24 weeks. So it was found that whether you use high flux hemodialysis or whether you use medium cutoff dialysis, there was no significant difference in the change of albumin at the end of 24 weeks. So this means that the expanded hemodialysis or the medium cutoff dialyzer was more efficacious as compared to the high flux dialysis, causing no extra complications or no other side effects. This is the visual abstract of the same study. 86 patients were enrolled in either of the groups with thrice per week hemodialysis for a duration of 24 weeks. And it was seen significant reduction in the lambda free light chain reduction, and there was no significant change in the serum albumin. So after seeing how these dialyzers or these expanded hemodialysis is affecting practically, now we also need to consider whether it's significantly improving the quality of life of these patients. So for that, another study was performed at Canada, which was a single center trial and which enrolled 28 patients. And what they did was, initial 2 weeks, they gave high flux hemodialysis for all the patients. And then later on, for 12 weeks, they shifted them to expanded hemodialysis. What they used in this study was a very unique type of, what we can say, measurement criteria. That was the PROM level score. So what they did initially, before starting the patients on expanded hemodialysis, they calculated this PROM level score. And the patients who had a PROM level score less than 70 were enrolled in the trial. This score is basically used to analyze the quality of life in these patients. So the PROM level score was seen, and the patients were subjected to expanded hemodialysis. And at the end of 12 weeks, what was found that the overall quality of life, the general well-being of the patient, the energy levels, as well as sleep, they significantly improved in patients who were undergoing expanded hemodialysis as compared to those who were undergoing high flux dialysis even for 2 weeks. So now, after comparing it with the inferior modality of treatment, that is the high flux dialysis, the medium cutoff dialyzer, as we saw, is at par with the online hemodiafiltration. So we need to have certain comparative studies that are comparing the online hemodiafiltration with expanded hemodialysis. So this was a study that was conducted in Thailand in 2025. And it basically, what it again did was, they included 40 patients and they randomized these patients into two groups, the online hemodiafiltration and the expanded hemodialysis group. Initial 2 weeks again were the patients were treated with high flux dialysis and were again subjected to the two modalities of therapy that were randomized. So even in the expanded hemodialysis group, there was no one medium cutoff dialyzer that they used. In fact, in the trial of expanded hemodialysis, they used two types of medium cutoff dialyzers, the Theranova 500 and the Eliseo HX21. So if you see the basic clinical data of this patient, the mean age of the patient that were included in the trial was around 65 years with male predominance of 82.5%. Most of the patients, as in every study, were diabetic nephropathy, and the mean duration of dialysis vintage was approximately 5 years. And what we saw was, what they analyzed was per session clearance and a total clearance at the end of 8 weeks. So if when they analyzed the per session data, it was seen that the important middle molecules, that is the beta-2 macroglobulins and the free light chains, they significantly reduced per session with the use of online hemodiafiltration. And even the parathormone levels, they significantly reduced per session when we used online hemodiafiltration. So what it was basically showing that online hemodiafiltration was better as compared to expanded hemodialysis for that session per se. Even when they compared the two types of the medium cutoff dialyzers, there was no significant difference between them. All the parameters that were assessed were equally cleared in Theranova 500 as compared to Eliseo H21. However, the paradox is that when they analyzed the data of this study after a period of 8 weeks, what they found is that both online hemodiafiltration and the expanded hemodialysis will have a clearance which was equal to that of the pre-dialysis levels, which means it was not significant. Though per session was significant, but over a period of time, there was no significant difference. So why this happened? The probable explanation was that when online hemodiafiltration clears the middle molecules from the blood, what happens is there is rebound transfer of the molecules from the tissues to the blood, which again increase the values to where it were before. The safety of these two modalities of treatment was analyzed by using the intradialytic hypotension and the albumin loss. It was found that intradialytic hypotension was more common in expanded hemodialysis, whereas albumin loss was more common in the patients who are undergoing online hemodiafiltration. However, it was not statistically different. So the clinical takeaway points from this study would definitely be that in a high resource center where all the facilities could be easily available with good financial backup, the online hemodiafiltration could be the preferred modality of treatment. However, if we consider the rural areas with standard hemodialysis setup with no financial backup, expanded hemodialysis could be a modality of treatment that could definitely help patients in clearing those middle molecules. So there are certain benefits and certain limitations. As we already saw, expanded hemodialysis is going to give us a better, larger molecular clearance without causing albumin the filtration. It also improves the quality of life with zero specialized machines or technical setup that is required. However, there are certain limitations. That is, first is the cost that we already discussed, and the need for good vascular access. Secondly, the thing is that we don't have a good backup evidence that can prove over a long period that expanded hemodialysis is really good modality of treatment. So this is definitely the next standard of care where expanded hemodialysis is comparing the HDF level of physiological clearance, that too is providing in a standard hemodialysis setup. So my key take-home points would be that this is basically we are going closer to the native kidney clearance by adding convection to the diffusion method for clearance. And this convection that is there in the expanded hemodialysis does not require extrinsic substitution fluid. It can be done in a standard setup, and it has been backed by some evidence, not very good evidence, but it has some evidential backup. And the ideal candidate, there are definitely many ideal candidates that we can search around us. Thank you.
Nice talk, and you delivered it very well. I just wanted to ask you, as you said, the limitations of this are like it has not been extensively used. Are we aware of any other trials going on right now using this technology? in any big trial or RCTs going on, so that we can expect the results by timeline some 6 months, 8 months down the line?
So at present there are no such ongoing trials with multicentric trials that are going on, but this trial that I last pointed, that was the trial that was conducted in Thailand. Actually the problem is that the number of patients are not very high and the follow-up was also not very long. So we need that kind of studies where large number of patients are recruited and a larger duration of study is required to get a financial, evidential backup for this using this modality of treatment. However, I would say that I've personally, when I was at AIMS, we have used this this dialyzer on a patient, and we monitored the beta-2 microglobulin levels pre-using this expanded hemodialysis and after using it. Definitely the pre-usage and the post-usage beta-2 microglobulins were significantly lowered by using expanded hemodialysis. So we can consider this for patients who don't have any economic issues, because it does not require any extra setup. Only thing that is curtailing us from using this modality would be the financials that it incurs while using this modality.
I think you pointed out that the initial cost was high, right?
Yes, sir,
so
definitely.
Recurrent cost may be on a lower side.
Recurrent costs, sir, problem with this dialyzer is again that even the standard that has been laid down it says that we can use this dialyzer only once. So for each session of dialysis, the patient will have to pay 2,800 just for the dialyzer, and additionally the cost of the machines and everything. So that will cost around 5,000 for the per session for these patients. So that is the only problem. But if the patient can pay, definitely a good modality of treatment.
There is no comparison between the complications actually, conventional hemodialysis and dialysis with the
Expanded hemodialysis.
Yeah. So are there any comparison? The intradialytic hypotension, hypoglycemia is lesser in, or there is a similar?
So in the study that was done in 2020 in the US, which RCT that I had discussed, basically they had seen all the complication parameters, and there were no significant difference actually. Differences were not statistically significant, though complications can occur in either modalities of treatment.
Thank you. First of all, thank you to Dr. Sameer Mahajan sir and organizing committee of Bajaj Hospital for giving us opportunity to chair this session. Thank you, Dr. Nikhil, for giving such an excellent and comprehensive talk. My question is how this expanded hemodialysis is covered under Yojana or not, and what about anticoagulation? It is the same anticoagulation we are using for expanded hemodialysis.
That is actually a great question. Considering the Indian setup and the Yojana parameters that we have to consider while providing hemodialysis, this actually will not be covered under, because the amount of money that we get from Yojana is quite suboptimal if we consider this using this dialyzer also. So that was the first part, and secondly, coming to the anticoagulation that needs to be given for these patients is as same as that of standard hemodialysis. So nothing different as compared to standard hemodialysis, only the filter. The magic lies within the filter and it does not lie within the setup.
Open for questions.
Definitely, sir, because all the problems that happen in the patients with end-stage kidney disease are because of the middle molecules. And with the use of the traditional dialysis that we have, low-flux dialysis, this middle molecular clearance is very low. For that, better modalities of treatment would be expanded hemodialysis and the online hemodiafiltration. Both modalities are equally good. But again, as I said, this does not require any extra setup. So expanded hemodialysis with a good middle molecular clearance is definitely going to extend or increase the longevity of the life of the patients with end-stage kidney disease.
Do we have this facility of the Bajaj?
Sir?
Do we have this facility of
No, sir, no. We need to get these dialyzers. Then we can use it at Bajaj also. We can use it anywhere. We just have to buy those dialyzers. Sir, one dialyzer would cost approximately 2,800 for the patient.
questions? So we close the session here. Thank you.
Thank you. Thank you.
Thank you, sir, for your inspiring words and valuable insights. May I now request our respected chairpersons to felicitate our speaker, Dr. Nikhil Ingre, sir. May I now request Dr. Samir Mahajan, sir, to kindly felicitate chairpersons for this session. Thank you, sir. Due to some circumstances, our next session speaker could not make the conference. Now, we are forwarding to our next scientific session, home hemodialysis. It is my pleasure to introduce our speaker for the session, Dr. Shrikant Deshmukh, sir, consultant nephrologist at Aster DM Sigma Hospital, Chhatrapati, Sambhajinagar. May I also request respected chairpersons for this session, Dr. Ranjana Deshmukh, madam, President of Physician Association, Chhatrapati, Sambhajinagar, and Senior Physician at Hedgewar Hospital, Chhatrapati, Sambhajinagar. Dr. Ajit Ghodke, sir, consultant nephrologist at Medicare Hospital from Bid, and senior physician at Icon Hospital, Chhatrapati, Sambhajinagar, Dr. Arif Hussain, sir. May I request to all of you, please grace the dais.
Hello. Good morning to everyone. Now Dr. Nikhil has told about the expanded dialysis, but there are some patients, those don't want to come to the hospital. So for them now this session is around home hemodialysis. So we can do home hemodialysis also. This is very neglected part of nephrology we want to cover in this session. So as we know, the chronic kidney disease advances, the stage 5 arises, we have to give option of renal replacement therapy either in the form of dialysis, hemodialysis, peritoneal dialysis or renal transplantation. So global burden of this hemodialysis is around 2 million people are doing dialysis, and home hemodialysis doing people is around only 2 to 3%. While in India it is more than 2 lakh people are doing dialysis, but the home hemodialysis population is around only less than 1%, because there are many circumstances, the financial burden and all these things, even the Yojana is also lacking. Because of that we are not promoting the home hemodialysis. So in dialysis, where two types are there. In center hemodialysis, where patient goes to the center, they used to do a dialysis for 3 times a week, 3 to 4 hours a session. And in case of home hemodialysis, they can do their dialysis at their own, as per their timings. So, but why one should choose a home hemodialysis? Because in case of home hemodialysis, the patient and autonomy is preserved. So they can do their own work, homework or work from home also they can do. If the children are there, they can go for schooling and all their regular work can be done. In case the better outcome in the form of there is a solute clearance is improved and tighter fluid control. The quality of life is improved because you have a lot of time, and cardiovascular benefit in the form of low blood pressure variability and reduced cardiovascular events or stress. So what is home hemodialysis? Actually, it is doing dialysis at your own home, and the sessions are more frequent, shorter, and treatment may mimic the natural kidney functions. So there are 3 customizable options in doing home hemodialysis, where we can do like in-center hemodialysis 3 times a week, 3 to 4 hour sessions, or you can do a short daily dialysis where 5 to 7 times a week, 2 hours per session you used to do. And another one is a nocturnal hemodialysis where you do a dialysis 3 to 6 times per week, 6 to 8 hours during sleep times. It is a slower but more thorough cleaning occurs. So these are the modalities divided into 3 parts, that is conventional, short dialysis, short daily dialysis, and nocturnal. So what are the benefits of home hemodialysis? From the patient's perspective, if you go, there is a flexibility and independence in the daily life, the improved quality of life and work capacity, better KT/V and blood pressure control. From the clinician point of view, real-time patient data and remote monitoring can be possible, proactive interventions can be done, and reduce emergency complication of these patients. So health system benefits, this is lower per patient treatment cost, but this is true for the developed countries, but this is not true for this developing country. Reduce hospitalization rate and scalable model for resource limited sources. So who can do, or inclusion or exclusion criteria for doing a home hemodialysis? The ideal candidates are motivated, cognitive intact patients. Those who are motivated from, they want to do at home only, they can do. Then adequate home infrastructure should be there. There is a space required, water treatment is required, and electricity also required. So there is reliable vascular access should be there, and supportive family caregiver network should be there, and stable clinical condition of patient should be there. These are the parameters from the socio-economic point of view, but who can do a home hemodialysis from biochemical point of view? The patient is stable and mobile as assessed by the treating nephrologist. He should not have any episode of pulmonary edema in the resting condition or with minimal exertion. Patient should, hemoglobin should be more than 8, or his potassium should not be more than 6 milliequivalent per liter for last 2 out of 3 months. These patients can be taken for home hemodialysis. So what are the clinical or lifestyle benefits? As in clinical outcomes, there are many studies shows that there is a reduction in the blood pressure, that is, which one is 140/90 in center dialysis. The blood pressure at home is around 120/80. The appetite has improved. You have a schedule control. You can do your homework, family and hobbies can be preserved. Then as you doing dialysis at your own home, you get a comfort also. So there is a increase in 35% energy when you do a home hemodialysis, plus 30% improvement in the sleep, 15% improvement in the water use, that is intake of water can be increased, and 25% reduction in the hospitalization. So if some patient comes to you and asks for a home hemodialysis, then he has to go for a workflow format. First, initially he has to assess by the nephrologist. Then we should do a company person will do a home assessment whether it is possible to do a home hemodialysis or not. Then vascular access should be created. Then formal training of the patient and caregiver is given, and then home setup is ready. These are the stage. First stage, patient comes to you when we should counsel the patient at stage 3, 4 or 5. Actually, we should counsel at the stage 3 or 4 only, so that they can create a AV fistula. That will maturation take will around 8 to 12 weeks, so that he can at stage 5 he should have a AV fistula created, and then he can go for dialysis. Secondly, home evaluation for the infrastructure management should be done. Then intensive training. The patient and caregiver are given 4 to 8 weeks of in-center intensive training regarding cannulation, machine operation, water and equipment setups. Then supervise in-center sessions. Some first few sessions are done in the in-center under the supervision of nurse or technicians. And then at home you can do at this setup, and with connection with the with consultant nephrologist or with the technician, you can do a home hemodialysis. So what home infrastructure is required? First one is the physical space. Around one room with 100 square feet is required. Separate area for RO plant and equipment storage is required. Utilities like water is required. More than 1,000 liters per session is required. So you have to install a RO purification plant also. Electricity and drainage system should be established. And safety and comfort, proper ventilation and temperature is must required. Emergency communication system should be there, and comfortable sitting and adequate lighting should be there. Regarding the machines, all we know that dialyzer is required. Most important thing is the dialyzer solutions, type A and type B solutions, where the B solution we have to prepare on their own. So that solution has to be prepared with prior to your dialysis session. Vascular access, you should have AV fistula is preferred in these cases, but if there is not, then we can do a AV graft also, and catheter like permanent catheter placement we can do. Vascular access or fistula care cannulation, that in intensive care treatment part, we teach this caregiver and the patient regarding the regular assessment of thrill and brew, avoid BP cuffs and venipuncture on the fistula arm, and monitor the infection or stenosis or aneurysm can be taught to this caregiver as well as the patients. So in India, it is very difficult to do a home hemodialysis because there are a lot of infrastructure problems are there. Plus, there is a socio-economical problems also there, and the policy is not supporting even to the peritoneal dialysis also. But this is difficult. But some patients are doing home hemodialysis. So there are challenges and the solutions for the home adoption of home HD adoption, like infrastructure challenges. We can do a solar powered RO system, water storage tank can be done, and community based centers can be made. In case of affordability, government subsidies can include these home HD also, or insurance coverage should be there. Training and awareness, the structured training program should be there for all type of these patients. Digital education modules can be provided with these patients. Future direction or innovations in home hemodialysis. We are listening this, there is a wearable dialysis device can be in the future, but since 2015 we are knowing this, but this is in the primitive stage only, and it will take more time, or sometimes we are going ahead with that xenotransplantation with the pig kidney we are doing. That is the future in advance we can do. Or in case of AI powered monitoring can be done. All these patients can be connected with the AI, so that the AI system will tell that this patient has some problem with the machine or with any system or TMP is high. Like that only we can control these patients. Automated water system can be established. Telemedicine integration and regenerative medicine can be provided. So what is evidence? There are many clinical trials and regarding this, with the cost effectiveness also mentioned. This Freedom trial in 2016 showed that there is improved survival and quality of life. The Choice study showed that there is a lower mortality and hospitalization rates. Meta-analysis shows that there is a superior phosphorus and blood pressure control. While in cost effectiveness, there is a 20 to 30% reduction in the annual per patient cost, and wearable device and this AI assisted monitoring can continue to improve the patient's outcome. So this is the most important. If someone wants establish a dialysis unit, so in-center dialysis, that is, it includes everything. The cost of traveling and all this thing is around 4.7 to 7.8 lakhs. Home SD setup required around 8 to 12 lakhs. Home HD operation requires 2 to 3 lakhs. The break-even point is around 18 to 24 months. If you go on long term or 5 or 7 years, the 40 to 50% cost saving can be done. So quality indicators and audit dashboard, whether you are doing a proper dialysis or not, there are some quality indicators like KT/V, phosphorus control, blood pressure targets like BP, pre-dialysis BP should be less than 140/90, hemoglobin level should be 10 to 12, vascular access survival can be monitored, hospitalization rate, lower incidence of hospitalization should be there, and patient satisfaction is the most important. There are many complications in doing home hemodialysis, but in intensive care treatment part, we advise these common complications like hypotension, muscle cramps, vascular access clotting, or infection at access site. These can be taught prior to the going for home hemodialysis. So remote monitoring and telemedicine, as I told you, real-time data can be transferred to the center. From there, they can do any requirement like any interventions can be done from there also, or any automated alerts can be set for the any machine alarms or any blood pressure drop that can be sent to the center or directly to the consultant, or virtual consultation like video call can be done with the patient and technician. So take home message is that if you do a right patient selection, right training, right support, then successful home hemodialysis can be possible. These are the nearby home hemodialysis patients, their setup and doing dialysis. Thank you.
Thank you, Dr. Sir, Shrikant Deshmukh, for your lucid presentation. Considering this topic is not new, but now it becomes, we think it becomes very difficult, but the day will come when patient will prefer home dialysis because that will be the need of the hour. So looking to the first time home dialysis, म्हणजे मला असं वाटलं की इन्सुलिन देण्यासाठीच तर इतकं आपल्याला त्रास घ्यावा लागला टू कन्व्हिन्स द पेशंट. सो नाव दिस इज द स्टेप अहेड, पण स्टील वी कॅन होप की patient will prefer home dialysis considering its advantages. Patient training and patient's relatives training is very important in this situation, and that will be the again second, म्हणजे तो पार्ट एक राहील आपल्यासाठी की पहिले ट्रेनिंग त्यांचं करायचं. They should be mentally prepared for everything, and then we'll have a home dialysis option. But it's a very good option for the patients because doing hemodialysis at home is very comfortable than going to the hospital and remain in the queue, number kadi lagel. So it's a very good option. Thank you for your presentation, sir.
Sorry? Machine can be supplied by there are two options. Directly you can purchase it or you can lease also. The cost of purchase is around 7 to 8 lakhs, and if you go for leasing, there are different options for there.
That's good.
They ask for a fixed deposit of around 3 lakh rupees, and they need a minimum guarantee of around 6 months of hemodialysis. So basically the investment is done on the part of Apex Feeding here, and the system is running very successfully in Mumbai itself. So all over rest of Maharashtra, due to cost issues, there are some issues, but once it will be affordable, I guess once the facility, once the nephrology services are available in interiors,
Shrikant.
Yes. Yes.
Hello.
Yes.
Hello. Dr. Shrikant.
Yeah.
Ikde. This side.
Can I just ask you one thing?
Yes.
Yes. Please, sir.
You have mentioned that the blood pressure control is good at home compared to the hospitals.
Hospital, yes.
What are the reasons?
First thing is that you are doing dialysis at home, so there is a comfortness is there. Secondly, the home dialysis is frequent. That's why the fluid removal is constant and frequent. That is the reason they mentioned that the blood pressure is better controlled at home.
Okay. Is it the white coat or mask effect is there?
Yeah,
something?
that is there. One comfortness at home is because of that only. If you patient goes to the clinic, definitely his BP is high. But when he is at home, it's at a baseline level.
Or is it the stress factors and the cortisol release and something like that, the oxidative stress which is already going on in these patients?
You are doing a frequent sessions of dialysis. That will reduce the fluid in the body. And that is causing your blood pressure is to control.
Okay, fine. Thank you. Any questions?
Yes, sir.
Just I want to ask you, is there any real world data regarding the adverse events at home dialysis? How much percentage, because whatever in-center dialysis we are doing, we do have adverse events in-center also. So is there any real world data available with this, either from India or from outside?
The data is like, those who are doing as a home hemodialysis, their 6 months or 1 year data is there. Hardly a patient do 1 year dialysis, afterward they will transfer to the center because of the complications they develop. First thing, if you ask as a percentage wise data, the various companies are there like NephroPlus or Fresenius. They are doing home hemodialysis. Their data suggests that the dropout rate is around 25%, which is around 8 to 10% in case of in-center. It is around 25%.
Thank you.
Yes, thank you.
Thank you, Shrikant.
Thank you.
Thank you, sir, for your valuable insights. May I now request our respected chairpersons to felicitate our speaker, Dr. Shrikant Deshmukh, sir. Ajay Rote sir to kindly felicitate chairpersons for the session. We are forwarding to our next CME session, Real World Experiences from Indian ICU. It is my pleasure to introduce our speaker for the session, Dr. Neeraj Inamdar sir, consultant nephrologist at Hedgewar Hospital, Chhatrapati, Sambhajinagar. May I also request respected chairpersons for the session, Dr. Atul Hanuante sir, consultant nephrologist at Mahavir Hospital, Chhatrapati, Sambhajinagar. Dr. Anant Kulkarni sir, senior physician and intensivist at Mahavir Hospital, Chhatrapati, Sambhajinagar, and senior physician intensivist at MGM Hospital, Chhatrapati, Sambhajinagar.
May I request Dr. Nikalji sir to chair the session, please?
Sorry for a small interruption. I would like to invite Dr. Sharat Kondekar and I would like to invite Dr. Ajay Rote to felicitate Dr. Sharat Kondekar, who has come as a MMC observer for today's CME conference, and for some personal reasons he has to leave immediately, so we'll just interrupt the session for a minute. I request Dr. Neeraj to start with this session.
Good afternoon, everyone. With the permission of chair. Yes. Yeah. So my topic is to talk about what we call maybe iPhone Pro, when everybody has iPhone and everybody has iPhone Pro Max also. So I will be talking about SLED and on the background of hemodialysis and continuous kidney replacement therapy. So it's a pragmatic modality. Pragmatic means it's a real world modality for hemodynamically unstable patients and less likely to be a chronic maintenance hemodialysis patients. So more or less ICU patients, acute kidney injury patients who are hemodynamically unstable. So I did not receive any honorarium from Baxter or Ventive, so I am not bothered about any CKRT or HD or high flux dialysis. So coming on to the outline, understanding the physiology and practical basis for SLED, that is low efficiency dialysis. We have the other name for SLED also, as we have for Sambhajinagar also, that is prolonged intermittent renal replacement therapy. So the terminology might differ, but the concept is same. We have to compare SLED with IHD and CRRT, since our whole life revolves around comparison. We have to identify patients who are appropriate for SLED, interpret the real world evidence on mortality, hemodynamic stability and renal recovery in comparison with the modalities available, prescribe and monitor SLED safely in ICU, what we can do to better the outcome of the patients, and recognize situations where SLED has its own limitations. So coming on to the topics, we will divide it into who received SLED, why it was selected, how it was delivered, problems encountered, and what happens to planes. So you might think these are the common indications for dialysis. And the boldest letter in this slide is indication. We must be knowing why we are doing dialysis. We want to remove the potassium. We want to remove fluid without sodium correction. We want to remove the uremic products. We want to remove the ammonia. We want to control the intracranial tension. We want to remove the fluid, or we want to bring the output. So most important thing is indication, and none of these four things are absolutely indicated for hemodialysis. So decreased urine output is not an indication for dialysis. First thing, we have to hydrate the patient, assess fluid assessment, and non-responsive patients will proceed to dialysis. Not just metabolic acidosis. It is the refractory metabolic acidosis. Predominantly non-lactic metabolic acidosis will respond to renal replacement therapy. Encephalopathy, just because patient is having encephalopathy does not put patient for dialysis, because altered sensorium per se is not indication, and we have to establish the etiology of altered sensorium. Just because urea is 64 or 120, creatinine is 3.5, you plan for hemodialysis because patient is altered, may not be a justifiable thing. And in case of ascites, heart failure, these are the other indications also which are many a times diuretic responsive, may not require renal replacement therapy. And we end up losing the patients or getting suboptimal outcomes when we choose a wrong indication for renal replacement therapy. So indication is extremely important. And what armamentarium we have with us is, don't forget, we have peritoneal dialysis, we have hemodifiltration, as Dr. Ingre has already been discussed, we have CKRT or what is known as CRRT, we have intermittent hemodialysis, and I will be speaking on SLED. So we have to choose which modality to select based on the indication for what we are doing a replacement therapy. So coming on to the SLED, it is usually performed in a patients who are hemodynamically unstable, whose fluid overload must be corrected without worsening shock. Conventional hemodialysis may be poorly tolerated, most commonly due to hypotension or any other symptoms such as anginal chest pains, profuse sweating, or backache sometimes. CRRT may be interrupted for procedures. We have to shift the procedure for endoscopy, for DJ stenting, for imaging, for many a times circuit clotting, and we have to able to remove the water without sodium slowly, or we have to correct the sodium without water. So SLED offers a practical middle path for an hemodynamically unstable patients. So why we are using SLED? Particularly for hypotension during conventional dialysis, we are getting more and more number of patients who are having septic acute kidney injuries, whom the hemodynamic constantly changes. We need a slower ultrafiltration modality. We cannot be removing 5 liters of fluid in 2, 3 or 4 hours. There are high CRRT consumable costs which are pragmatically high. We need to use the same machine for more than one patients. We have very limited machines and large number of patients who required renal replacement therapy. And we need for dialysis that could be paused, as we have discussed previously, for multiple interventions also. So usual indications include sepsis associated AKI, for cardiorenal syndromes till the patient comes out failure, hyperkalemia. So hyperkalemia is a tricky mode where we have to rapidly correct the potassium, reverse the complete heart block, or for that matter other ECG changes, for which sometimes putting TPI may not be justified, but doing an urgent dialysis is justified. For transitioning from CRRT when the patient recovers, particularly patients who are on vasopressor support without worsening the vasopressor requirement, diuretic resistant fluid overload, the indication has to be very clear. Patients intolerant to conventional hemodialysis, and there are many reasons. Some patients usually get chest pain after 3 hours, some patients get profuse sweating, some patients start complaining of severe cramps on dialysis, and those patients might benefit because of low efficiency dialysis, acute pulmonary edemas, severe metabolic acidosis, and post-op AKIs. So SLED can be performed in an unstable but not deteriorating rapidly. That means your inotropic requirement is not worsening rapidly. I mean, if it is worsening rapidly, we have to move on to the CRRT. Vasopressor requirement is stable or slowly decreasing with your conservative management. The acute tubular necrosis is established. Now the BP is built up, and now you can perform safely SLED. Gradual fluid removal is required when sudden removal of fluid, particularly in cardiorenal syndrome, may not be justified. Conventional HD is not tolerated, we have repeated this, and CRRT is unavailable, or transitioning from CRRT is necessary. So usually it is performed as 6 to 12 hours. Majority of the centers perform it for 8 hours. Solute clearance is intermediate. Hemodynamic tolerance is better than CRRT, better than IHD, less than CRRT. Fluid removal is gradual and controlled. Anticoagulation can be used, can be discontinued. It is a low performed on normal dialysis machine. It is free of any procedures. and nursing workload is moderate, as we can use the same staff, same machine for multiple reasons also. Whether it can be performed on vasopressor, it has to be predominantly performed on vasopressor patients only. When the dose is stable, MAP is acceptable. You have done the initial hemodynamic correction. There is no rapid dose escalation, and you have to do it dynamically. It is an ongoing procedure, and one has to always keep vigilant on the changing parameters. When the lactate is stable and improving, which is an important marker, and there is no strong indication for dialysis. Dialysis means uremic encephalopathy. Well, uremia clearance is extremely important. Uremic pericarditis, where correction of uremia is more important. In such things, SLED might have its own limitation because uremia clearance may not be optimal. We have to be cautious when vasopressors is rapidly increasing, when ongoing severe arrhythmias are present, active bleeding is ongoing, there is evidence of worsening shock, and we will come in the last slide. Profound hypovolemia has not been corrected prior to the dialysis. So just because creatinine 8 does not mandate the initiation of dialysis, trying to achieve the hemodynamic stability prior to procedure is also an equally important. The most common complication we encounter is intradialytic hypotension, and that can be temporarily managed with stopping the ultrafiltrate, lowering the blood flow rates. We can go as low as 150. Extend the treatment duration 5, 6, 8, 12 hours. Give small fluid boluses when clinically appropriate. Adjust the vasopressors. Reassess whether the patient is intravascularly depleted. This is an extremely important step. And we have many clinical, biochemical and assessment tools to overcome this difficulty. Review the ongoing sedatives and vasodilators. Many a times residents forgot to stop the antihypertensives, and we keep on facing the problem of hypotension. Use cooler dialysate when appropriate, and all these functions are available in the machine, and stop the treatment when hypotension persists despite correction. So timely dynamic actions are extremely important. Majority of the times ICU, we do it without anticoagulation, particularly patients having thrombocytopenia, post-op patients and coagulopathy, and it's generally not a problem in SLED because even without saline flushes, the results are good. So practical measures are, first thing is a good vascular access. We have to secure a good vascular access. In obese patients, somebody having femoral catheter may not be able to give a good flow. Somebody with left internal jugular vein catheter may not be able to achieve a good flow, and even after the end of dialysis, the patient ends up with hyperkalemia or hyponatremia, which is supposed to be cleared by dialysis. We have to achieve the adequate flow rate, which can be possible with good vascular access. We have to ensure the saline flushes so that the patients may not go in hypotension also and circuit doesn't get clot, because that's the most common thing which can reduce the efficiency of dialysis. We have to avoid the repeated interruptions. This is more or less for CRRT, and we have to observe the circuit pressures, that is venous pressure and arterial pressures, and overcome the problem of access if they develop during the dialysis. Coming on to the drug dosing, SLED can remove clinically important quantities of drugs. We have to adjust the dose like the aminoglycosides before and majority of the drugs after dialysis. Removal depends on the session duration, blood and dialysate flow, membrane and residual function. And we have vast variety of the membranes available to perform the SLED. Drug doses may need to be given after SLED. Therapeutic drug monitoring, which is underutilized entity in our part of the world, has to be utilized for particularly antimicrobials. And ICU, nephrology and infectious disease teams must communicate. This is most cost-effective thing, that one has to communicate with each other for the ongoing process. So our usual prescription involves 6 to 12 hours. Blood flow is around 180 ml per minute. Machine, we usually use 5008 for dialysis. We perform it daily initially, followed by alternate day. Ultrafiltration, depending on the indication. Based on potassium, it can be 2K or 4K. We avoid potassium-free bath. Anticoagulation, depending on clinical situation, we can perform it during daytime and nighttime because the staff requirement is not very high, and it can be safely performed overnight also. ICU nurse plus dialysis technician is a best combination one can go ahead with SLED, that the dialysis can be initiated by a technician and can be continued by a trained ICU nurse. We should be knowing the limitations also. Whenever the rapidly escalating vasopressor support is required, it is better to discontinue the SLED. When the vascular access is not good, we may not be able to achieve the desired results. When the patient is having severe agitation, foremost thing is to stabilize the patient, intubate the patient, and then plan for vascular access. Otherwise, many a times catheter can be thrown out, fistulas can rupture during the ongoing dialysis in an agitated patient. Inability to provide a trained overnight staff, because we have to understand the venous pressures, we have to understand the coagulation parameters, we have to dynamically assess whether the patient had developed the bleed, hypotension. So trained staff is an extremely important thing. Severe refractory shock we have discussed. Recurrent circuit clot, we have to identify, and usually the poor blood flow is the culprit for this indication. Multiple interruptions when we have to shift the patient for multiple procedures. An acute brain injury requiring very stable osmotic control, we have to prefer patient for CRRT. When it performs very well, we have already discussed this thing. Coming on to the evidence, I am not dealing or comparing anything with SLED or PD or CRRT, but more or less KDIGO guidelines suggest that continuous and intermittent renal replacement therapy are complementary. CRRT is suggested over standard intermittent RRT for hemodynamically unstable patients and for raised intracranial pressure. So patients with cerebellar edema, particularly with hepatic encephalopathy, might benefit with CRRT. They have not commented in 2012 about SLED as a separate entity, while in updated drafts, they have included the word PIRRT, that is prolonged intermittent renal replacement therapy, as a bridge between hemodialysis and CRRT. So we have to improve the outcomes by identifying and starting SLED earlier than after worsening the parameters. Avoid overly ambitious ultrafiltration target in one setting. Standardize the definition of hemodynamic intolerance. We will come on to the checklist of doing the SLED. Use a structured pre-SLED checklist. Improve the documentation of vasopressor dose. Many a times 2 का 4 कर दिया, 4 का 6 कर दिया, 6 का 8 कर दिया. Nobody knows what dose noradrenaline patient may be receiving. Monitor the phosphate levels consistently, particularly after 3 to 4 sessions. Establish an antibiotic dosing protocol before any decision of dialysis modality. Maintain a SLED registry, that what our ICU outcomes are, and conduct the regular review. So what improves the success is hourly ultrafiltrate. We need not have to be very rigid in terms of SLED. We begin conservatively, and if the patient is tolerating, we will try to increase the ultrafiltrate. Temporarily reduce or stop UF rather than immediately terminating the dialysis, because each time dialysis, ultrafiltrate removal is not the only indication for dialysis. Coordinate the antibiotics timing with the SLED session, and giving vancomycin prior to SLED must be a worst decision somebody can do. Document and prescribed versus actual delivered dose. This is extremely important for any modality of the dialysis, including IHD, SLED and CRRT, because majority of the times the target need to achieve, that is 6 to 8 hours of dialysis, may not be completed, and it is just on the paper that we are doing the SLED. Maintain the joint ownership, that the patient is admitted just under intensivist, just under nephrologist, or some other team, might lead to the compromise results. So SLED is not a fixed dialysis recipe. It is a dynamic ICU therapy that must be adapted continuously to patient's hemodynamic. So coming on to this small checklist, what we can do is we have to mention clear indication for dialysis. Hemodynamic status of the patient should be documented. Vasopressor dose should be documented. Recent biochemical parameters. What is our target age of achieving dialysis? What is the vascular access we are dealing with? What is the risk of the bleeding? What is the anticoagulation plan? Dialysate composition, antibiotic timing, who will be responsible for monitor, and criteria for reducing the ultrafiltrate or stopping the treatment should be predefined. Coming on to the benefits, which we have already discussed. So last slide, SLED is a practical ICU modality. It is easily available and do not require continuous therapy. Success depends on the patient selection, and real world outcomes are assessed by treatment completion and achieving the endpoints. Since Nikalji sir is there, we should not forget that there is a component of conservative therapy where we need not have to advise the patient for SLED also, CRRT also, and dialysis also, and have to accept the outcome that the patient is going to die in near future and need not have to be very aggressive and can compromise our results many a times. So renal therapy should be prescribed according to the patient's physiology or indication, not by the machine availability, pressure on the monitor or revenue expected. The indication must choose the modality and not the vice versa. Thank you. This one of the patient is improved with CRRT, yesterday's photo only. And the first photo is somebody improved on peritoneal dialysis for acute PD, not of SLED, not of mitral.
If we have time, we can have a couple of questions.
Secondary to?
Cardiac-active steroid toxicity-induced hyperkalemia.
Which?
Digoxin-induced hyperkalemia.
Okay. So monoclonal antibodies are right treatment modality.
Instead of this, hey, but this doesn't work there.
Yeah. Doesn't work, nahi. It might overcome the time or help us to buy the time.
No, it doesn't help, sir, because the problem is intracellular. It's not extra. तुम्ही जे काय करता ते बाहेर प्लाझ्मातलं काढता.
So it gives us time till the time we can reach or give the antibodies.
Very nice and lucid talk, sir. It is always a privilege to listen to you, and chairing your session is like thrilling experience for me. I do have one question, sir. If at all we are prolonging SLED session for 8 hours, 10 hours, is there any possibility that patient can develop dialysis disequilibrium syndrome?
Less with SLED, more with intermittent hemodialysis, because our whole purpose is doing low efficiency dialysis. So if the uremia is indication, intermittent hemodialysis always will fare better than SLED. So indication matters. If we are doing it for the indication of fluid removal, then obviously we have to prolong the session. If we are doing for an indication of uremic encephalopathy, uremic pericarditis, then intermittent hemodialysis will surely fare better. So chances of disequilibrium are more when the patient is having advanced azotemia. So less likely that SLED may end up. Yes, in an advanced azotemic patient, if we prolong the SLED, it might end up with dialysis disequilibrium.
One question, sir. We get a frequent intrahuman dialytic hypotension, particularly with intermittent hemodialysis. So if you compare with SLED, is the hypotension chances less as compared to intermittent hemodialysis?
Yes, sir. Because dialysate flow is also less. We are keeping dialysate flow of around 300 and blood flow is also less. So it is basically dialysate flow which helps us to compensate for the intradialytic hypotension and prolonging the ultrafiltrate removal. So most common problem with the intermittent hemodialysis is hypotension only, which can be safely overcome with SLED.
And the renal injury occurs because of dialysis?
There are very much varied data. I agree with that ki patient can die with dialysis also. If the acute gastroenteritis patient is done hemodialysis without fluid resuscitation, he will die. That's a renal injury instilled by the machine. But when it is performed without any indication, that is why, when in doubt, perform dialysis. That kind of mindset might end up becoming more renal injury than preventing the renal failure. So it is always the indication which matters. So dialysis causing renal injury, or some people are afraid to remove the fluid just because AKI will worsen. आपने 3 लीटर fluid निकाला, इसलिए किडनी पेशाब नहीं पैदा कर रही है. That mindset is still existent. ये डायलिसिस वाले आके 3 लीटर पानी निकालते हैं, दूसरे दिन तो पेशाब ही नहीं आता है. So it doesn't matter for renal recovery. Tubular necrosis will recover, will take its own time. And the fluid or urine output is independent of tubular injury. So this mindset ki fluid remove kiya isliye AKI hua can happen. Patient can die on dialysis also, but is very uncommon.
You don't want to compare the modalities.
Are very different. Some hospitals never do peritoneal dialysis. Some hospitals never do SLED. Some hospitals terminally do CRRT as a revenue generating model also. So there are different approaches to doing SLED. As I have told, when to use iPhone Pro Max and when to use iPhone Pro, which has point benefits, no doubt, but we have to choose it appropriately. That's why even my last patient was like, we have performed CRRT on her, but the indication was not renal, it was for hepatic encephalopathy, and she required it for 10 days. So everything has its own place, and we have to be judicious about its usage.
Absolutely. We have a specific one topic for the same thing, CRRT versus.
Thank you.
Thank you, sir, for your inspiring words and valuable insights. May I now request our respected chairpersons to felicitate our speaker, Dr. Neeraj Inamdar, sir. Dr. Nikhil Ingre, sir, to kindly felicitate chairpersons for the session. Thank you, sir. Now we are forwarding to our next academic session. It is my honor to introduce our speaker for the session, Dr. Shailesh Kakade, sir, consultant nephrologist at Jupiter Hospital from Pune. May I also request respected chairpersons for this session, Dr. Mukund Sasturkar, sir, senior physician and intensivist at Chhatrapati Sambhajinagar. Dr. Parmeshwar Jadhav, sir, consultant nephrologist at Kaushalya Kidney Care Hospital from Parbhani. Dr. Sachin Solanke, Professor Medicine at Noor Hospital from Badnapur.
The chairperson's permission, should I start? Should I start? Yeah. Thank you for inviting me today, and I could see the morning sessions were quite impressive and quite good discussion was happening. So now coming from the different filters which the first talk Dr. Nikhil spoke, I think the next things what is about HDF new. So so my role today is to convince that yeah, HDF is having some benefit over the normal hemodialysis. So if you look at HDF, what is the technical requirement for the HDF other than the normal dialysis? So what it requires is the HDF machines. So, sorry. So this is a different machine which is other than the hemodialysis machine. This is one important. So HDF is hemodiafiltration and HD is hemodialysis. So the difference are there, and definitely it is beneficial. We will go through it. So other thing is what is required is dialyzer, which is different. Staff training is also required, and water treatment system, which is the most important thing, which is quite different than the regular hemodialysis, and which is the access for HDF is usually used is AV fistulas. Catheters can be used, but yeah, we can go through that. So we should have a checklist. This is what I just now told. So what is ultra pure dialysis fluid? So that is the most important thing, the RO system. So if you go through this, if anybody has every dialysis center, I think investment in ultra pure water, I think, is the most important thing. Even if you don't have HDF, you should invest in getting the ultra pure water. If anybody is starting a dialysis unit, the crux of the dialysis is water. So water, if it is good, the people will be more benefited. That is most important thing to understand, that if your water quality is not good, even if you do hemodialysis whatever times, the people may have some kind of chronic problems, because water is used for every session. Everybody are exposed to the water impurities. So if it is a pure water, it is good for everybody. It is more healthier, it is more beneficial for the people. So that is important thing to understand, that if anybody has to invest now, I personally will feel that investment in having a ultra pure water is more important. So anyway, what is tap water which will undergo to the dialysis water, and then the standard dialysis fluid is added, and then the ultra filter endotoxin filter is there which will produce the ultra pure. So ultra pure water is that where the bacterial count, if you see the bacterial limit less than 100, which is in the regular dialysis fluid, and which is the endotoxin unit, which is 0.003 in ultra pure water, which is less than 0.1 in the hemodialysis now ARMI guidelines which we are using. So what is the HDF implementation? If you see, these are the implementation. Assessment of infrastructure should be there, staff training sessions, gradual transition of eligible patient to HDF, and then the outcomes like improved patient satisfaction score, reduced hospitalization. We should all look at what is happening because of HDF. So now coming to the evidence, what is the evidence? Why I am talking that HDF is better? So regarding HDF, the difference, if you see that what we do in hemodialysis is the diffusion method. So the diffusion is the waste product pass along a concentration gradient from the blood into the dialysis water. So this is a concentration gradient which pulls the things. But in the convection, if you see, the force is applied to the filters, to the filter water from the blood, and the water filter drags the soluble particle along the dialyzer membrane. So this is convection. So there is in HDF we have both diffusion and convection. So that helps in removing a lot of impurities. Basically the middle molecule clearance, which the first talk we were listening about. So HDF removes more larger molecules by convection than hemodialysis, which is important. So this is the concept where the substitution fluid is an important concept which is there in the HDF, which is not there in hemodialysis. So this substitution fluid which is given to the patient, this is the line which is coming from the patient. This is a pump where it goes to the filter. From the filter, the blood which is going, so the substitution fluid is added to the blood. So the substitution goes to the patient body. So what happens, what we call in the dhodala. So that is the other terminology. When we use lot of water to wash clothes, we can't drying and if washing the clothes, it will leave some impurities. So this is what we are trying to give the substitution fluid, so that the more things can be exposed to the membranes, and then the more things can be removed. So the substitution fluid is given to the patient, and then that will be removed. So machine remove whatever substitution fluid is given by its own. So we don't have to put any addition to the things. Whatever machine gives, it will remove by itself. The ultrafiltration, what we add, that is the removal of the excess fluid which we add. So that is a different thing, and this is a different thing. So evidence, so these are the 4 important trials which has been published in the literature. This is a contrast study, Turkish HDF study, Ishol study, and French study. These are all the European studies which has been worked on the HDF. So if you see, in all the studies, if you see the low flux HD means low flux or high flux. High flux he was talking about, and low flux is the normal hemodialysis what we do. The dialyzers which we use are low flux dialyzers. And the online HDF. So online is basically it is the fluid, it is the water which we are using. So it is called as online hemodiafiltration. So if you see in all the studies, around 200 to 500 patients were enrolled, and all the studies were up to 2 to 3 years. And if you see, this is the 24 liters per session. So what is this 24, 15, 18 liters? It is basically the substitution fluid and the removal, whatever is happening. So how much amount of fluid which we are giving to the patient. That is an important concept about substitution fluid. So, or whatever the patients actually is getting through the different things. So there are a lot of things about blood flow, how much we keep. So substitution depends upon different variable. We can't just set ki we will give everybody 20 liters of substitution. That does not work for everybody. It depends upon how much is the blood flow, what is the volume status of the patient. So a lot of things depend on that, we can decide. So you can see here different substitution volumes are there. So this is what they have achieved per session. And if you see here what is the outcomes of these trials, out of these trials, if you see primary outcome, there was no significant mortality benefit in the initial 2-3 trials. But if you see the post hoc analysis, there was a significant benefit in the primary endpoint when convective volumes was more than 21.5 liters. So if the volume which is given to the patient substitution fluid is more, they have found to have been beneficial. This is the same things, the 45% mortality risk reduction when the convective volume is more than 5.4 liter. I think this number is a really big number if you ask about 45%. So there are few things which we will keep discussing about. Not the negative part, yeah, but to achieve that volume, it is really difficult in Indian setup as such. So if we go through, they have pulled the data also of all these 4 trials, and if you see all these 4 trials, the pulled data, there was around 14% reduction in all-cause mortality and 23% reduction in cardiovascular diseases. As we know, the HD or CKD patients are usually cause of death is many of the patient is the cardiovascular diseases. So knowing about cardiovascular disease is very important. Now coming to the survival benefit which I was talking about is depend on the convective volumes which commences at around 23 liters. So I think achieving what I mean to tell is that achieving the more convective volume is important. I think every studies has been mentioning about 20, 21 liters, 22 liters, 23 liters, but in Indian scenario it may differ. Our patient population is different. We are little less muscular than the Europeans or the Americans which they have studied on. So I don't think so, but whatever I do in my setup, we have around 3 to 4 HDF sessions, machines which we work through and go through daily. So I am working on this for around 4 to 5 years we are having this setup. So what I can achieve is maximum 18 to 20 liters. I am also not able to achieve 20-25 liters which is mentioned in the studies, but one thing is there, the patients do really well. They are having really good outcome. Their quality of life has improved. I have not seen them coming back to me for hospitalizations or for coming back to me telling, sir, मुझे आज ठीक नहीं लग रहा है, I am having cramps, I am not feeling well, I am generalized lethargy. That complaints which HD patients, most of the patients are having, itching a lot. Many of them are actually beneficial by doing this HDF. This is most likely because of the middle molecule clearance, and there are a lot of things which I think will come up with the further things, and even the government should look at it in a very important aspect. So if you see sorry for the slide, it has cut. Median predicted survival benefit was 44 days for every years of treatment with HDF. Patient who benefited most from HDF were younger patient, less likely to have diabetes or cardiovascular diseases, higher serum creatine and albumin level. These are the study outcomes. So mostly the reason our younger patients were doing well is mostly it is a good thing. So what were the limitations of this meta-analysis? That difference between the two trial designs may be there. The data was diverse. The patient populations with varying treatment modality. Sorry, it's not working. The data was diverse, so they were used low flux and high flux dialysis both. The analysis of on convention values were also interpreted as observational analysis in which the residual confounding cannot be excluded. So there were some limitations to this pooled data. So the CONVINCE trial was designed after this trial, which has been to investigate whether the high dose HDF offers survival benefit compared with the conventional high flux HD. So everybody now wants to know whether the mortality or the benefit is there or not, because that is the most important outcome everybody wants to know. Is the patient surviving more? So this is the CONVINCE trial, where they have seen that they have taken around 1360 patients which were randomized to two arms, equal arms, post HDF more than 23 liters and high flux HD. So the whatever they have done the dialysis, so that is important, that dialysis patients were also given a good thing. It was not that they were not looked at properly. They were giving the high flux HD with a KT/V, which is an important indicator, which was more than 1.4 for all the patients. And they were seeing the outcome as all-cause mortality and cardiovascular events, and patient-reported outcomes were seen. So this was a 3-year follow-up study. And this were done in European countries again. And if you see that the high dose high flux HD and high dose HDF, if you see the KT/V was every time quite good. And post dilution HDF, if you see the convective volumes in most of the studies, there were few, gradually it has started decreasing with the time. If you see around 23 to 24 to 25, they were trying to find out, and these were the results. And you can see the death from any cause was found to be beneficial. Non-cardiovascular diseases, including COVID-19, was found to be quite beneficial. So high dose HDF was found to reducing the reduction by 23% than high flux HD. So this was a very important thing to understand, that this was significant beneficial trial compared to the hemodialysis, which is high flux. And if you see, these are what I was talking about, that patients who were having no pre-existing diabetes, patients who were not having any cardiovascular diseases, but more than 65 years, were found to be much more benefited than the other patients. So I will go through this. This is the same thing what they were European HDF. This was the update beyond the CONVINCE trial. And this is the Lancet study, where they have seen the contrast Turkish, Ishol, Frenchy and CONVINCE. All these 5 trials were now put together, and they have done the analysis, and they found that 16% reduction of all-cause mortality. So this is a very big number to understand. The 16% reduction were seen in all-cause mortality. So mortality and convection volume, a graded relationship between the convection volume and mortality risk was apparent. As the volume increases, the mortality risk. So if you see the entire dialysis population, there was quite significant improvement in the mortality. And risk of death was reduced. This was a different study, where, but this was a smaller study. And this was only a data. This is not the study. This was only a data from the Fresenius Medical Care Clinics, which they have seen 85,000 patients. The risk of death was reduced by 30% in the patients who were having the HDF. So this, how did they did that? They have seen the hemodialysis patients and the hemodiafiltration patients. So if you see the hospital admission and hospital days, which is again an important thing. Many of our hemodialysis patients, if you see, they come to us with the breathing difficulty, sir सांस लेने में तकलीफ हो रहा है, धाप लागते हैं, and then they get admitted, get dialysis done overnight, and then they go. So this is important that actually increases the bill by around 50,000 rupees. So that 50,000 rupees can be definitely used. One hospitalization in a whole year will help the patient to do the HDF. That is an important lesson over here. So 30% reduction in all-cause mortality, 55% reduction in the mortality from infection, 61% reduction of mortality from stroke, and 28% from hypotensive episode, 22% risk reduction in hospitalization, and 33% cardiac muscularity. This I think my next speaker will speak about that. There were a lot of, in the CONVINCE trial, they have gone to the quality of life. I was only talking about the mortality and this thing. So quality of life, because they are living. So how are they living? Are they having really good quality of life? Are they getting able to do all the activity? Are they able to go for a walk? Are they able to do their mental stability? Is there or not? This study showed that sleep dysfunctions, physical functions, cognitive functions, has everything improved with the HDF. So if any questions are there, I will like to take. किमतीमध्ये it is around 5,000 rupees to 5,500 rupees at our center. पण त्या सेंटर मध्ये आम्ही HDF मध्ये तुम्हाला नवीन फिल्टर every time we will use. So dialyzer is not reused. आणि tubings including everything, it is around 5,000 to 5,500 rupees. No, frequency of HD and HDF मध्ये काही no difference is there. But आता in what I am doing, my patients tells ki sir, I am on dialysis for 8 years now, 7 years. तर मग they are definitely with the number of more years on dialysis, they may have some middle molecule accumulations and all these things. So त्या patientला they go for once a week HDF, all other 2 times HD. So there will be some removal. There is no study, there is no data, but is this possible? Yeah, I don't think so whether everybody agrees, but I do that. I tell them you do take one HDF and take the other things. There is no study, yeah, but we have to bring the data up. We have to enroll our own patients. I think we will get the data also. एक काय म्हटलं सर? एन्केफेलोपॅथी म्हणजे तो ICU सेटअप मध्ये आहे. तर दॅट इज लाईक इफ यू हॅव ए अल्ट्रा प्युअर वॉटर, then you can do HDF for everybody, any patients. There is no way that you can't do for this patient or you can do for this patient. HDF can be done for, but the whole requirement is you should have a ultra pure water. पाणी जर नसेल तर never try. It can become a big problem because you will put lot of impurity, because this water is going to go in your directly in the blood. It is not going to go through the dialyzer. नाही तर dialyzer आणि HD मध्ये फक्त dialyzer आणि त्याच्यासोबतच combination होते. पण this going in the blood, you have to have a ultra pure water, otherwise you are having a big challenge with the patients. काय म्हटलं सर? Machines are need for HDF. आता HDF can become a new HD also. मी असं पण म्हणू शकतो. पण it will take some time. आता if you ask me की मी पाण्यामध्ये इन्व्हेस्ट करू की मशीन मध्ये, तर I will tell you first invest in water. Water चांगलं करा. ते that will be better for your hemodialysis also, your HDF also. If your water source and water thing is good, you will be, your patients will maximum time will be happy. आणि I think the most important thing patient should ask for is the dialysis machines कुठल्या यापेक्षा पाणी कसं वापरता. तुमच्याकडे पाण्याचा परवाना दाखवा. That should be the patient's first question to the doctor, which I think आपण त्या मशीन, फॅन्सी मशीन्स बघतो, त्या मशीन मध्ये काहीच होत नाही. त्या मशीन मध्ये फक्त डायलायझरच काम करते. अल्ट्रा प्युअर ते मी पहिले जे दाखवलं देर आर स्टँडर्ड्स तर ते अल्ट्रा प्युअर वॉटर यायला पाहिजे तर त्याच्यासाठी स्टँडर्ड लॅब असतात दॅट लॅब विल टेल की त्या टेस्टिंग त्याच लॅबमध्ये होतात सो दॅट यू हॅव टू फाइंड आउट की त्या लॅब्स कुठे आहे आणि त्यांच्याकडे ते पाण्याचं टेस्टिंग पाठवायचं अल्ट्रा प्युअर वॉटरचं स्टँडर्ड आहे 0.003 आणि 0.01 ते व्हायला पाहिजे एन्डोटॉक्सिन आणि हे आणि हिमोग्लोबिन इज अ व्हेरी इम्पॉर्टंट पॅरामीटर्स
Any more questions? Thank you, sir, for a very nice presentation. Thank you very much.
Thank you, sir, for sharing your knowledge with us. May I now request our respected chairpersons to felicitate our speaker, Dr. Shailesh Kakade, sir. Dr. Ajay Rote sir to kindly felicitate chairpersons for the session. Thank you, sir. Thank you, sir. Thank you so much. Now we are forwarding to our next scientific session. It is my honor to introduce our speaker for the session, Dr. Manan Doshi sir, consultant nephrologist at Sahyadri Hospital from Pune. May I also request to respected chairpersons for the session, Dr. Pradeep Saruk sir, consultant nephrologist at Aster DM Sigma Hospital from Chhatrapati Sambhajinagar, Dr. Sanjay Patne sir, Deputy Dean and Senior Physician, Professor Shiva Trust Medical College and Hospital from Chhatrapati Sambhajinagar, Dr. Deepak Gowdi sir, Senior Physician and Intensivist at Chhatrapati Sambhajinagar. May I request it to all of you, please grace the dais.
करेक्ट नहीं
So at the outset, I would like to thank the organizers for inviting me for this talk. And the previous speaker, Dr. Kakade, has made my job a bit easier. So the topic allotted to me is patient selection and outcomes. And what we have done till now in CKD is, by doing dialysis is we have prolonged their lives, but have we restored their health? Has their functional capability been improved until now is something that needs addressing. So we are going to talk about HDF, and here we have understood from the previous talk that it's the dose that matters, not only the modality. But we have to select rationally, read the evidence critically, and we need to know the boundaries where we can and we cannot do hemodiafiltration. So first, addressing the problem, we know that kidney disease is a problem. The 5-year mortality rate is close to 60%, only 40% survival rate. Annual mortality rate is 10%. And cardiovascular deaths cause more than 50% death, sudden cardiac death about 1 in 3. And if any new modality has to come, it has to address this, and it needs to rectify this. And we clearly know that KT by V, that is the measure of small molecular substance clearance, has not made a difference. And so if we try to go through the studies, what we try to do is first increase the urea clearance and see if that makes a difference in outcome. So we had NCDA study, hemo studies, which clearly showed that increasing the small molecular clearance has not really made any difference in outcomes. So then we tried increasing the flux of the membranes using higher flux membranes, and again that did not show overall outcomes. And then we started doing hemodiafiltration to see if that really makes an outcome, and yes, as per the CONVINCE trial, it did make an outcome. So presenting a case of 58-year-old male who is a diabetic, who is on thrice weekly dialysis, has a left brachiocephalic fistula with a good flow. We are using 15 gauge needles to cannulate the fistula, and we achieve a good blood flow of 350, 380. His KT by V is good. His interdialytic weight gain is only 2.8. UF rate is about 11 ml per kg. And we have a good dialysis unit with good RO water, which is ultra pure, and we have HDF capable machines. So as per numbers, this patient is doing good, right? We really don't need to change anything. He's achieving good KT by V. The interdialytic weight gain is okay. But what these numbers don't capture is he has anemia. He does not have good response to erythrocytosis stimulating agents. He has hypotension at the time of dialysis. There is symptomatic intradialytic hypotension that this patient has. He has anorexia, malnutrition, failing lean in mass. And also post-dialysis recovery time is very long. So he does dialysis, he goes home, he feels tired, and he has to sleep, rest for a long time to regain energy levels. So where this comes to is what KT by V does not capture. So we classify uremic solutes into 3 different categories. One is small molecules, other is middle, and the large molecules. So what KT by V does is it does clear the small molecules, but it does not address the middle or the large molecules. So there is a gap there. And this gap is addressed by hemodiafiltration, which also targets the middle molecules removal. So what does HDF actually mean? So it is hemofiltration plus hemodialysis. So hemodialysis is which addresses the small molecules by diffusion, and hemodiafiltration, hemofiltration is by convection. So we remove large amount of solvent, and along with that, solutes are dragged across the membrane, and their removal, what we call as the solute drag, and that is what has made this middle molecule clearance better, and as is postulated to improve the quality of life of patients on dialysis. So this is the high flux dialysis. So if you give a blood flow of 300, you remove 10 ml per minute of ultrafiltration, and dialysis flow is run at 500. So you have 510, which is the 10 ml of ultrafiltration that is happening. So what does hemodiafiltration do is you still remove 10 ml. Along with dialysis flow, we are also giving additional 40 ml of fluid, and that additional 40 ml of fluid is removed with ultrafiltration over here. So this is your substitution fluid. So total fluid removal is 50 ml, out of which 40 you are returning back to the patient. So this is what convective removal does. And initially, what we do in CRRT is we have substitution bags. We have separate bags which are hang down, and we commercially make those fluids and supplement. But for CKD patients, we have something called as online hemodiafiltration, where this substitution fluid is generated online with the use of 2 additional filters. So here what happens is, suppose you have 500 ml of fluid. You run dialysis at 480, 80 ml is infused here, and that additional 80 ml is removed from the dialysis, and along with ultrafiltration, it does come out. So what we have is 2 additional filters, and this replacement fluid can either go before the filter or after the filter. If it goes before the filter, it is called pre-dilutional online hemodiafiltration. If it goes after the filter, it is the post-dilution hemodiafiltration, online hemodiafiltration. So what the studies have shown, I've predominantly used post-dilution hemodiafiltration, and where, as the previous speaker said, the substitution fluid that is targeted is 25 liters. Now mind you, convective volume differs for hemodiafiltration versus CRRT. CRRT convective volume includes your ultrafiltration plus replacement fluid plus the dialysate. Here the convective volume includes your convective removal plus the ultrafiltration. It does not include the dialysate in the convective volume. And as we know that as the convective volume increases, the beta-2 microglobulin clearance also increases. And when we use it in a different way, so suppose if we are not using post-dilution, we use pre-dilution, then there is a dilution factor which has to put in. So for pre-dilution, it is 2. So if your target is 25 liters, but you are using fluid pre-dilutional, so that is going to dilute your blood previously. So the clearance has to go up. So hence the ultrafiltration volume has to go up. So in that case, it will come somewhere close to 50 liters in pre-dilution. For mixed dilution and mid dilution, it will be somewhere around 1.5. So mixed dilution is both giving pre and post. That requires a third pump in a CRRT machine. And a mid dilution is a separate filter which is available where a substitution fluid can be given mid dilution. Now when we talk about removing fluid, we need to understand something called as filtration fraction. Easily put, it is the rising hematocrit across the filter. So when the blood goes through the filter, you are removing a lot of fluid from the filter, the blood is going to get hemoconcentrated. The higher the blood gets hemoconcentrated, more is the chance that filter is going to get clogged. So for at least to term it as a hemodiafiltration, it has to be minimum 20% of the blood process. Highest you can go is about 30% because you go beyond that, your filter is going to clog because your TMP is going to go up. And another way to address filtration fraction is increase the blood flow, because then you're going to increase the plasma flow across the filter and reduce the filtration fraction. So to avoid this, newer machines have something called as automated AutoSub Plus. So what machine does is it continuously measures your transmembrane pressure. It measures the pulsations that are developed from the peristaltic pump, combines that information and keeps that TMP in the optimal window of 140 to 120. And what it does is it reduces the alarm, it maximizes the convective dose. And what studies have shown is that it increases your convective volume by 12 to 18%. Now, for doing HDF, we need certain things. One thing is we need to decide which patients need to go on HDF. So if we divide patients according to vulnerability and uremic toxin load. So high toxin load with high vulnerability, like patients who are hemodynamically unstable, who have high incidence of intradialytic hypotension, who have congestive cardiac failure, a DCLD patient who is on dialysis, more prone to hypotensions during the dialysis episodes. These are the patients who would benefit maximum from hemodiafiltration. Strongly recommended for patients who have high uremic load like uremic pruritus or dialysis-related amyloidosis, multiple joint pains, who have prolonged recovery after dialysis. And the rationale being the clearance of middle molecules. For other patients, there can be tailored approach, like elderly patients with poor tolerance and patients who have excessive cramps due to ultrafiltration. They will benefit from hemodiafiltration as well. For patients whose access are not good, hemodiafiltration may not be possible because you need a good blood flow to achieve the convective volume. If you don't have a good vascular access, it may not be possible to do hemodiafiltration. After the patient, we need a machine to do. So there are various machines available. Most commonly are the Fresenius and the B. Brown Dialog Plus. These are few other machines which are available, which are capable of doing hemodiafiltration. We need membranes. So we need membranes, dialyzers, which are able to achieve this convective volume. So they are specially made, and these are measured by molecular weight retention onset and cutoff. So what retention onset means is where your sieving coefficient 1 means whatever is there on the other side will get transfused to the dialysate side. 0.9 is where rejection starts, and 0.1 is that beyond that nothing is able to pass. So for hemodiafiltration, we need an ultrafiltration coefficient of more than 20, sieving coefficient of 0.6, and albumin should not pass. So based on that, you can classify the membranes as flux based on ultrafiltration coefficient and the cutoff. We already had a talk in the morning about cutoff and advantages of that. These are the various filters which are available, which can be used for hemodiafiltration. They have varied surface area and varied priming volume. Certain pediatric filters are available, FX40, FX speed, and Polyflux 2H. as Dr. Kakade said, the mandatory is you need to have ultra pure water, because whatever water is going to get generated online is going to be directly infused in the patient. If you have impurity in the water, your endotoxin levels are high, if it's contaminated with bacteria, it's directly going to go into patient and cause problems. So you need to have ultra pure water. And only having ultra pure water is not enough. You need to keep on monitoring it, that you are continuously making that ultra pure water. So it is recommended that you check for levels every monthly and quarterly for chemical. And you need to have a loop disinfection of the dialysis water as well. So in Pune, we check it regularly. We do it monthly. And endotoxin level is checked by LAL assay. So now we have the machine, we have the membrane. So what we need to have is we need to have a good blood flow. So to achieve this volume of ultrafiltration, your blood flow has to go somewhere around 300 to 400. If you don't achieve that, it may not be possible to achieve this convective removal. And until you have that convective removal, you may not be able to achieve the outcomes which you intend to give to your patients. So to achieve this blood flow, one thing is they are better off with AV fistulas. And if you have a temporary line, actually you may not be able to achieve this kind of blood flows. You need to use large bore needles. If you use smaller bore needles, you may not give as much blood supply as you intend to. And hence, which needle you are using to prick the fistula is also a part of your prescription when you consider hemodiafiltration. So if you use a smaller needle, although you intend to give 400 blood supply, your effective blood supply will never be what you intend to give. So sometimes, especially for Asians, it may not be possible to have this high blood flow fistula. So what we call as the leftward shift, that is our body surface area is not as much as what the Westerners are. So we need to adjust the convective volume to body surface area. And suppose if body surface area is low, then maybe your target convective volume must be lower than what is suggested. Other thing is that suppose if you have an axis which cannot give you a blood flow of 300, 400, then you can do a pre-dilutional replacement, and you can actually do a hemodiafiltration with a lower blood flow volume. And what studies have shown is that they equally give good outcomes compared to post-dilution HDF. And predominantly, it's in Japan that they use pre-dilution HDF, and they have a poor blood supply, but they use a pre-dilution method. Almost 91% of them are on the pre-dilution method. What China does is it just does once a week hemodiafiltration and rest of the times normal dialysis, but there are no studies to establish this protocol. This is the Indian consensus, which was recently published in March 26, and we are lucky to have two authors amongst us, Dr. Kakade and Dr. Kumtekar. And what it says is that, yeah, it can be advised for patients with poor response who are hemodynamically unstable, but what it also suggests is that it's recommended for patients of all age, and every patient should be given a choice of hemodiafiltration and explained its benefits, provided you have the capability to provide it with good ultra-pure water and a hemodiafiltration machine. So what is recommended is standard 3 hours, 4 a week session, good blood flow, convective volume of 23 liters, and using a 15 gauge needle, filtration fraction to be kept between 25 to 30%. Evidence is already spoken about, so I'm not going to dwell into it, but what it says is that none of the studies actually disagree about use of HDF. The difference is about the volume that you achieve with the HDF. And these are the various studies which previous speaker has already said. But what we also need to understand is there are certain caveats in that. Like what the trial enrolled the patients, well, the mean age was 62, more than 80% had AV fistulas, less than 40% were diabetics, less than 25% had coronary artery disease. And ideally, none of this is the real case scenario in our dialysis unit. Most of our dialysis patients will be diabetic. Nowadays, a lot of them are on temporary catheters or a perma catheter. So this may not really represent our population. And also what needs to be understood is that there was switchover for patients who did not achieve the blood flow volume. And the fragility index of the study was 3. So if you shift 3 patients from one group to other group, the outcome would have changed. So what is the verdict is that, yeah, it does favor all-cause mortality and cardiovascular mortality. But other things, we are still looking into it, and we need a better evidence to recommend it. Now, we have another patient who's doing well on dialysis, has tertiary hyperparathyroidism, has a carpal tunnel syndrome, and something called dialysis-related amyloidosis. So we switched this patient on to thrice-a-week hemodiafiltration. And before shifting to hemodiafiltration, the beta-2 microglobulin level was more than 40, and we could reduce it to 31.5. So there was a 22% reduction in the beta-2 microglobulin level, and the pain, joint pain reduced from 9 to 6 on a visual analog scale. So why beta-2 microglobulin level is because it's considered as a suitable marker for vital molecular clearance, and the risk of death decreases by 11 to 13% for every 10 milligram per DL decrease in beta-2 microglobulin level. So high flux hemodialysis reduces beta-2 microglobulin by 40 to 50%, but online hemodiafiltration reduces it to 70 to 85%. So this is the absolute removal, and what is targeted is less than 27 milligram per DL. But this alone is not enough because there is a rebound, and hence on online hemodiafiltration, typically you achieve a level which is 10 to 15% less than the level achieved by high flux hemodiafiltration. So this is another patient who has recurrent hemodialytic hypotension, and we switched her to hemodialysis. And what is the evidence for that is that these patients, when you do hemodiafiltration, you are going to remove a lot of inflammatory cytokines, markers, middle molecules, uremic toxins, and you're also going to replace fluid with substitution fluid, which is cold. So that produces hemodynamic stability. It also reduces cramps, it reduces cardiovascular adverse effects, better preservation of renal function. And what is striking is that the hangover effect after dialysis is much lesser with hemodiafiltration compared to high flux hemodialysis. There is better response to anemia, and also the cognitive function, the what you call restoring the health is much better with hemodiafiltration compared to hemodialysis. This is the study where they did an analysis of for what patients would you prescribe hemodiafiltration, and the prescription varied country to country. France had maximum response to hemodiafiltration across various groups. And this is the global adoption rate. Unfortunately, in India, there is a big lag. And why is there a barrier to hemodiafiltration in India? Because you need to buy machines. The machines are going to be expensive. The consumable cost is going to go up by 1,000 to 2,000 rupees for every hemodiafiltration. There is reimbursed limits. Also, most of our patients are doing dialysis on yojanas, which are not covered by this structure. You need a RO unit which produces ultra pure water. You need to keep on maintaining the RO unit. You cannot reuse the dialyzer for hemodiafiltration as what you would do with normal hemodialysis. You need to have a patient who is on thrice a week dialysis. Most of our patients do not agree for thrice a week dialysis. They would say 2 times a week is enough. They would have a vascular access is a problem because a lot of our patients are on temporary catheters. If you have a good water quality, good vascular access, dialysis frequency is there, and yes, these patients can be used for hemodiafiltration. If not, then the pragmatic approach is to use the medium cutoff dialyzer, which the morning speaker has already discussed. Regarding greener dialysis, we do use a lot of water for hemodiafiltration, but this can be addressed by limiting the dialysate flow to 20% of your blood flow. So by limiting the dialysate flow, what you do is you increase the replacement fluid. So amount of water spent is going to remain the same, but you're going to achieve better convective removal by doing that. So there is a checklist that is your water pure? Are you able to use high flux dialyzer? Do you have machines? Do you have 2 filters? Now, also you need to remember for ultra pure water, just putting the machine is not enough. There are 2 ultra pure filters which also need to be changed periodically. Recommendation is either 100 sessions or every 3 monthly, whichever is earlier. So, and who is not the candidate? Suppose you cannot reach more than 18 liters per session and who do not have a good access and you cannot achieve a reliable ultra pure water, and these are the patients who cannot be taken on hemodiafiltration. With that, I would end my talk, and I would be happy to take some questions.
Anybody? Sir, after your masterly talk on diafiltration, online diafiltration, as a physician interested in clinical toxicology, may I add with your kind permission, sir, that as a toxicologist, we look at the target organ concentration rather than the plasma concentration. For example, in paraquat, if a patient of paraquat poisoning comes to me, and even if I try HD or ultra HDF, I don't think that works because it's a pneumocyte concentration. Similarly with lithium also, it's a CNS concentration, digoxin. So it's usually the target organ. And second thing, sir, endogenous clearance. There's a few molecules which have got very good endogenous clearance. Actually, in toxicology, we concentrate about 30% clearance for any effective use. So cocaine already has more than 30% clearance. Really, do you think if a patient comes to you, you'll employ this strategy?
If a patient come to me?
Cocaine overdose. Will you use online HDF?
It can definitely be used, I think, because although it has endogenous clearance, it depends on the patient status and what you want to achieve. If patient is in a very sick state and you want to achieve a clearance, it can be tried. That is what we might take.
Anybody from the audience? Thank you, sir. Very masterly and very well-studied lecture. Thank you so much. And for that madam who introduced me. Madam, I am Associate Dean, not Deputy Dean.
Thank you.
Anybody to felicitate our speaker?
Thank you, sir, for sharing your valuable insights with us. May I now request our respected chairperson to felicitate our speaker, Dr. Manan Doshi, sir. Now I request Dr. Vinod Gosavi sir to kindly felicitate chairpersons for this session. Now before forwarding to our next session, thank you, sir. Now, before forwarding to our next session, now with a great pleasure to let us move towards today's digital inauguration ceremony, marking the formal beginning of this academic CME program. May this digital inauguration ignite minds to explore, inspiring excellence in medicines forevermore, where science meets excellence takes flight. Let this CME begin with knowledge as our guiding light. May I now request today's chief guest of CME, Chief Executive Officer, Kamalnayan Bajaj Hospital and Nursing College, Dr. Josh Fernandez, sir, please grace the dais. Now, I would like to invite today's special guest, Dr. Yogesh Lakkas, sir, chairpersons of ISCCM, Chhatrapati Sambhajinagar. Dr. Rahul Chaudhary, sir, Secretary of ISCCM, Chhatrapati Sambhajinagar. Now, I would like to invite today's guest of honor, Dr. Ranjana Deshmukh Madam, President, Physician Association, Chhatrapati Sambhajinagar. Dr. Pradeep Benzarge Sir, Secretary, Physician Association, Chhatrapati Sambhajinagar. Now, I would like to invite Medical Director, Kamalnayan Bajaj Hospital, Dr. Ajay Rote Sir. Now, I would like to invite today's organizing chairperson, Dr. Samir Mahajan Sir. Now, I would like to invite today's organizing secretary, Dr. Nikhil Ingre Sir. Please grace the dais. May I now respectfully request our honorable chief guest, along with our esteemed dignitaries, to kindly proceed with the digital inauguration. Thank you to all dignitaries. Please have a seat. May I now request today's CME organizing chairperson, Dr. Samir Mahajan Sir, to felicitate today's CME program chief guest, Dr. Josh Fernandez Sir. May I now request today's organizing secretary, Dr. Nikhil Ingre Sir, to felicitate Dr. Pradeep Benzarge Sir. Thank you, sir. May I now request Dr. Ajay Rote Sir to kindly felicitate Dr. Yogesh Lakkas Sir. Thank you, sir. May I now request Dr. Shrikant Sahasrabuddhe Sir to kindly felicitate Dr. Ranjana Deshmukh Madam. Thank you for all dignitaries. Please have a seat. Okay. May I now request Dr. Vinod Gosavi Sir to kindly felicitate Rahul Chaudhary Sir. Sorry for the inconvenience. Thank you, sir. May I now respectfully invite Organizing Chairperson Dr. Samir Mahajan sir to deliver the inauguration speech.
So, good afternoon everyone, welcome all. As we are running a bit late, I would keep this short just to introduce the purpose of the conference. First of all, it gives me an immense pleasure to welcome you all to KB NEPHROCON 2026, organized by our Department of Nephrology, Kamalnayan Bajaj Hospital, Chhatrapati Sambhajinagar. On behalf of the organizing committee, I extend warm welcome to our esteemed dignitaries on in the inauguration function, as well as distinguished faculties, respected physicians, intensivists, nephrology colleagues, and seniors present here who have taken time out of their busy schedule. Some of them have traveled from different cities all across Maharashtra to be here, particularly as a speaker, faculty, and to share their knowledge and wisdom with all of us. Medicine is evolving at an unprecedented pace, and nephrology is also no exception. So now gone are the days where nephrologists used to work in isolation. Now nephrology branch needs to blend with medicine, intensive care, critical care particularly, and we need to provide combined approach to the patient as a team. So the purpose of this conference particularly was to highlight on those aspects which are completely integrated in terms of nephrology, medicine, internal medicine, and intensive care, and particularly taking into consideration the newer modalities of therapies, extracorporeal therapies. Those are available recently in our town, particularly in Marathwada region. So earlier we used to only talk about hemodialysis. Nowadays we commonly talk about SLED, CRRT, hemodiafiltration, and practically all the facilities are now available in Marathwada in last couple of years in multiple institutes, and Kamalnayan Bajaj Hospital is no exception. So the purpose was to highlight and get into the insights of these therapies so that we are all aware about the therapies and we remove all our doubts and reservations regarding using these modalities of therapy, so that we use it more and more practically for the benefit of the patients. With this vision, we have designed today's scientific program to be practical, interactive, and clinically relevant. I am confident that the discussions and deliberations throughout the day will be enriched by all of us. I encourage everyone to participate actively, particularly to ask questions and make the most of this opportunity to learn from our esteemed faculty and our friends. Thank you all for joining us. I wish you an engaging, productive, and memorable KB NEPHROCON 2026. And with this, let's begin the scientific sessions as early as possible and to keep it in time. So thank you all for making it here, and once again for attending this conference.
Thank you, sir. May I now respectfully invite President Physician Association Dr. Ranjana Deshmukh Madam for the speech.
Dear all, I congratulate Kamalnayan Bajaj Hospital and Nephrology Unit particularly for arranging this CME very nicely. The venue is very new and very good. This is one thing. And second, the topics which are selected by the team are very particular. Once they are useful for physicians who are working, so newer modalities are known to us because we cannot go for the nephrology conference everywhere. So new things which are happening in the world are known to us by this program. Second thing, who are nephrologists practicing or new students, they are also benefited by all these practical tips which are getting from the nephrologist. And the primary physicians, where the primarily patient goes to them. If they know what are the things which are applicable to which patients, if they know correctly, they can refer those patients in time to the nephrologist or physicians who are working in the dialysis unit. So these are the 3-4 advantages which have been covered by this nephrology unit by Kamalnayan Bajaj Hospital, keeping all the topics or all the topics are touched in particular home dialysis, or those we can think that it may not be possible, but the time is such that all things all the modalities will be available with us only, and patients friendly in the approach. So I once again thank you all, and those physicians and intensivists who are attending this CME will be benefited. I am sure about that. Thank you once again for calling us. Thank you.
Thank you so much, madam. May I now respectfully invite Chairperson of ISCCM, Dr. Yogesh Lakas, sir, for the speech.
Good afternoon, everyone. Definitely today is a Sunday morning, but the gathering is tremendous, and the efforts made by our organizing team, Dr. Samir Mahajan, then Medical Director Dr. Rote, and the CEO of Bajaj Hospital, Dr. George. It is tremendous efforts we can see, and the topics those are chosen for this CME, these are wonderful, because nowadays dialysis, it is not limited only to a single organ. It has crossed the boundaries. It is the important modality. It is in fact extracorporeal organ support, and multiple organs are supported by this system. Nowadays it has evolved beyond the boundaries, and it is need of any ICU. And being a chairman of a critical care society of Chhatrapati Sambhajinagar, proudly I can say the interaction among all of us, being as a physician, as an intensivist, or as an administration, it is always important to discuss a patient and to give the best modality therapy, which Bajaj Hospital in the region, I would say it is the offering everything, whether it is a CRRT, whether it is a ECMO, and it has really made changes in giving the care to the patients, and that too at the affordable cost. That's why Chhatrapati Sambhajinagar is evolving as a topmost center in Maharashtra or India, which can give the healthcare at an affordable price. Many patients, they would like to come from Mumbai. Many patients, they would like to come from Nasik, and that matters a lot. As an administrator in the IMA body also, it matters to provide healthcare to each and every needy person, and each and every life saved, it matters a lot. And today, additionally, we can see that many nephrologists, they have come from the Pune. That interaction among the intellectuals, it makes really difference. And definitely, today is one special occasion, Friendship Day. So we all are friends. As a Chhatrapati Sambhajinagar city, we represent Chhatrapati Sambhajinagar, and we are really proud of each and every consultant here who makes city proud. And it matters a lot, because nowadays Chhatrapati Sambhajinagar has gone on the platform. Nationally, it is being recognized because of the efforts of many consultants. Even Dr. Rote, he is like nationally recognized NABH assessor. This matters a lot for all of us. Even Dr. Shrikant Sahasrabuddhe, he will be national president Spain Society. बस अभी लास्ट इतना ही कह देता हूँ, because it is a friendship day today. मंजिल से ज़्यादा सफ़र ने सिखाया है हमें, अच्छे दोस्तों ने जीना बताया है हमें, and as all of you friends will make this journey of medical fraternity in the Chhatrapati Sambhajinagar, and will make Chhatrapati Sambhajinagar always proud while giving the care to the patients or in the academic events also. And at the last, I will just invite you for Mahacriticon 2026, which will be held on 23, 24, 25th October, and that will be organized by Chhatrapati Sambhajinagar ISCCM branch. Dr. Sahasrabuddhe, he will be the organizing chairperson for that organization. Myself will be organizing secretary. Then Dr. Valse as a vice chairman, Dr. Rahul Chaudhary as joint secretary. And we will represent all of us as a team in the Mahacriticon, and let's make our city proud. Thank you for inviting me in this esteemed CME.
Will Fernandez has taken over. And exactly, it is an coincidence that yesterday he has completed 3 years for Kamalnayan Bajaj Hospital. So we would like to congratulate him. And with his vision and his dedication and his global experience. So what matters is a global vision and experience. So Kamalnayan Bajaj has really transformed into a world-class institute. And I would like here to introduce you to few of the aspects of Kamalnayan Bajaj Hospital which are very crucial in today's scenario. Before that, would like to congratulate Samir and Nikhil, who have done tremendous efforts, and my colleague Dr. Milind, who will be joining in some time. So they have taken tremendous efforts along with our marketing team. Also, would like to thank Physician Association and Critical Care Society for their very active participation. So as you are aware, Kamalnayan Bajaj Hospital has got a 35 years of legacy of clinical excellence. So my presentation for next 7 minutes, not more than that. So it will be focusing on yesterday, today, and tomorrow. So yesterday, as I mentioned, it's 35 years of trust. It's a foundation. It's a philanthropic backing for MMRI Trust and Bajaj Group. It's bringing world-class care to Marathwada. That was the vision with which we have started. Today we are a quaternary care hospital, NABH, NABL accredited, the only hospital which is digital NABH accredited, the only hospital which has received Digital Excellence Award from NABH, and lakhs of patients have been successfully treated. Tomorrow, scale and supremacy coming forward in the next 2 to 3 years. That's our vision. So the foundation of filling, the vision was, as you know, it was founded by MMRI Trust, and basic vision and mission of Kamalnayan Bajaj Hospital is the patients in this region should not need to travel anywhere outside of the city for any treatment. So that's why we label Kamalnayan Bajaj, or everybody thinks Kamalnayan Bajaj Hospital as really the complete hospital. So we have got a commitment, we have got the scale, and we have got the vision, and we are in tune with our vision. We are working all the time. So we have got a critical care unit, surgical theaters, dedicated robotic surgery, sustainable foundation, and the intervention hub. So everything is so intricately, you can see the design. That is such a wonderful thing that a patient need not go anywhere else, and it has got a wonderful facility, everything under one roof. So the surgical vanguard, if you see, we have got a 4th generation Da Vinci robot, and we are doing almost 25 to 30 robotic surgeries every month. The robotic surgeries primarily include oncosurgeries, but they are also including, they include the gynecological surgeries. Not only that, we also got an advanced robotic system for knee transplant that is also being used. So there are multiple benefits of using the Da Vinci system, which is the only FDA approved robotic system in the world, and that we are proud to have. The ICU activation protocol is unique for Kamalnayan Bajaj Hospital because we have got advanced hemodynamic monitoring, we have got advanced ventilation and CRRT. Just to reiterate that Kamalnayan Bajaj has its own CRRT, thanks to Dr. George sir for making this available to the hospital. And we have got the ultimate safety net in terms of ECMO. So I would like to point out here that one of our patients who was successfully treated with ECMO went the first successful lung transplant of the region. So we are also working that next lung transplant would happen in our own premises. That's our next vision. And clinical triggers, if you see, it is deployed for cardiogenic shock, severe ARDS, pneumonia. ECMO machine is the only, most advanced, only ECMO machine working in this region. The cutting edge diagnostic imaging, you know, we have got 384 CT scan machine. 3 Tesla MRI, advanced niche diagnostics in terms of advanced mammography, level 1 sleep lab with inbuilt video EEG for complex neurological sleep disorders. That's a current scenario. We have got a multidisciplinary committee team and the complete transplant ecosystem. So we have done heart transplant and the only center which has done heart and liver transplant parallelly in one patient. We have done more than 1,500 successful kidney transplants. And as I mentioned, we have one of our patients underwent lung transplant. We are planning to do intestine transplant. We have got a license to do lung and pancreas transplant. And we are awaiting actually one patient who will simultaneously undergo kidney transplant and pancreas transplant, mostly a type 1 diabetic patient. So we are working on that. We have got a highly successful. Recently, what we have started is a fetal medicine department. Now, many of the installations in Kamalnayan Bajaj Hospital are for the first time in India. So the USG machine, which is used for fetal medicine, is the first installation in India, which has got the maximum clarity. And we have got advanced nuclear medicine diagnostics, which we already have. Now, we have got a take to outcome diagnostic metrics. If you see, these are the ECMO, PSMA, CRRT, all those I have already discussed. Another important aspect, so as Dr. Yogesh, my close friend, just mentioned that Maitri Divas hai, today is a friendship day. So Kamalnayan Bajaj Hospital believes in collaboration. So we have got so many tie-ups with industries, corporate schools, colleges, government institutes, other hospitals. We believe in collaboration. We do not believe in competition. That's again a vision of our CEO, sir. So we want everybody to be together to improve the community overall as a health of the community. That's the vision of Kamalnayan Bajaj Hospital. So we have got advanced research synergy. We have got tie-up with medical hospitals and collaborations. Not only that, with his vision, now we are ready for the next generation industrial revolution that is happening in Chhatrapati Sambhajinagar. We are prepared to cater to the healthcare needs of the new industries. Just to tell you that we are already on the panel of Toyota, JSW, all the new upcoming industries. We have got a Japanese desk in-house so that one Japanese translator is sitting 9 to 5 and we are daily catering few Japanese patients. We have also been tied up with Australian High Commissioner. So any Australian patient coming to Sambhajinagar, the preferred healthcare partner would be Kamalnayan Bajaj. So these all things have been moving up and we are really working very hard. So we have got more than 200 strategic healthcare partnerships across corporates, industries, school, colleges and industries. And what we also very meticulously, we ensure that all our treatment modalities are complying to the national and international guidelines. We have got a monitoring system to ensure all the treatment which is instituted for our patients is within the framework of those national and international guidelines. We are ISO certified, NABH and NABL certified. We are a QCI winner. We ensure that everything, and environmental stewardship also we focus on. So you can see these community-related activities. We have got a Heal School program. So we have got tie-up with multiple schools. In fact, many schools have now Kamalnayan Bajaj Health Center in-house, so that our staff sits in there. They perform their duty. Our pediatricians attend the parent-teacher meeting of the schools. So this is a vision to improve the future of our country, the future of our region. So there are robust academic ecosystems. We have got almost 12 departments, 12 subjects in which DNB programs have been successfully done with able leadership of my colleague Dr. Milind Vaishnav, who is heading that. But all other partnerships we are doing many of the things. And clinical achievements would be, as I mentioned, we have got a quality award, NABH, NABL accreditation, and all those things. So now coming to the future, so Kamalnayan Bajaj is pioneering for the future. So you can see that from 300 beds, we will be soon migrating to 600 beds. So with the vision of our CEO, sir, we are already started building our new hospital, so it will be ready in the next 3 years. So soon we'll be catering to 600 bed hospital. So then we'll be having next generation oncology and diagnostics. This is another very important aspects. So currently we are installing and commissioning the India's first digital PET-CT machine, which has got most advanced early cancer detection feasibility, and that would be functional within a month's time. So maybe latest by 15th of September it would be functional, and this will be the first installation in India to have the most advanced. It's a digital AI-enabled PET-CT machine. The installation is on way. So that is one of the important. So our focus of the work of what Kamalnayan Bajaj is doing, the center of our work is our patients. It's all patient-centric. So we focus on education, research, and clinical care. So that is what we are already focusing on. So that's why Kamalnayan Bajaj Hospital, it's a most ethical and transparent organization, and we position ourselves as the most advanced quaternary care unit, which has got exact diagnostics, post-acute rehabilitation and ethics, extreme intervention, and unyielding life support by way of having ECMO, CRRT. That's why we become the ultimate referral partner for anybody, any healthcare practitioner in our region, and not only in our region, to anywhere else. This is the last slide of my presentation. So I'm here very proud to say that NABH and Quality Council of India have tied up with Kamalnayan Bajaj Hospital to host a program on digital NABH accreditation system. That is on 5th of August. I have already shared the link to register for this conference. Would request all of you to be a part of this journey in which Kamalnayan Bajaj Hospital would be hosting this program along with Quality Council of India, and we'll be discussing about the newer modalities of digital health, artificial intelligence, and the importance of digital health accreditation, because we are the first hospital in this region. Also, Kamalnayan Bajaj Hospital is the first hospital to be accredited as Digital Mitra. That means we can help other institutes to get in the digital accreditation. So we request all of you to be a part of this wonderful program on 5th of August. Registration of free of cost, and more than 2 members also from each hospital are welcome to come. It's just a 3 hours program from 3 to 5 or 3 to 6, and that would be hosted in Kamalnayan Bajaj Hospital. Once again, thank you very much for attending this session, and I thank the organizer for giving me this opportunity to speak. Thank you very much.
Thank you, sir, for your valuable information. It is my privilege and honor to invite today's CME Chief Guest, Chief Executive Officer, Kamalnayan Bajaj Hospital and Nursing College, Chhatrapati Sambhajinagar, Dr. George Fernandez, sir, for the speech.
First of all, a very good afternoon to all of you all. It's a privilege to stand before this distinguished gathering of nephrologists, physicians, and healthcare professionals as we open KB NEPHROCON 2026, a conference dedicated to modern extracorporeal therapies, their evidence, their application, and where they are taking us next. At Kamalnayan Bajaj Hospital, we have always believed that quaternary care is not just about the complexity of what we treat, but about the depth of collaboration behind it. Today's program, spanning hemodialysis, HDF, CRRT, hemoabsorption, and transplant navigation, is a reflection of exactly that. Clinicians coming together across institutions to sharpen the science that keeps our patients alive and well. This conference sits naturally within the philosophy which we hold at Kamalnayan Bajaj Hospital, that care must be preventable, promotional, predictable, and curable. Nephrology, perhaps more than most specialties, lives at that intersection of all four. The therapies we will discuss today don't just treat kidney failure. They anticipate it, manage it, and in many cases, transform its trajectory for the patient. I want to thank the Department of Nephrology under the leadership of Dr. Samir and our organization team and the Physician Association of Chhatrapati Sambhajinagar for bringing together such an outstanding faculty for this CPD. To our speakers and chairperson, your willingness to share the real-world experiences is what makes days like this extremely valuable for all of us, and the credit goes to you all. To every delegate here, please engage, question, and take back something that changes how you practice on Monday morning. That ultimately is the measure of the conference that you are in, and so that it is well spent. I wish you all a very productive and insightful KB NEPHROCON 2026. Thank you.
Thank you so much, sir. Now we are forwarding to next session for HDF workshop.
Hello.
Hello everyone. Very good afternoon everyone. So my name is Solomon Kame. I'm a clinical manager in Freshness Medical Care. So as today we had a good sessions of HDF and all the modalities. So as Dr. Sailesh Kakade sir and Dr. Manan Doshi sir had a session on online HDF. So this is our Freshness Medical Care 5008S HDF machine. So I would like to request everyone, if it is possible, to come closer if you want to see closerly the features and all the things, or it is fine. Okay, thank you so much. So this is our Monty screen. So here we can adjust all the flows and your parameters. So in upside you can see there is the status bar. So here we can see the which modality is right now working. Like right now it is in the standby mode. Here it is. Here we can see the status of the machine. Here is software, cleaning status, device information, calibration, and network. The most important thing is device cleaning status. In cleaning status, we do every before every treatment we need to give hot disinfection, or end of the session we need to give the hot disinfection, and after we can do the rinse, and we can say see here the date before. We can see the status of the in what last program, like when we have given the disinfection. Similarly, this is the parking alarm. So if in ICU or in department actually during session, if the alarm is not reset, we need to go in the parking and we need to reset the alarm here. Similarly, information, which alarm has been came. So basically we can see the information of the previous alarm or the alarm we have seen. This is for heparin. This is for the treatment which we have performed. And last 3 treatment we can see. This is the main part we can see, like if you want to see how much convective volume we have heard about today's session, like convective volume we should reach. So in this we can see the convective volume of this. Here it is for the blood pump. The minimum in HDF, our blood flow is we can keep 0 and maximum is 600 ml per minute. So here we can adjust the blood flows. Secondly, here we can see the UF. If we are initiating the patient, here is the green signal will become. So this is for UF. And this is the main key features of this our 5008S machine is the emergency button. So when we see in sudden complication to the patients, if patient is going in the hypotension, what we do stop the UF, reduce the blood flow, give the bolus, check the BP. In this button, we can check, means by clicking this button, we can check all the 4 parameters we can do by this clicking the button. Similarly, BP curve. This has an automatic BP curve machine, so we can attach this, and we can take readings half an hourly or 1 hourly as per your requirement. So these are the features. So this is heparin pump, blood pump, substitution pump. This is venous pressure. air detector, and these are the most important thing, blood temperature monitor and blood volume axis monitor. And these are substitute and these are re-sport. So for HDF, we require ultra pure dialysis fluid. So how we can start the patient? So basically we required a good quality, water quality. If we don't have a water quality, we couldn't start the HDF. And as per ISO 23500, we need to have a endotoxin level below 0.03 and CFE level 0.01. So if we are not having a good water quality, we cannot start the HDF therapy. To start HDF, we need a high flux dialyzer. So this is our FX600 Cordex dialyzer, which have 1.6 surface area, and it is designed for the HDF therapy. So why this filter is specially designed for HDF? So while we are giving a substitute fluid during the session, so what we are doing is throwing the water pressure into the dialyzer. So we are removing by removing hydrostatic pressure. So this filter is designed, we have various filters also, dialyzers like FX800, FX1000, and also FX high flux dialyzer like FX60, FX80, and also we having HF60, HF80. So these are the dialyzers. So the major key features of this machine is auto surplus and EcoFlow. So as we can see, here is a 100 auto flow, that is a dialysate flow. And while we are doing priming, we doesn't require NS, like for priming or termination, we doesn't require NS because we are having a ultra pure dialysate fluid. So it can be used for priming to start the patient, and for termination, like we are using NS. So we doesn't require saline for this. We use this as a ultra pure dialysis fluid. In this we can see the prescribed sodium, we can adjust that. Prescribed bicarb, we can adjust that, depend on the patient. Also here we required a buyback. The buyback is must for the patient because it is a sterile and it can be used for the patient. So major key feature is while we are doing priming, like we have 4000 ATS machines or other HD machines. So basically उसमें क्या होता है कि जो dialysis machine के लिए हम flow set करते हैं, जैसे कि generally 300, 500, 800. तो HDF machine के लिए key feature क्या है कि जो हम flow rate जो ड्यूरिंग प्राइमिंग में हम क्या करते हैं, जो डायलिसिस फ्लो रहेगा वो 100 पे रहेगा. उससे क्या होता है कि जो डायलिसिस जो कंज्यूमेबल है वो बायबैग है और जो कैन का जो कंज्यूमेबल है वो रिड्यूस हो जाएगा. तो इसमें जब तक हम पेशेंट कनेक्ट नहीं करेंगे तब तक हम जो फ्लो रेट है वो 100 बाय डिफॉल्ट ही रहेगा. जब हम कनेक्ट करेंगे, दिस इज HDF फैक्टर. HDF फैक्टर इज फॉर इफ वी आर इंक्रीजिंग ब्लड फ्लो. अगर हम ब्लड फ्लो इंक्रीज कर रहे हैं, फॉर एग्जाम्पल 1.2 अभी नॉर्मल रखा है यहाँ पे, जैसे हम ब्लड फ्लो इंक्रीज करेंगे पेशेंट कनेक्शन के टाइम, तो इट विल डबल अप द डायलिसिस. Auto flow is nothing but a dialysate flow. We are increasing by HDF factor. So here we can assess the patient by the temperature. अगर पेशेंट कई बार रहते हैं कि हाइपोटेंशंस में रहता है, हाइपोटेंशंस के कारण कई बार हमको टेम्परेचर रिड्यूस करके पेशेंट्स को करेक्शंस कर सकते हैं. तो यहाँ पे हम टेम्परेचर एडजस्ट कर सकते हैं. The major features is ऑनलाइन मॉडलिटी पे जाएंगे तो हम ट्रीटमेंट मोड सिलेक्शन कर सकते हैं. तो यहाँ पे ट्रीटमेंट मॉडलिटीज है HDF पोस्ट डायल्यूशन, HDF प्री डायल्यूशन, HDF पोस्ट डायल्यूशन, HF. तो HDF मतलब हीमोडायफिल्ट्रेशन, HD हीमोडायलिसिस. तो इधर प्री और पोस्ट हम कब करते हैं, जब हम फॉर एग्जाम्पल हम एंटीकोगुलेशन अगर कुछ यूज नहीं कर रहे पेशेंट के लिए, तो वो टाइम पे हम प्री डायल्यूशन कर सकते हैं. अगर हम एंटीकोगुलेशन हिपैरिन यूज कर रहे हैं तो वो टाइम पे हम पोस्ट डायल्यूशन यूज कर सकते हैं. तो एट अ टाइम इन बिटवीन आपको अगर चेंजेस करने हैं कि एंटीकोगुलेशन अगर आपको बंद करना है तो आप डायरेक्टली प्री डायल्यूशन पे डायरेक्टली स्विच कर सकते हैं. दिस मशीन long for 24 hours this runs, and we can do normal HDF also and online HDF. And online HDF is important for the patient who are in OPD patients, like we have seen this case studies today. So here is auto sub plus button. So auto sub मतलब क्या है कि auto sub क्या करता है, जितना required जो substitute से जो doses जा रहा है, तो जितना required है वो machine automatically patient के लिए produce करेगा. अगर हमको eco flow में जाना है for example, तो eco flow में हम manually यहाँ पे set कर सकते हैं substitute doses as per requirement. But I will suggest to go with the auto sub mode. ऑटो सब मोड की वजह से क्या होता है कि जितना रिक्वायर्ड पेशेंट के लिए जो सब्स्टिट्यूट फ्लूइड है कन्वेक्टिव वॉल्यूम रिक्वायर्ड है उतना जाएगा. ठीक है, तो बेसिक है कि यूजर फ्रेंडली है मशीन. अगर नए टेक्नीशियंस है तो यहाँ पे ग्राफ के थ्रू हम एज अ ग्राफ रिक्वायरमेंट हम फॉलो कर सकते हैं और इट इज इजी टू हैंडल. यहाँ पे हम एचडी मोड में रखेंगे तो एचडी में देख सकते हैं कि यहाँ पे ब्लड पंप है और यहाँ पे सब्स्टिट्यूट पंप नहीं दिखाई दे रहा है. तो इट विल गाइड टू द टेक्नीशियन, इट विल बी इजी फॉर देम टू स्टार्ट इनिशिएट द थेरेपी. तो इसमें और एक है कि रिंस, इफ यू आर यूजिंग अ सिंगल यूज डायलाइजर वी डजंट रिक्वायर टू टर्न द फिल्टर. तो फिल्टर हम टर्न नहीं करने की जरूरत, यहाँ से एयर ऑटोमेटिकली खुद मशीन ही निकालेगी. तो टेक्नीशियन का वर्कफ्लो बहुत ईजी हो जाएगा. और वर्कफ्लो ऐसा है कि पेशेंट्स को जो रिक्वायर्ड है उतने डोसेस ऑटोमेटिकली जाएंगे. जैसे मैंने बताया कि डायलिसिस में अभी प्राइमिंग मोड में है तो 100 ब्लड फ्लो है. जैसे हम थेरेपी चालू करेंगे, फॉर एग्जांपल हम 350 ब्लड फ्लो रख रहे तो 650 तक जो डायलिसिस फ्लो है एज पर रिक्वायरमेंट जाएगा. तो इसके लिए मेजर एचडीएफ पे जो पेशेंट्स रहते हैं तो मेजरली रिक्वायरमेंट क्या है कि जो एक्सेस फ्लो, वी सजेस्ट टू टेक पेशेंट्स ऑन एवीएफ फिस्टुला we can maximum the blood flow, we can increase the maximum blood flow for them, so it will give the more convective volume. तो यहाँ पे basically जो key features हमारे AutoSub plus EcoFlow, it will also reduce your consumptions of NS and also electricity, and also we require water. So in HD we are using, means we are consuming total 120 liters of RO water, and for this we require only 90 liters of RO water. So in here we have a specific two filters that is called DISEF. दो DISEF filter है. जो पहला DISEF का filter का काम है जो water की जो impurities है उसमें का निकाल लेना. जो second DISEF है जो वो substitute के लिए है, जो substitute हम patient के body में infuse कर रहे हैं तो वो हम दूसरे डायसेफ से पेशेंट में प्रोड्यूस करते हैं. तो मेजरली सब्स्टिट्यूट इसके लिए अल्ट्रा प्योर डायलिसिस वाटर बहुत इंपॉर्टेंट रोल करता है, क्योंकि अगर वाटर में कुछ कंटेमिनेशन रहेंगे तो पेशेंट्स को रिएक्शंस आएंगे. तो इसीलिए मोस्ट इंपॉर्टेंट थिंग कि वाटर क्वालिटी है वो अच्छी रहनी चाहिए. इसमें हम ओसीएम डेटा फिल कर सकते हैं KT/V के लिए. तो यहाँ पे हम KT/V लगा सकते हैं. जो 4000 ATS में है, जो डायलिसिस मशीन्स में है, जो KT/V हम अचीव करते हैं वो लेसर रहता है. लेकिन इसमें हम एडिशनली, क्योंकि हमारे पास हाई फ्लक्स डायलाइजर है और उसकी वजह से जो KT/V है उसे भी अच्छे से अचीव कर सकते हैं. इसमें और एक है कि रिसर्कुलेशन मोड. कई बार होता है कि फिस्टुला के प्रिक सेम डायरेक्शन और क्लोजर रहते हैं तो उसकी वजह से रीसर्कुलेशन होने के चांसेस रहते हैं. अगर रीसर्कुलेशन मैक्सिमम हो रहा है, फॉर एग्जांपल 30 to 35 और 40% अगर हो रहा है तो पेशेंट को क्लियरेंस अच्छे से नहीं मिल रहा है. तो वो टाइम पे हमको मशीन भी अलार्म भी देते हैं कि मशीन योर ब्लड इज रिसर्कुलेटिंग, सो वी कैन सी इन दिस आवरली. तो 4 घंटे में 1-1 घंटे बाद वो अलार्म आता है रिसर्कुलेशन का कि कितना रिसर्कुलेशन हो रहा है. जनरली हम देखते हैं कि जो कैथेटर के जो पेशेंट्स रहते हैं 15 to 20% रिसर्कुलेशन होता ही है, और जो एवीएफ फिस्टुला के 10 to 15% रिसर्कुलेशन होता ही रहता है. लेकिन अबव अगर जा रहा है 35 के अबव या 30 के अबव जा रहा है तो वी नीड टू लुक आफ्टर दिस, बिकॉज वी आर नॉट गिविंग द एप्रोप्रिएट थेरेपी टू द पेशेंट्स. So here in UF menu, we can adjust the UF. For example, I'll setting up 2 liters, time 6 hours. So as I told, it can be go to 24 hours sessions. And we can also manage UF profiling. Okay, any questions? Anyone? Okay, okay, thank you so much.
Thank you so much, everyone.
Now we are forwarding to our next scientific session. It is my pleasure to introduce our next speaker for the session, Dr. Vinod Gosavi sir, physician intensivist of Kamalnayan Bajaj Hospital. May I also request respected chairpersons for the session, Dr. Sharad Biradar sir, senior physician and intensivist at Aster DM Sigma Hospital, Chhatrapati Sambhajinagar. Dr. Wajid Moghal sir, consultant nephrologist at Galaxy Hospital, Chhatrapati Sambhajinagar. Dr. Geetesh Dalvi sir, senior physician intensivist at Gajanan Hospital, Chhatrapati Sambhajinagar. May I request it to all of you, please grace the dais.
Hello. After the inauguration function and pre-lunch session, I think Dr. Vinod sir will enlighten us on this particular topic, which is cytokine storm, myth, reality, and extracorporeal therapy. We, as an intensivist, heard about this particular cytokine storm very often. And after the post-COVID era, somehow we are missing this particular term. So, without much delay, I request Dr. Vinod sir to start and give us the practical inputs regarding how to manage this cytokine storm. Over to you, sir.
Thank you. Thank you, chairpersons. First of all, thank you to the organizers that they have given me an opportunity for this CME. Now, as we know, the cytokine storm 5 years back, 5 to 6 years back, we have gone all through this, and it was very pandemic situation. So basically, I'm just touching the realities and just try to enlighten some take-home messages. Basically, we know that the sepsis definition has already been changed. That is a dysregulated immune response to an infection. So, the father of medicine, as we saw, William Osler, says that sepsis is the body's own battle. In sepsis, except on few occasions, the patient appears to die from the body's response to infection rather from it. And this forms the fundamental concept to understand the pathogenesis of cytokine storm syndrome. Lewis Thomas, in NEGM it was published, that body's primary response to infection and injury is uncontrolled hyperinflammation. So the microorganisms that seem to have it in for us turn out to be rather more like bystanders. It is our response to their presence first that makes the disease. Our arsenals for fighting off the bacteria are so powerful that we are more in danger from them than the invaders. So it's a myth or reality. The term cytokine syndrome or cytokine storm entered the mainstream medicine during 2003 SARS outbreak and exploded during COVID-19, but is a distinct syndrome or a loosely applied label. It's a myth, if you say, but a uniform catastrophic immune explosion requiring immediate suppression in all patients. This is wrong. Basically, it's an heterogeneous disease. It's not an uniform that you can apply the same to all the patients. So every patient is different and every body reacts to that infection differently, as we have experienced in COVID. So in reality, it's a heterogeneous hyperinflammatory state, context-dependent, variable in magnitude, and distinct from sepsis. This is a nice article in NEGM which has thrown an enlightenment on cytokine storm. So defining cytokine storm syndrome is basically Feigenbaum and June in NEGM has defined as life-threatening systemic inflammatory syndrome characterized by elevating circulating cytokines and multi-organ dysfunction triggered by an immune activating agent. As you know that there is a thin line between a normal response and a dysregulated response, and which is always a blurry when it is in severe infections. So triggers are the cytokines, basically, the triggers are the infections or CAR cell therapy or sometimes in autoimmune diseases and COVID-19. And the key cytokines involved are interleukin 1, beta, interleukin 6, interleukin 18, interferon gamma, TNF alpha, and GNCSFs. So what is defining is basically elevating circulating cytokine levels, acute systemic inflammatory symptoms, and thirdly is secondary organ dysfunction, either due to inflammation because of an infection if the pathogen is present, or the cytokine-driven organ dysfunction if the pathogen is not present. So if you've seen that many of the inflammatory states are seen in infections and sometimes immunomodulating therapies, autoimmune diseases, and HLH, as we have experienced. So this is a very important slide. As we know that there is a trigger, there is always a pro-inflammatory state and anti-inflammatory state. So the battle between these decides where the patients will going to respond or not respond. So pro-inflammatory cytokines are TNF alpha, interleukin 1, interleukin 6, interleukin 12, interferon gamma and MIF. And anti-inflammatory cytokines are IL-10, TGF-6 and IL-4. So basically, where the response will stop, either the pro-inflammatory cytokines will overwhelm the anti-inflammatory state, or the anti-inflammatory chemicals or cytokines will suppress the pro-inflammatory states, and that decides your patient's fate. So spectrum of CSS, that is cytokine storm syndrome, basically infections are the commonest causes, malignancy-related CAR cell therapy, HLH, autoimmune diseases, macrophage activation syndrome, as we know that this is well versed, and sometimes systemic lupus. Iatrogenic causes are sometimes the biological agents which are used to target certain therapies. They can also induce the hyperinflammatory states. And genetic causes are HLH and primary immunodeficiency. So recognizing underlying etiology is critical. The treatment for macrophage activation syndrome related CSS differs substantially from infection triggered or CAR related CSS. The one size fits all cytokine blockade is insufficient. So we have to see each and every patient from different angle. Clinical presentation is, wide range of clinical and laboratory abnormalities can be seen with organ dysfunctions and circulating cytokines. The pathophysiological features, this is very important. If you see, basically, there are triggers, potential triggers and initiators, and there are driver cells, and there is immune hyperactivation, and there is also a negative regulation, basically feedback. When it goes inadequate, this cytokine storm starts overwhelming the patients. So basically, it's an inappropriate recognition or ineffective recognition with immune invasion, or an inflammatory response to an exaggerated effector response and cytokine production, or an ineffective response to an immune evasion or failure to terminate that homeostasis or return to homeostasis. So this forms the pathophysiological basis of cytokine storm. So this is a pictorial diagram. So what are the key cytokines involved in cytokine storm? Basically, they are interferon 1 beta. The main source are activation of macrophages and monocytes, and the role in storm is producing an pro-inflammatory state, the fever and organ damage, and the key mechanism is inflammation activation, targeted by the IL-1 receptor antagonists. Second key cytokine is IL-6. I am not going to details. The main source are macrophages, T cells, endothelial cells, and it produces an acute phase response in the storm. But the key mechanism is JAK pathway, and these are targeted by tocilizumab. Interferon gamma, again the involvement of T cells and NK cells, macrophage activation which perpetuates to HLH, and the key mechanism is upregulating MSC, which macrophage activations, and they are targeted by JAK inhibitors. TNF alpha, again the main source is activation of macrophages and T cells, and the role in storm is systemic inflammation, cell death and shock, and they are key mechanism NF-KB pathway. Infliximab is targeted by these cytokines. And last, the GM-CSF, the main source is T cells and macrophages. Myeloid cell activation, lung injury is role in the storm, enhances the macrophage survival or function, and they are targeted by anti-GM-CSF. So this is important. Basically, what are the parameters we monitor in cytokine storm? They are also elevated in sepsis, ARDS, and again cytokine storm. But if you see the third column, the parameters which are elevated are markedly high. The serum ferritin, the IL-6 levels, the NK cell functions, if we are monitoring, they are severely impaired, and hemophagocytosis, which are present on bone marrow biopsy. And H score is really, really high. And what is the treatment modality is basically, when in sepsis you are having adequate standard care with source control antibiotics, ARDS, a good lung protective ventilation, and in cytokine storm you have to use the immune modulating drugs which targets the cytokines. So cytokine in COVID-19 we have seen, it's not a controversy. Most of the patients we have seen that the patient has the thin build patient in COVID had a severe score and they went home easily without any oxygen therapy or some form of oxygen therapy. And the patient, the guys who are healthy, working in gym regularly, had a bad score, definitely had succumbed. So these are the variety of our immunological response, that every patient differs to an infection. So this was a study which was done in 2000, published in 2007. KLM has demonstrated way back that they have studied around 4,000 patients of community-acquired pneumonia, and they have studied IL-6 levels and IL-10 levels. Both they were viral patients and bacterial patients, and they have found that when the levels were very high, they are correlated with the mortality. So the mortality was high when the circulating levels of cytochrome was, the cytochromes IL-6 and IL-10 was high. So in COVID-19, there is an hyperinflammation, and as from the studies, the evidence says that elevated cytokines were there. In severe COVID-19 shows markedly high IL-6, IL-10, TNF-alpha, and ferritin, but lower than the classic HLH. So there is a difference between this immune dysregulation followed by lymphopenia, macrophage activation, and impaired INF response. And what we have seen that in recovery and rehab travel, the 28 mortality benefit in hospital patients requiring oxygen therapy when we use tocilizumab. So this was evident that even in COVID, the trials have shown there was some mortality reduction with IL-6 inhibitors, and the standard recovery trial shows that the steroids, which are immunomodulating drugs, definitely the mortality reduction was high when the patient was mechanically ventilated patients with standard of care. The organ impact in COVID was lungs, kidneys, heart, and vasculature. Endothelial injury is a hallmark of severe disease, and the co-barrier study shown that when you have and use JAK inhibitors in patients, there was some mortality benefit, but that was not significant. So in cytokine terms, definitely exists. There are different set of cytokines, and we have to give the standard of care, and then after standard of care, if the cytokines or the IL-6 blockade or immunomodulation is indicated, we can use. Now the important part is extracorporeal therapy in such type of syndromes, the CSS. If cytokines drive the organ damage, can we remove them from our body or the bloodstream? And this forms the central hypothesis behind extracorporeal cytokine therapy, and the evidence is rapidly evolving. If you see this slide, the toxic level of cytokines above certain levels, that determines the cytokine storm syndrome. So should we cut down that toxic level so that the patient will respond? This is a glance, different type of modalities of extracorporeal therapy is available. Sorry. So at all extracorporeal therapy modalities at a glance, first is high volume hemofiltrations. There was a study which shows that high volume 70 ml per kg versus 30 ml per kg high volume hemofiltration was done, and the study shows that there was no difference when you use 70 ml per kg or 30 ml per kg, which was used in, and there was a modest difference. This study was done in sepsis patients. Hemoadsorption, that is cytosop we usually was, the polymer beaded adsorption cartridge removes the IL-6, the IL-1 beta, TNF-alpha, non-selective. So this is a non-selective hemoadsorption. There are selective ones and there are non-selective ones. So what we are targeting, we have to define first. Therapeutic plasma exchange, as we know, that definitely as an immunomodulating therapy, it removes large molecular weight mediators from the, including cytokines, DAMs, and complements, and it has been well documented, benefited in TTP, MAS, and refractory sepsis. The third modality is plasma filtration coupled with adsorptions, and this combines, and the patients are mostly from the septic shock where there is an elevated hyperinflammation. So what is the principles of extracorporeal cytokine adsorption is basically removing the circulating cytokines, endotoxins, DAMs, PAMs in non-pharmacological and non-targeted manner. There are no clinical biomarkers that this cutoff is used to use this therapy, but definitely the clinical, the biochemical picture has to be used to use extracorporeal therapy, not only biochemical matters. Clinically, you have to decide that this patient is definitely in a storm. So two more absorption strategies. Non-selective is basically cytosops, which removes broad spectrum molecular size cytokines, and selective ones are toracmycin and syrup. So by and large, these are selective and non-selective ones, but remember that when you are using extracorporeal therapies, you are also targeting your different molecules of vitamins, minerals, nutrients, antibiotics. So you have to be cautious regarding this. What is the clinical evidence? What the data actually shows? The mortality questions. In a 2022 meta-analysis, more than 10 RCTs have shown that there was conflicting results and there was no consistent mortality benefit, but there was large confidence interval, and which shows that there is a confound pool analysis. So by and large, we have to select your patients and use. Second, in 2025, it was published in Intensive Care Medicine, 175 septic shock patients, there was a mortality difference. And this treatment intensity was not timing, but you have to choose your patients. So there was some reduction in mortality in this 175 patients. Toramycin, there were 3 studies, UFAS, Abdomix, and Euphyrids. So by and large, when there is an intra-abdominal infection, the endotoxemia is very high. You have to remove that endotoxins so that the survival benefit is targeted. In UFAS trial, there was a reduction in mortality. It was a significant, but it was a single census study. In Abdomix study, there was some mortality benefit, but a large trial was shown, Euphyrids, that demonstrated that there was no significant mortality benefit when you are using this in abdominal sepsis. Oxyris, again, meta-analysis suggested that there was a 20-day mortality reduction, but high-quality evidence remains limited. So by and large, there is some evidence to remove this cytokine, and the important thing was that there was hemodynamic improvement, reduced vasopressor requirement, cytostop, using cytostop, toramycin, or oxyris, suggesting improved vascular tone and tissue perfusion. Organ function markers were included, including the involvement of improvement in renal, hepatic, and PO2-FIO2 markers. So when you are using this extracorporeal therapy, you think as a last resort, but the patient is sick, you are using different modalities, standard of care, and with this now, because there are a lot of intervention which reduces the mortality, there is source control, appropriate antibiotics, and after this, when you do this, by using all these modalities, it's very difficult to point out that this will definitely reduce your mortality. And by science, you have to demonstrate that the p-value is less than 0.1. So, if you choose your patients wisely, you can use cytokine removal therapy in patients. So what are the device comparison? Choosing the right tool. Cytosops is basically a non-selective adsorption using removing 5 to 50 kilodalton molecules. Targeting cytokines are IL-60, NF-alpha, and 1-alpha, IL-1 beta. The circuit used are CRRT, and standalone. So key indication is basically broad cytokine storm and septic shock. Antibiotic absorption, definitely you have to monitor the levels. Toramycins are basically a polymyxin B. Endotoxin removal. So this was demonstrated in UFAS and Euphyrids trial. So by and large, gram-negative sepsis with abdominal infections, this has been used. Then oxyris has been used with moderate level of evidence. Then the HA33T and 380, the filters were used with some evidence. Just a minute. So what are the limitation, controversy, and unresolved questions? Non-selective removal, antibiotic pharmacokinetics you have to think, and what we don't measure are really the tissue burden of the cytokines rather than we are measuring and circulating blood levels. Therapeutic plasma exchange, last child. This is one of the modality which has definitely shown a benefit in different conditions, and strong evidence has been found in TTP and MAS related CSS. These have been used in sepsis and septic shock with small RCTs were there with some hemodynamic monitoring, and some patients of COVID has been targeted with this therapy, and there was some cytokine reduction and clinical stabilization. And in pediatric patients, definitely there was a role with multi-inflammatory system syndrome. The TPA has been as a rescue refractory cases. So extracorporeal therapy in COVID-19 is our best position as a rescue strategy after steroids and tocilizumab in patients with having AKI, multi-organ failure, or hemodynamic instability. So when to initiate the therapy? Severe septic shock, refractory resuscitation with high inflammatory burden, vasopressor dependent multi-organ dysfunction, and CRRT already indicated, use of oxyris as a first choice. So what are the key messages? CSS is real, but it is an heterogeneous. Diagnosis requires identifying the trigger. Not all hyperinflammation is cytokine storm. COVID-19 confirmed the clinical prevalence. IL-6 blockade and steroids are now standard, and extracorporeal therapy remains adjunctive. Therapeutic plasma action has the strongest extracorporeal evidence in TTP, mass, and refractory shock. And RCT evidence for heme absorption remains elusive. Still, the data is to be needed to confirm that this is definitely a mortality difference-making tool. So, thank you.
Thank you, sir, for insightful talk and sharing clinical evidence and practical aspect of the topic. If any questions, we can take if time permits.
At the end of your talk, I must say, thank you very much for bringing this particular term from the hypothetical term to the reality after showing these trials. We all have witnessed it, these patients during COVID pandemic. Still, few of the patients who present as a extended COVID syndrome may present with such symptoms, and the clinical judgment is the most important thing to diagnose and treat these patients. Thank you very much, sir.
Thank you.
Any questions? Thank you.
Thank you.
Thank you, sir, for your valuable insights. I request respected chairpersons to felicitate our speaker, Dr. Vinod Gosavi, sir. Now, I request respected Dr. Anand Nikaje, sir, to felicitate chairpersons for the session. Thank you, sir. Now, our next scientific session speaker, Dr. Shrikant Sahasrabuddhe, sir, pulmonologist and intensivist at Kamalnayan Bajaj Hospital, Chhatrapati, Sambhajinagar. May I also request respected chairpersons for the session, Dr. Yogesh Lakas, sir, chairperson of ISCCM and senior physician and intensivist at Noor Hospital, Chhatrapati, Sambhajinagar. Dr. Sachin Solanke, sir, Professor Medicine at Noor Hospital from Badnapur. Dr. Manav Pagare, sir, Senior Physician and Intensivist at Shraddha Hospital, Chhatrapati, Sambhajinagar.
It's really privileged to chair the session of Dr. Shrikant Sahasrabuddhe, a good friend of us, and a very important topic he'll be delivering. And as everyone knows that he is a national faculty, he is a past chairman of the ISSM Chhatrapati Sambhajinagar branch. Then he is a president-elect Indian Society of Parenteral and Enteral Nutrition, many publications to his credit. And the very important talk he'll be delivering now, integrating hemoadsorption and ECMO, following a session of cytokine storm, a very important part he is be talking on. Over to Dr. Shrikant Sahasrabudhe.
Thank you so much, respected chairpersons, for the kind introduction. I am aware that we are slightly running out of the time and you all are waiting for the next very important session, that is lunch, I suppose, which is preponed. But I'll make sure to give some kind of message to you from whatever I could understand and give some take-home messages at this point in time. And in the next about 18 or 19 minutes, I will embark on this topic, which is the integration of heme adsorption and ECMO. And my very good friend, Vinod, just delivered a fantastic talk on cytokine storm, and there would be a lot of overlap between the two talks. So I'm sure you will be with me. This is my one of the favorite slide, which I start with, but probably I don't need this slide here in my own city, because people are usually, when they pronounce my surname, it is very difficult. So, I show them this photo and then it becomes easy for them to remember the Viru Sahasrabudhe from Three Idiots. So, let us start the talk. So, as we know that the cytokine storm, it is the storm which actually affects the important organs in the body like heart, lungs and kidneys, and it is a catastrophe, especially when you look at the patient who are septic or the patient with ARDS or cardiogenic shock. And when I was kind of studying for this particular talk, and Samir has been very kind to give me one of the tough talks for this today's conference. So, but thanks to him so that I could read. And so as we know that cytokine storm is, the hallmark is raised IL-6, TNF-alphas and whole sorts of pro-inflammatory cytokines, which actually it's quite an overwhelming response and it affects the majority or the major organs of the body. And so here we are to actually integrate the two important extracorporeal therapies, or I would say the integration of the extracorporeal therapy with the heme adsorption, where we know that we take help of ECMO in many of these situations, and it definitely helps, but who tames the storm? And here we have a lot of villains and so many of the pro-inflammatory cytokines, and there is definite interplay of pro and anti-inflammatory cytokines as was shown in the earlier talk. So the lifeline, which we cannot ignore, and every one of us will agree that so many of the therapies, the interventions, the medications and the treatment modalities which got evolved during the COVID times. And I would remember that, before COVID, probably we would have just heard about ECMO as a, some isolated or some sporadic cases being done. But after COVID, I'm sure we must have, overwhelmed by this response, and the ECMOs which are instituted in many of the hospitals, be it a tier 2 city as well, like us. So we have a dedicated ECMO machine, Rotaflow 2 from Jettinge. So we have a VV ECMO which takes care of the respiratory failure, predominantly ARDS, severe pneumonias, and of course VA ECMO, which actually takes into account the clinical spectrums like cardiogenic shocks or eCPRs, and the ELSO registry, which registers about more than 24,000 adult respiratory distress syndrome who underwent this treatment modality. So needless to say that, it is the term that when we have an ECMO, the side effects or the adverse reactions related to the access as well as the therapy itself, you can't escape the side effects and the adverse event. Similarly, you have sick patients, so you have high mortality in these patients. So there is some unfinished business when the patient is on ECMO. So agreed that it will help, it will help the oxygenation. It will help to reverse hypoxemia. It will help to survive the patients on cardiogenic shocks who have some hemodynamic instability. But at the same time, we should not forget that these inflammatory markers which are raised in the form of IL-6, TNF-alphas, which would not be taken care of by ECMOs. So adversely or contradictorily, you have these inflammatory cytokines going up for the patients who are on extracorporeal devices, as we all know. So it will activate the complement system, it will activate the neutrophil response and the systemic inflammatory response syndrome. And there is definite gap in the form of that mechanical support may not actually translate into the immunological rescue. So the vasoplegic syndrome persists. So the patient will be vasodilated, they will be hypotensive, and you will need more and more vasopressors. So what is heme adsorption? It is the molecular vacuum cleaner. Actually, as the name suggests, it will adsorb something. That means it will bind to something. So we want all these kind of inflammatory cytokines to go away from the body. So this is what exactly and precisely heme adsorption will do. So it will, the blood through the porous styrene divinyl benzene copolymer beads will adsorb the cytokines. So the target range which is given there, and the cytosorb, which is the most studied device, which is FDA approved. And the problem here is, as you could see, it's a non-selective rebalancing. So it removes both the pro as well as anti-inflammatory mediators, and there is immunological rebalancing and not immune suppression. So this is probably the crux of the understanding which we all need to understand, that this is immunological rebalancing, because it will remove both the kind of mediators we are looking at. So what is the device landscape here? As you could see, that this is cytosorb, which is very famous. You have Oxiris. So the distinct feature about Oxiris is it has a triple action. It will remove endotoxin, it will also have cytokine adsorption and simultaneous renal replacement therapy. So this is what we need to remember about Oxiris. Toramycin is the classical polymyxin B filter, and Jafran, which is the HA380 system, which is mainly for widely used in Asia and also has been studied for VA ECMOs with cardiogenic shock. So this is what the device landscape which we need to understand. So talking about the VV ECMO plus heme adsorption. So these patients of ARDS, the hypoxemic respiratory failure, what is the evidence say? So this is a CTC register, which is the cytokine therapy in COVID-19 registry, which included about 100 patients, which was published in Critical Care 2023. And so you have Akil et al. And which was published in Journal of Clinical Medicine 2022, which was a systemic review, and it consistently showed that reduction in IL-6 and the vasopressor requirements and the fluid balance. At the same time, Lee et al. In 24 showed that there was hemodynamic stability which was enhanced, and the mortality benefit, which was rightly pointed out by Vinod, that you have an inconsistent mortality benefits in all across the studies which we will have, with barring few which we will just touch upon. Talking about COVID-19 ARDS, I think we have talked about it. This is a VV ECMO, and this is something which, the dream which we never want to see again. So you have a scenario where you have ICU admission with extreme elevations of IL-6, then you initiate a VV ECMO and hemoadsorption at about 72 hours. So that is something which is another important thing, and we have been discussing since morning that any modality, be it a SLED or hemodialysis or hemodiafiltration, the right patient at the right time is the crux of the matter, and it applies to these patients as well. So you have ECMO winning and the patient getting discharged. Talking about the VA ECMO and hemadsorption, especially in cardiogenic shocks, as you could see that this is the vicious cycle, starting with the shock state where you have a low cardiac output, ischemia, perfusion injury, culminating into SIRS and the vasoplegia with refractory shock and refractory vasodilation, and this circle continues. So we need to mitigate this cycle, and for that we need to have interruption or breaking of this inflammatory loop in the form of heme adsorption at this point in time, where you have the translation of ischemia reperfusion injury into SIRS, where heme adsorption would work, and of course the VA ECMO, which will break the hemodynamic loop. So you have a hemodynamic support as well as heme adsorption to take care of this dual problem. So it is not purely a hemodynamic problem where you have a systemic inflammation. We need to understand that, when you look at the cardiogenic shock patient, it's not only the heart, it is probably a multi-organ dysfunction, which is quite, at that particular point of time, it is concealed. And what we probably get carried away with the pressures and the numbers. So here we have a VA ECMO paradox where it restores perfusion, but it triggers SIRS, as we just now saw. So this was a meta-analysis, the heme adsorption in heart failure, which requires the mechanical cardiovascular support, and there is a significant in vasopressor requirement and IL-6 levels. So this was ECMO-SOP trial, which was published in Journal of Clinical Medicine 2023. It was a prospective randomized controlled trial where VA ECMO and a cytosop were instituted in patients of cardiogenic shock, and the primary endpoint was cytokine reduction and ECMO winning success, which was done, and the results are awaited. So this is some promising signals towards the positivity of this integration of ECMO and heme adsorption, especially in patients of cardiogenic shocks. So this is a clean ECMO trial. I'm just giving you some of the evidences which we have. So this was a landmark trial. This was a landmark randomized controlled trial published in 2025. So this was again a prospective randomized control, and the Oxiris was used. And as we remember, it is a triple advantage with Oxiris. So the primary endpoint is a VIS score reduction. VIS stands for vasoactive inotropic score. And you have these scoring systems. I don't remember, but you have so many of the vasopressors, and then you count those vasopressors, and there is a scoring system. Anything above 30, the score above 30 is bad. So you have secondary endpoints where IL-6 kinetics and ECMO winning success was noted. And the key findings was Oxiris arm showed significant VIS reduction. So this is again a clean ECMO trial which came into light in 2025 with some promising signals. So this is the clinical aspect of that as to how we integrate the circuit. As it is, we know that the ECMO is quite a complicated kind of setup where you have two cannulas. So one which comes from the patient and then goes into the ECMO circuit. And this is the integration of that particular ECMO with the heme adsorption setup. So there can be three kind of setups. One is the pre-pump addition. I'll just show you pictorially as to how it is. The another one is post-oxygenator. And the third one is the standalone, which again, in the last talk we could see that the standalone setup is there. The anticoagulation is standard is heparin infusion with a target ACT of 180 to 220, and there is no additional heparin boluses which are required. Of course, you need to be very cautious about the platelet counts, the bleeding diathesis, and the bleeding tendencies of that particular patient. So this is how the pre-pump looks, where you could see that this is the pump of the ECMO. This is coming from the patient. This is a drainage cannula. So you have the institution of the pre-pump setup before the ECMO pump, and from here the blood goes to the oxygenator, and the oxygenated blood goes back to the patient. So this is one setup which is called as the pre-pump integration. The second one is the post-oxygenator, where you could see that after the oxygenator you could see a cytosol. So this is after the oxygenator, and this is supposed to be a little better than pre-pump because it is in high pressure and there is less chances of aeration, and the deaeration is much better. And the third one is standalone, where you can see that the ECMO is going on as it is, but there is a connector here before the pump which goes to the cytosol system with a dedicated pump, then goes to the cytosol and does both the blood columns which will unite here and go back to the patient. So this is how the system looks like. So the septic shock, which is as an intensivist, that is the most important threat which we see day in and out. And this is a triple threat scenario where you have refractory shock, the patient can have ARDS requiring VV ECMO, and of course AKI and fluid overload. So this was the pooled analysis, the heme adsorption in septic shock on MCS. So there was 28% relative reduction in the VIS, or also the IL-6 reduction, and the mortality signal which tends towards the benefit, but it was underpowered. The number of patients were not very high. So when you see at the evidence of these particular modalities, it is very difficult for us to extrapolate it into our daily practice. It has to be individualized, it has to be case to case, and you cannot generalize it for all the patients. And we are proud to say that there are the Indian Society of Critical Care Medicine 2024, under the leadership of past president Dr. Yatin Mehta, who actually published this kind of consensus about the heme adsorption, which is recommended as an adjunctive therapy in septic shock patients, where IL-6 was more than 1,000, Oxyris, which was used, and it was initiated within 6 to 12 hours of ECMO cannulation. So best practice consensus, the European ECMO network, grade 2B recommendation for heme adsorption in ECMO, and antibiotic drug removal, which even my friend Neeraj talked about. The antibiotic dosing is extremely important, and it has to be documented on paper. Yes, I think I will have 2 more slides. So you have an antibiotic drug removal where you have a critical care, it's a caveat where dose adjustment and the post-cartridge administration is very important. Okay, so this is some evidence base. We talked about clean ECMO trial, the 4 meta-analysis, the CTC register. What about the surviving sepsis guideline? It actually says it suggests against the use of these particular heme adsorption. So it's a conditional recommendation at present point of time. So there is a Tigris trial, which is a RCT on polymyxin B filters, and of course the Euphrates RCT, which again we not talked about. So this is the patient selection. So ideal selection of VA ECMO or VV ECMO within 48 hours, IL-6 of more than 1,000 or ferritin of more than 2,000, refractory vasoplagia, septic shock, so where Oxyris is preferred, and of course we have a cytoscore. So if you have a cytoscore of, this is how you can actually calculate cytoscore. It is a research tool, and it is not a clinical score like an Apache or a SIRA score. So this is a practical approach: confirm ECMO, calculate the cytoscore, select the device which we discussed, integrate the site, the antibiotic caveat, don't forget that, monitoring of the inflammatory mediators, and of course the duration of typically 24 to 72 hours with usage of about 1 to 3 cartridges. So challenges and controversies, yes, the antibiotic removal which we actually discussed, the timing, which is early initiation, which is very important within 72 hours, and Endox trial, which the results are awaited, and they are probably quite promising. Cost, I mean, we all are here, and we know that cost is always a concern. So I think these are my key messages: is the cytokine storm persists on ECMO, because ECMO will only support the oxygenation or organs, and it will not extinguish the cytokine storm. Heme adsorption, which will fill that gap. Clean ECMO trial, it is a practice-changing guideline. Again, the patient has to be selected. Timing is everything. Antibiotic removal, never forget that. And Fields awaits the Endox trial, which we actually are waiting for that. So heme adsorption plus ECMO is not a cure, but a bridge that buys time for the biology to recover. So thank you very much.
Thank you, Srikant sir, for enlightening such a nice talk. Topic was quite a bit complicated, but you have made it so easy. Thank you.
Thank you.
Thank you, sir, for making this topic very simple. It looks very difficult, but you have simplified it for us. Thank you for that. I want to ask one question. Is there any systematic review studies are there to see the difference in outcome between the only when ECMO is used and ECMO plus tocilizumab is used, and ECMO plus adsorption is used.
Yeah, so ECMO plus adsorption, which I showed, was an Endox trial, which the results are coming, and a clean ECMO trial, which clearly showed some benefits. But when you compare, you talked about tocilizumab, right? This I am not aware of that. I don't know.
Any question from audience?
Basically, CSR trial shows no significant mortality benefit in patients of URDS. But ULR trial, when you sub-analyze the trial, basically there was a very crossover trial because the patients were very sick and they were on the verge of mortality. They have crossed over 30% of the patients to the treatment arm. And definitely, if you sub-analyze that trial, the ECMO was beneficial in ERDS patient. There was significant mortality difference. Tocilizumab and ECMO was used in COVID patients, but there was no consistent results as such. And he has already talked about hemoabsorption.
Absolutely. Everything is in detail, it is discussed, and it is a precision adjunct to the standard therapy which is practiced in the current area. And the patient selection, that will matter a lot. And ECMO trial final results are still awaited, so that will put certain highlights on certain things, because patient selection is ultimately the main thing while putting this or integrating heme adsorption with the ECMO. That will matter to save the lives of the patient. Perfect.
Thank you, sir, for your valuable words and inspiring remarks. May I now request respected chairpersons to felicitate our speaker, Dr. Shrikant Sahasrabuddhe, sir. Thank you, sir. May I also request Dr. Milind Vaishnav, sir, to kindly felicitate chairpersons for the session. Thank you, sir.
A slight modification in our scientific programs. As we are a bit late, I think we'll take a short lunch break before we start the next session. So tentatively we'll gather here at 2:30 to begin with the next lecture. Yeah, thank you.
Good afternoon, everyone. After refreshing lunch break, we are move on our next scientific session, CRRT. It is now my great pleasure to introduce our next speaker, Dr. Girish Kumthekar sir, Senior Nephrologist and Transplant Physician at Aditya Birla Hospital from Pune. May I request respected chairpersons for the session, Dr. Sudeep Patil sir, Consultant Nephrologist at New Onkar Hospital from Dhule. Dr. Surendra Jaiswal sir, Senior Physician at Ramakrishna Hospital from Chhatrapati Sambhajinagar. Dr. Avinash Thakur sir, Assistant Professor Nephrology at Government Medical Hospital and College, Chhatrapati Sambhajinagar.
Thank you so much. And it's great to come back to Sambhajinagar, my alma mater. My task is to discuss about CRRT fundamentals, a practical guide. But my hidden agenda is to keep you awake for 20 minutes after a sumptuous lunch. And I'll try to do that to my best of my abilities. I was also told not to display too many studies and datas and fancy slides, so I will stick to the traditional way. These are the questions that come to our mind when we are starting a CRRT. We see a patient and we discuss about what should be the dose, high dose or low dose, what anticoagulation I should use, whether a citrate or heparin or no anticoagulation. What should be the replacement delivery? Should I give the fluid pre-filter, post-filter, both? How do I regulate the fluid? Whether I should only remove the fluid or I regulate the fluid? And then comes the question, when to start it in the disease trajectory? Should I start it early in the disease trajectory or should I wait till the patient earns it? And the last thing that comes to our mind, why CRRT? Why not do an intermittent dialysis? Let us do it for some time and then see if patient recovers or not and then go for a CRRT. So these are the questions I would like to answer in coming 20 minutes. So basically what is CRRT? It's a slow and sustained removal of solutes and water. But what lies in the basic principle of CRRT is to avoid cardiac stunning by rapid removal of water from the intravascular space and to match the fluid removal with the capillary refill rate. Prevent rapid shift of osmoles across the cell membrane. So what we are treating is the intravascular space and we expect the intravascular space to get rid of all the waste products and the intracellular waste products come into the interstitium and the intravascular space and maintain a balance. So CRRT serves to prevent rapid shift of water and solutes across the cell membrane, across the vascular membrane and the interstitium and the vascular space itself. So these are the different types of CRRT which we can use. What is common in all of them? We can take out fluid. That is common in both of them, remove fluid. But there are only few modalities which will give us a convective solute clearance. By convection, we know that we put a substitution fluid into the blood space or the blood column and we remove it mandatorily. So whatever substitution fluid we are putting into the blood, it is removed by the machine by default. We don't set it. This is seen only in CVV-HF and CVV-HDF. Okay? There is another modality of clearance, that is diffusive solute clearance, which happens in a modality when we have a dialysate fluid running across a semi-permeable membrane, which doesn't happen in a scuff, which doesn't happen in CVV-HF. It happens only in CVV-HDF and CVV-HD. So if I have to talk about CVV-HD, I will say it is only good for fluid removal and diffusive solute clearance. Is this only theory? Absolutely not. It tells us exactly what is accumulating into the effluent bag. So for example, I am doing a scuff. What will accumulate in the effluent bag? Only ultrafiltrate. If I am doing a CVV-HF, what is coming to the effluent bag? It is the replacement fluid or the substitution fluid and the ultrafiltrate. If I am doing CVV-HDF, what is coming into the effluent bag? It is the ultrafiltrate, the net ultrafiltration, the dialysate, as well as the replacement fluid. All three will come into the effluent bag. And if I am doing CVV-HD, it is only the dialysate and the ultrafiltrate which is accumulating into the effluent bag. Why is it important? It is because we measure the rate of effluent accumulating into the bag based on the predicted body weight and a time interval, which is usually per hour. So what it becomes? It becomes a effluent rate per kg per hour, and this is called as dose of dialysis or dose of CRRT. So this dose is the fundamental understanding of CRRT based on which we treat a patient, based on which most of the trials have happened, and based on which we do drug dosing in CRRTs. Okay, so for example, if I have to do a dosing for CVV-HDF, what I will do? I will measure what is the ultrafiltration per hour, what is the rate of replacement per hour, what is the dialysate happening per hour. I will divide it by, say, 60 kgs, the patient's predicted body weight, per hour. So that is the dose of CRRT. But it is not that simple. We need not forget, because if we are giving something pre-filter substitution, we are inherently diluting the blood column, and that has to be corrected for the dose. So this is the basic understanding of dose of CRRT, which needs to be calculated on a daily basis. Then comes the question, after this brief introduction, then comes the question, why do we need CRRT? We have other modalities. We have SLED, we have SLED-EF, we have HDF, we have acute PD. Why do we need it? We need it because it is physiological. So what happens? We are removing something from the blood compartment, and we expect the interstitium to shift the balance from interstitium into the blood compartment. And it is our wishful thinking that we say that my ultrafiltration rate, whatever I set, will be reciprocated by the interstitium fluid, and it will shift the fluid from interstitium to blood compartment, which does not happen, because it is governed by something called as capillary refill rate. So if my water removal from the intravascular space exceeds the capillary refill rate, what I will see? I will see hypotension. So I need to match the water removal with capillary refill rate. And this is particularly important in a disease scenario, what we call as sepsis, which is leaky capillary syndrome, where the capillary refill rate has gone haywire. So for example, in a patient of sepsis, I am giving ultrafiltration of, say, 300 ml per hour. The patient is going to land in hypotension because the fluid remains into interstitium, and the intravascular fluid I have removed in ultrafiltration. But CRRT doesn't do that, so that is the reason it is more physiological. And that is why we need it. But this is not enough. The horizons need to expand, and this is how the horizons are expanding. Up till now, we were talking about CRRT, which is continuous renal replacement therapy. But now it is not replacement, it is support. So we don't wait till the kidneys fail. We support the kidney whenever the demand and capacity paradigm has gone haywire. When the kidneys are not able to support the metabolic needs of the body, we support it not only for raise creatinine, raise urea, raise potassium, low bicarbonate, fluid overload. These are conventional indications. We are going beyond conventions because we do CRRT for volume regulation, we do CRRT for immunomodulation, we are doing CRRT for electrolyte disturbances when the creatinine and urea is actually normal. So all these things are expanding the horizons. Then we are trying to achieve immune homeostasis with CRRT. What is immune homeostasis? It is the repercussion of the peak concentration hypothesis, where you can see the peaks of the immune mediators. These are pro-inflammatory and anti-inflammatory. We don't need both. So the peak is cut off by CRRT, and what we achieve is immune homeostasis. And this is not only true in adults, this is true in pediatric patients also. So if you are doing a CRRT in a pediatric patient, we call it as pCRRT, then we can definitely see that the polymorphonuclear leukocyte count is stabilized without giving any changes in the antibiotics. So this is a sustained removal of solutes. So sustained removal is because of the inherent prescription of the CRRT, where the dialysate flow, blood flow, replacement flows are measured in hours, not in minutes. And that's why it is particularly suitable for patients with liver dysfunction and raised intracranial pressure, where we don't expect solute removal in a higher rate. Then when to start and when to stop? This is $1 million question. No agreement till date. But the agreement is on this cartoon. This cartoon tells us that the demand and capacity gap needs to be bridged by CRRT. So whenever we say that the demand is more, capacity is less, as we say in some patients with chronic kidney disease, we need to bridge the gap with a CRRT. So this is demand capacity paradigm. And this was reflected in this article, that what are we waiting for? We see a patient and we are yet to decide whether to start a CRRT. So people have worked on it. So these are all international guidelines which say when to start CRRT. And the terminology, the nomenclature has changed to kidney support therapy, not kidney replacement therapy. If you look closely in all these guidelines, there are more than 6 guidelines. The one thing which you notice is there is no magic number. There is no magic number of creatinine, potassium, bicarbonate, nothing. The focus of all these guidelines is on the stage of AKI and when you are starting a CRRT, whether within 12 hours, 24 hours, 72 hours. And the demand capacity paradigm. So I may start a CRRT for a creatinine of 3 when I see the patient is worsening, and probably I may not start a CRRT for a creatinine of 4 when I see the patient clinically stable. So it is a clinico-biochemical correlation that makes me decide on a CRRT. But what hinges the decision to start CRRT is hemodynamic instability. So that is the pivot on which our decisions are based. Then there are multiple studies which have happened, like ELAINE, AKIKI 1, 2, FST, so many. I just want to focus you on ELAINE study, where the criteria for late CRRT was 12 hours of stage 3. So I see a patient in ICU, I say this is stage 3 AKI, and I am starting the CRRT within 12 hours of diagnosis is called as late CRRT. Okay? Then just move on to say AKIKI, then move on to say ideal ICU. So I am starting a CRRT within 48 hours of stage 3 AKI. So patient coming to my ICU, I am seeing a patient, I say it is stage 3 AKI, KDIGO stage 3 AKI, maybe a creatinine criteria, maybe a urine output criteria. So this is late. So if we look these criteria very closely, do we really practice them? No. So the early versus late debate is a Western debate. What is Indian debate? Late versus very late. This is the real debate what is happening in Indian scenario. So we never fit ourselves into the early CRRT. Whatever we do in practice is either late or very late. Okay? We talk about starting CRRT, but we hardly talk about stopping CRRT. So these are the 2026 AKI KDIGO recommendations when to stop CRRT. So the thing that we need to focus is whether the patient is on diuretics or off diuretics. If the patient is on diuretics, a urine output of 2.3 liters is mandatory to wean off CRRT. The patient is not on diuretics. Even an output of 450 ml a day is enough for us to think of de-escalating the CRRT. Diuretics have no role in postponing CRRT de-escalation. It has to be the native urine output, not augmented urine output. Then this is the very crux of fundamentals of CRRT, that is what anticoagulation I should use. Because anticoagulation dictates our choice of bags. The bags are different for heparin anticoagulation, bags are different for citrate anticoagulation. Protocols are also different. And what the KDIGO says, what the prevalent guidelines, every CRRT should be a regional citrate CRRT unless contraindicated. And what are the contraindications? We'll see in a short time. But these are the options that we have. We have either a systemic anticoagulation or a regional anticoagulation. What do we mean by regional anticoagulation? The anticoagulation starts at the exit of blood into the arterial limb, and it is terminated when the blood is returned back to the patient. So what is anticoagulated is not the patient's systemic milieu. It is the extracorporeal circuit. And this is the preferred modality, what we call as regional citrate anticoagulation. So we have two types of fluids with us. One is hypotonic, one is hypertonic. And both have their pros and cons. And we need to get versed with using both because they are scientifically proven. And this is why citrate is better. This is electron micrograph, which tells us that the citrate column is devoid of any clogging. Clotting is a far later stage when the filter is insalvageable. This is clogging. So citrate prevents clogging. What is the rule of 10%? Whenever you are using a citrate, don't jump in your prescription. Don't increase or decrease blood flow in haste. Don't increase or decrease citrate flow in a haste. Don't increase or decrease calcium replacement in a hurry. Increase or decrease it based on only 10% of the previously set rate. For example, I am giving a calcium at 20 ml per hour. I go up by say 22 or I go down by 18. No 20 to 25, no 20 to 15. Okay, so this is the rule of 10%, which we have learned in a hard way. So this I was talking about. What are the contraindications for regional citrate? They are absolute and relative. This is I am trying to put it very simple. Lactates of more than 8 is contraindication for regional citrate. No compromise in this contraindication. Relative contraindications are liver dysfunction. We are always afraid of doing a regional citrate in liver dysfunction, but it is a relative contraindication. Severe shock, it is a relative contraindication because we can do it if we are using a shock protocol. All right? And then comes the drug dosing and dose of CRRT. These are not only rhyming words, okay? Because every drug dosing depends on dose of CRRT. Because dose of CRRT is the GFR of the CRRT machine, which is the artificial kidney. And the dosing depends on the calculated GFR of the kidney. So dosage have become like a lot of debate on that. Somebody starts at 10, somebody goes at 40. But whatever is, dose depends on the patient's internal milieu and the demands. So we need to calculate the dose on a daily basis. The prescribed dose, which is seen on the monitor, is definitely not the delivered dose. So delivered dose we need to calculate by measuring urea in the effluent bag and patient's urea. So bag urea divided by blood urea becomes sieving coefficient. Multiplied by the prescribed dose gives us the GFR of the CRRT machine, based on which we titrate our antibiotics, antiepileptics, sedatives, nutrition, neuroparalytics. And that is the reason if we don't do this, we keep underdosing our patients. And we start cribbing outcomes on CRRT are not good. We actually underdose them. For example, somebody is receiving a CRRT at 40 ml per kg per hour. The meropenem dose is 1 gram TID with 1 extra dose every 48 hourly. So it is actually more than someone who is with a normal kidney GFR. Okay? And how to do a fluid management? Fluid management, I'll just go a little fast. So there are 3 steps. Okay? First step is to determine patient's body weight. And this is not actual body weight. This is not ideal body weight. This is predicted body weight, which we calculate based on the height of the patient. We don't have weighing scales. Most of the patients come to our ICUs on a stretcher. We can't weigh them. So it's a height of the patient. We calculate the predicted body weight. And then we try to target a fluid removal, which is based on the predicted body weight, which should be 0.5 to 1.5 ml per kg per hour. And how to do that? This is step number 3. For example, a patient with 80 kgs, I want to do patient, I want to make negative. I want to remove some fluid, and I have fixed it at 1 ml per kg per hour. So it becomes 80 ml per kg removal. But that is not the net ultrafiltration, because my nurse is giving him 100 ml per hour of infusions. So if I set net ultrafiltration as 80, I am actually making the patient 20 ml positive per hour, and I am not achieving my goals. And at the end of the day, patient is positive by 600 ml. So that is the reason, first try to understand what intake the patient is taking. In this case, it is 120 ml per hour. I minus it from 80. So the actual ultrafiltration happening is 40 only. So net ultrafiltration is on and above the hourly intake of the patient. That we need to understand. And if we follow this paradigm: removal, refill and balance. So these are the 3 things based on which we manage the fluid on CRRT. And there are 2 types of fluid balances. One is machine balance and one is patient balance. So the machine balance is what the machine is giving you, how many ultrafilters you have given. This is a very tech savvy machine. It gives you everything at the end of the day. But the patient fluid balance is told to us by the nurse, who tells us how much IV given, how much drugs given, how many nutrients given. And then I tell my technician whether to keep the patient in balance or net negative or net positive. And this should be incorporated in your CRRT chart. So my orders should be net negative. Right? Here we go. So at the end of 28 days, what these people found that, okay, so red is bad, blue is good. Okay, red is bad, blue is good. The upper portion is people receiving CRRT as a second choice. The downward is people receiving CRRT as the first choice. What they found, people who received CRRT as a first choice, they had better dialysis-free probabilities at their 28 days. So that became CRRT first policy. This is I want to highlight. We see a patient, we try to do a sled YAF, and then we see, okay, this is not working, let us shift to CRRT. That is not the case. The CRRT first policy says that it was associated with decreased risk of RRT dependence at the 28 days and more RRT free days at 28 days. So that is the reason people are now endorsing CRRT first policy, because that is pivotal for clinical decision making. Then CRRT can't come alone. It usually comes coupled with other modalities. So we don't shy off from coupling all the CRRT modalities with these 3, which is ECMO, hemadsorption and therapeutic plasma adsorption. So these are the modalities I need to club. And the most thing which is least discussed while doing a CRRT is that access. So my only request is, don't use a functioning fistula for CRRT. It is our inherent temptation to use the fistula because it is working. But it is not recommended. All right? And these are the components of CRRT monitoring in ICU. First, we have to start finding indications for CRRT. We actually start it. Then we need to see what is the target molecule. Am I removing urea, potassium, fluid, acid, immune mediators, cytokines, leukotrienes, endotoxins, whatever. Then I see the target molecules based on the dose. Then I monitor the quality of the CRRT, and then I start looking for indication to stop CRRT. So the indication of start CRRT are nothing but the indication of stopping CRRT. What is take home? First identify what is causing the disease in question. Then see the disease severity score. expected time to recovery, the disease trajectory. We see the VDI, the vasopressor dependency index, and then we prescribe and monitor. And all these algorithms decide dose of CRRT, the anticoagulation required, which filter I use, and what ultrafiltration I need to prescribe. So that is all for my side. Thank you so much. Happy learning. So there are two sets of patients. One is adult, one is pediatric. So the KDIGO says it is 25 to 30 ml per kg per hour. That is not the prescribed dose. That is the delivered dose. So once we start increasing the dose of CRRT, we see an inflection point. The dose of CRRT is increased, we get more benefits. But after the inflection point in adults, which is 60, we don't see any more benefits. It's a plateau, it's a flat line. This concept doesn't apply in pediatric population, where the delivered dose is 80 to 120 ml per kg per hour. So in pediatric population, it is high dose CRRT. Adult population, there is an inflection point. So beyond which increasing CRRT dose has no benefits. Yes, sir.
Nice presentation, Dr. Kumtekar.
Thank you, sir.
We should be proud he is from Marathwada region and dominating Pune.
I'm your student, sir. That is my first identity.
And my usual question in any conference where it is CRRT, how many of ICUs have CRRT? 1, 2, 3, 4, 5. And how many ICUs expect in Marathwada region? There must be, in every district there must be ICU. Correct?
Yes.
So this is nice presentation, ideal presentation. But we cannot have always ideal. So automated PD is still a viable option. I
Yes.
just Google.
Yes. Yes.
It should be
Absolutely.
tried.
Absolutely.
When there is no CRRT, even the slate sometimes doesn't work. Yesterday we had one patient with cardiomyopathy, ejection 30%. We did CAPD and she improved. 4 or 5 days she improved and then she had a coronary event upwards. But don't forget PD. For chronic renal failure, PD first. There is a policy. So many countries are doing PD first policy. So similarly, when CRRT is not available,
Yes.
the patient has abdominal surgery, there CRRT you may do. But APD is still viable and very workable option. And you should give sufficient justice to APD.
Actually, the clearances metrics are identical for CRRT and APD. Only thing, the problem about the coagulopathy. If there is a coagulopathy, putting in a catheter in the peritoneum becomes a challenge. And if the abdomen is not feasible for PD, but
So like
clearance, they are equivalent. I completely agree.
with few contraindications,
Yes, sir.
you practice APD. At least PD should be trained. Now the problem is there is no PD training even in DM and DNB course. And that's why all nephrologists should learn PD. I have some problem with the dental, just that's why there's a difficulty in speaking.
Nowadays, we are doing more acute PD actually. We
Shekhar
are not giving any break-in time.
Shekhar must have done at least 500 PD.
Thank you, sir. Thank you so much.
Thank you, sir, for your great presentation and sharing your knowledge with us. May I request respected chairpersons to felicitate our speaker, Dr. Girish Kumtekar, sir. Thank you, sir. May I also request Dr. Nikhil Pathak, sir, to kindly felicitate chairpersons for the session. Now we are forwarding to our next scientific session. Our next session speaker, Dr. Yuvraj Sawant sir, consultant nephrologist at Aster Aadhar Hospital from Kolhapur. May I also request to chairpersons for the session, Dr. Rahul Chaudhary sir, Secretary of ISCCM and Senior Physician and Intensivist at MGM Hospital, Chhatrapati Sambhajinagar, Dr. Rohan Gundre sir, Senior Physician and Intensivist at Chhatrapati Sambhajinagar. May I also request Dr. Milind Vaishnav sir to please come on the dais for chairperson.
So good afternoon all. I think it's a difficult task to talk on CRRT after Girish sir talk. Okay, but no, I will try my best to deliver it. So the topic given to me for what's a CKRT dose, delivery and quality matrix. Difficult to cover in 20 minutes. Mainly I will speak about what is dose, what is the prescribed dose, okay, then quality matrix and few things about the citrate, what the standard of practice. So first I will start with the blunders what I did actually. So basically CRRT program I started in Kolhapur in around 3 years back. 3 years back, one patient admitted under physician, 58-year-old, sepsis, multi-organ dysfunction, admitted in the ICU, and I got a call to start the CRRT. Basically, we have maybe third or fourth CRRT what we are doing actually. And as usual, initial phase of managing. So we are treating patient like CRRT is like 24-hour dialysis. Okay, so that was the what mistake we were doing. So anyway, we have started on the dialysis CRRT. It was a heparin. There was no citrate that time, and everything was good. Fluid balance was good. Electrolyte balance was good. ABG, there was no acidosis. Everything, and but ultimately patient was sick. He had cardiac issue. Patient died of cardiac problem. And after 3-4 days something, then hospital called me after that medical director want to speak to me regarding this case. I was very happy. You have started CRT program, so you have something good I have done. Then he told me that the relatives has complained that because of CRT this patient has died. So I was also surprised what went wrong actually CRT. Then later when I saw the complaint, his son was in the US, he was a clinical pharmacist there. So there, yes, we have started the dialysis, fluid electrode balance was maintained. There was there was no acid-base problem. But whatever dose of antibiotic we have given, or what was the prescribed dose, what was the delivered dose, and so anticoagulation. So he had everything he had copied from the ChatGPT. And even 3 years back, I also don't know how to use the ChatGPT. So that time I was also surprised. So these things we have to see. So that made me to learn all these things again. Yes, so it was a learning curve for me that time. So with a lot of extracorporeal therapies, new advanced therapies we are doing in ICU, I think everybody should know what is the basic mechanics, what is the dose delivery, what is the quality matrix of any RRT, because with the evidence of AI, I think patient will get everything. We are doing right or wrong. So what will you take away? this is today is mainly about, what is dose? Okay, so I will talk about what is the dose. Why there is a problem with prescription delivery gap, okay, and we'll just talk basic about citrate. Few terminologies I want to speak. First is QB. It will come. QB means blood flow rate. Dialysis flow rate. QR means replacement flow rate. QUF ultrafiltration rate. QNet is net fluid removed, and SC is sieving coefficient. So I will start with this case. This is what case I had. This is a case of fulminant acute liver failure. So 17-year female presented to ICU, admitted at the gastroenterologist, acute fulminant liver failure. He had, you can see the INR was 10, enzymes were raised. Okay, so patient was in encephalopathy. Yes, he has borderline kidney dysfunction. Creatine was 3, oliguric. So we have decided to go for the CRRT. Okay, the main indication more than uremia, it was a hepatic encephalopathy. So what we will do? So in this, so this is the prescription for the CRRT. Okay, so what we used to discuss, so whenever any patient comes, yes, we have to see what is the indication, what filter you have to use, what mode of CRRT we have to use, anticoagulation, what dose of CRRT, volume regulation, and therapy termination. So these are what we call as operator dependent. Okay, and what is operator dependent? Okay, so what is the delivery of dose, like solute clearance, effluent dose, and sieving coefficient. So what is effluent dose? So effluent dose is equivalent to the amount of dialysate fluid or substituent fluid to be used, plus hourly ultrafiltration. So what is the standard dose prescribed is 20 to 25 ml per kg per hour. So here in this case, what I have done is, yes, I have used CVV HDF mode. Then it is dose is around, she's 50 kg, so dose 25 into 50, so around 12.1250 ml per hour was the prescribed. So I have kept is 1,500 of dialysis and substitution flow, out of which 600 I have kept for dialysis and 900 I have kept for the substitution. Because I want more of convective clearance, that is the reason I have kept this as a substitution fluid. So what is the evidence that, what is the evidence for dose? So these are the trials for the evidence. These are the trials. So what are the dose target? It was given Ronco. Okay, so what they have done is they have compared 20 versus 35 versus 45. Okay, so what they have shown, it is we have benefit up to the 35 ml. Okay, so after that there was a plateau. It's another two trials. It's ATN 2008 and Renal 2009. Okay. So what they have mentioned, there is no improve in mortality if you increase the dose. So what is the KDIGO 2012 has recommended? It's a delivered dose is 20 to 25 ml per kg per hour. So I have started on the dose of 25 ml per kg per hour. Okay. So what next we have to do? See, initially, then whenever we use this CRRT, okay, so I think every 24 hours we keep on the evaluating. Okay, so whether whatever prescribed dose we have given, whether it is really getting delivered to the patient. Okay, so what we have seen is a delivery dose is almost always less than the prescribed. So not necessary you have prescribed dose of 25 ml per kg per hour for 24 hours. Not necessary you will get the same delivered dose to the patient. So what is the expectation of the delivered dose? At least you should aim for more than, at least you should deliver 80% of the your prescribed dose. And what are the reason for the the less dosing for that what we call as a downtime. Okay, so what is the downtime? So downtime is any period the prescribed therapy is not running. Okay, so like clotting, alarm changes, procedure, and transport. So these are the causes of downtime. Okay, so basically we have machine setup delay, alarm, then catheter issues, procedure transport, and the filter clotting. So at least in practically what I have seen, the more problem with filter clotting and catheter problem. So in my practice, so obviously we have nowadays using citrate as a first line anticoagulation for all the patients. That has tremendously improve the, prevent the clotting. And other thing is access, what I have seen the access. So whenever I find any problem with the access, my practice is to change the access. I never keep on meddling, khicho, adjust karo. I have seen disastrous complication whenever I got the access problem. So whenever I have access problem, I prefer to either I will remove, put there, or I will change the position. So next, these are the, then yes, procedure, transport. Okay, so they are causes, alarms. Okay. So next come is anticoagulation. Okay. So in my practice, initially I have started with the citrate, but now initially I started with the heparin. Okay, so now as a practice I am using citrate as a first line anticoagulation for the most of my patient. So I will show what is that citrate protocol, I should say. So this is the diagram. So citrate anticoagulation is very simple. Okay, so this is a regional citrate anticoagulation. Okay, so what we are doing here, so this is the extracorporeal therapies. Here we are giving the citrate anticoagulation. Okay, that is going to the your dialyzer. Okay, dialyzer from, so presence of citrate, they prevent anticoagulation, and again this returning to the patient. Okay, so so two types of concentrate what we are using. So one is concentrated 4% trisodium citrate we are using, and then dilute citrate, the concentration is there. There is dialysate fluid in citrate what you are using, what is Sika dialysate, that does not contain the calcium. Okay, so this is Sika dialysate we are using that contain K2, K4, K2 plus and K4 plus. So what is this integrated protocol in citrate? Okay, so basically what we are doing, so based on the citrate dose, okay, we have to, based on your post-filter calcium, we are adjusting your citrate dose. Okay, so whatever citrate dose we are giving, we are adjusting based on the post-filter calcium. That is what we have to maintain is 0.25 to 0.35. And on other side, see, on other side, what we are using is the based on the systemic ionized calcium. Okay, so we are adjusting the calcium dose. So this is just mathematics what we used to do in the citrate. So what are the advantage of citrate? Obviously, it's regional, avoids bleeding complication, is double as buffer, highly effective in studies, no thrombocytopenia. Disadvantage, metabolic complication and complex protocol. So how citrate acts? Yes, as we know, this calcium is a factor. What is a important is a factor for the coagulation pathway. So what happened? So here, what happened in citrate solution? So from here we are giving the citrate solution. Okay, so for citrate solution, it is calcium citrate is formed. Okay, so once calcium citrate is formed, so there is no coagulation here. So okay, so from there what is happening? This calcium citrate, most of the calcium citrate, 60 to 70% is coming to the effluent. Okay, so to the effluent bank it is coming. The calcium citrate 60 to 70% is coming out. Remaining calcium citrate is going to the patient. Okay, and here what we are doing, based on the active so citrate active calcium, okay, so it forms calcium citrate complex. So absence of the calcium from the blood in the filtrate result in no clotting. 60 to 70% will filter out and dialysate, or returning calcium citrate into body and broken down into bicarbonate and calcium. So what happened to that citrate? Okay, so when that citrate is one molecule of calcium citrate is converted into 3 molecules of soda bicarbonate. So what we have to do? So when we start the citrate protocol, how we have to? So when we start citrate protocol, the most important thing is what we used to do is the monitoring. Okay. So what we used to do whenever we will start the citrate, okay, so immediately we have to use the post-filter ionized calcium. Within 5 minutes we have to do, okay, and based on that we have to adjust the citrate dose. Okay, first what we have to do, we have to use the post-filtrate calcium. Okay, and next what you do next, and systemic ionized calcium we have to do, some do 6 to 8 hourly. In my practice I have to do 5th hourly, actually 5. I have more frequent I have to do. And based on that, I have adjust the ionized calcium, the dose. See, so next is so what are the bedside targets? What we plan is post-filter calcium is 0.25 to 0.35, systemic ionized calcium is 0.90 to 1.10, and TMP preferably we used to keep 150, sieving coefficient not less than 0.7%, and citrate accumulation less than 2.5%, and cumulative balance we have to adjust. So what we are, this is the chart. Okay, so monitoring calcium is the key. And here what we have done, systemic ionized calcium, we have to do 5th hourly or 6th hourly, and based on you have to do the calcium dosing. And post-filter ionized calcium, you have to monitor, and based on that you can monitor your citrate dose. So lastly I will go fast. See, basically in CRRT machine, the software calculate your calcium flow rate as well as your citrate dose. You have to just give information about what is your ionized calcium, post-filter ionized calcium, and systemic ionized calcium. The machine itself calculate and decide the calcium infusion rate, also with the citrate flow rate. So what are additional benefit of citrate? It is a potential source of calories. It is immunomodulation effect. Yes, there are also trials are also shown lesser mortality. So what are troubleshooting? So this is in citrate usually can get problem because of increased buffering action of citrate, one thing, or there may be problem because of calcium, excess accumulation of citrate that we call as citrate toxicity. So what will happen if suppose is metabolic alkalosis is there? Okay, so metabolic alkalosis can be because of, you have to check volume status, you have to see whether patient is on diuretic or not. So what it indicates? So metabolic alkalosis means there is more buffering action of your citrate. So what we have to do? We have to decrease the blood flow rate. So it will decreases the metabolic alkalosis. Also, what you have to increase the dialysate flow. Okay, so that will remove the citrate morely. And next is about metabolic acidosis. So despite of CRRT, if patient is developing metabolic acidosis, okay, so we have to see whether this metabolic acidosis is because of citrate toxicity or is inadequate buffer. So how will you calculate? You have to calculate what is we call as a total calcium to ionized calcium ratio. Okay, so if it is more than 2.5, it indicates citrate toxicity. And if it is total calcium to ionized calcium ratio less than 2.5, it means there is citrate deficit because of inadequate buffer. You are getting this metabolic acidosis. Last slide. So just to take home message in a CRRT. So effluent is the dose. Okay, and you always evaluate your CRRT. What is the prescribed dose and what is the delivery dose? Okay, and I feel in CRRT, I feel citrate will be the future rather than your heparin. Thank you. And I just want to thank Girish sir. Okay, so he's mentoring us for developing our CRRT program.
Thank you, Dr. Sagar. As we are all aware, we are almost 1 hour late. So I think if there are any questions.
Vaishnav, really, one question. If anybody has a question. CRRT is fine. You are managing machine. The problem is monitoring patient. So how do you do hemodynamic monitoring during CRRT? That is most important. Do you use continuous cardiac output monitoring?
Yes.
So who manages that? So is it, the question is whether it is an intensivist who should do CRRT or a nephrologist do CRRT? Or you are doing joint? Because one who has extensive experience should do CRRT. Once in a month, once in 3 months. One of the speakers once said, if you are using new machine, don't monkey with the machine. It's a very bad comment. But if you don't know the machine properly, don't use it. Otherwise, we will face the problem which he faced in first case. You will be asked, yes, how much CRRT you have done? Has patient died because of a disease or CRRT? How many thrombocytopenia you have seen after CRRT?
So with heparin is very common.
No, even with CRRT, one patient had severe thrombocytopenia. He died because of thrombocytopenia rather than his main disease.
Because of citrate or because of CRRT?
I think somebody from Samir will tell. Was it heparin or citrate? You don't know. Thrombocytopenia, whether it was with heparin or citrate. It is with heparin, I know. But how many cases you have seen? Or you have never done with heparin?
No, it is very common, sir. With heparin, getting thrombocytopenia is very common. We've seen at least 24 hours to 48 hours, we will get thrombocytopenia with the heparin.
But HIT is talked too much on European other countries. India, how many of nephrologists have seen HIT? So, Sachin, not seen. Is it discussed very loudly in Western and hematological conferences? Very less. Very less. Thank you, Vaishnav.
Thank you, Dr. Sagar. Hello.
Hello. Hi, yes. Thank you, Dr. Sawan. That was a really practical guideline for the management of patient on CRRT. I just wanted to ask you and Dr. Kumthekar sir also, what is the role of CRRT in treatment of poisoning, and what insights you could give or about the experience all over about the role of CRRT in treatment of poisoning? Which poisonings have you treated frequently, and what was your experience about that?
Sir, one point to add. Sir, if you compare the intermittent hemodialysis versus CRRT, so I think the clearance will be more with short time with the intermittent hemodialysis than the CRRT actually. So if it is a poisoning, unless there is a hemodynamic compromise, I still will go for the intermittent hemodialysis for treatment of poisoning than CRRT.
Hemoadsorption.
You rather than
Correct.
CRRT as a risk.
Thank you. Thank you, Dr. Sawant. Thank you, Dr. Kumtekar and Dr. Kulkarni sir, for your expert comments.
Thank you, sir, for your valuable insights. May I now request our respected chairpersons to felicitate our speaker, Dr. Yuvraj Sawant, sir. Now I request Dr. Samir Mahajan, sir, kindly felicitate chairpersons for the session.
So due to some logistic problems, we will first have the short CRRT workshop, which will be followed by a session by Dr. Shailesh Kakade sir on establishing a disease donor kidney transplant program, why and how.
Very good afternoon to everyone. So I'll go with the fast. I would like to thank you, Yuvraj sir and Girish sir, for the wonderful presentation. They have done my almost half job. So we'll start. So this is our multi-filter pro machine for CRRT. So इसमें basically हम CRRT में जैसे normal course कर सकते हैं, जैसे citrate course कर सकते हैं, प्लाज्मा फेरेसिस भी कर सकते हैं और पीडियाट्रिक CRRT भी कर सकते हैं. तो इसमें मोडालिटी जैसे सर ने, गिरीश सर और युवराज सर ने भी कवर किया, जैसे कि मोडालिटी CVVH DF, CVVH D, CVVH, ये सारे मोडालिटीज़ हम कर सकते हैं. तो आई विल गो थ्रू फास्ट इनफ. सो ये मॉनिटर स्क्रीन है जहाँ पे हम सारे पैरामीटर सेट्स करते हैं. सो द ग्रीन वन इज dialysis scale and white one is substitute scale. So this is scale 1, this is scale 2. So in CRRT, as Dr. Yuvraj sir has told, that less interruption will help patient to give more results. So we have a good advantage that we can keep, this is a 5 liters of bag. At a time we can keep 10 liters of bag. So while doing 10 liters of dialysis, 10 liters of substitute and 10 liters of filtrate bag, that is the effluent. So ये बेसिकली हमें यूज़ होता है कि लेस इंटरप्शन थेरेपी में. जैसे हमने कनेक्ट किया तो पेशेंट्स को जैसे कि अलार्म्स वगैरह नहीं आएंगे, बैग्स चेंज करने के लिए ज़्यादा टाइम नहीं डालना पड़ेगा. तो इससे क्या होता है कि पेशेंट्स के लिए इम्प्रूव हो जाता है कि लेस इंटरप्शन, मशीन को टच करने की ज़रूरत नहीं है कि जब तक कुछ वैस्कुलर रिलेटेड अलार्म्स ना आए, लो एक्सेस प्रेशर रिलेटेड अलार्म्स. तो क्विकली गोइंग थ्रू. सो दिस इज डायलिसिस पम्प, ब्लड पम्प, filtrate pump and substitute pump. Additional, we have 2 pumps for doing Zika therapy. So this first one is citrate pump and second one is calcium pump. And these three domes are, first one is pre-filter dome. In pre-filter dome, we measure the TMP of the dialyzer. If any clogging is there or any kink is there, the pressure will be rising. So we'll get to know. And second dome is axis pressure. So axis pressure है, एक्सिस प्रेशर से जो कैथेटर से जो प्रेशर आता है, जैसे कि हम ब्लड आउट कर रहे हैं, अगर इनकेस जब जर्क है या किंक है तो उससे क्या होता है कि पेशेंट मशीन अलार्म देगा. तो यहाँ पे जो अलार्म आएगा कि लोअर एक्सिस प्रेशर वाला अलार्म आएगा अगर फ्लो अगर एक्यूरेटली नहीं है तो. सिमिलरली ये जो है ये रिटर्न प्रेशर के लिए है, जो फिल्ट्रेशन के बाद जो पेशेंट के अंदर जो ब्लड जा रहा है, अगर एक क्लॉग है या किंक है तो प्रेशर विल बी राइज. सिमिलरली प्री फिल्टर, जैसे मैंने बताया कि अगर प्री फिल्टर भी अगर कुछ क्लॉट्स वगैरह है तो प्रेशर विल बी राइज. सो वन सिट्रेट पंप और कैल्शियम पंप. सिट्रेट पंप बेसिकली जो ब्लड फ्लो है हमारा, ब्लड फ्लो तो उससे चलता है. अगर इफ यू आर कीपिंग आवर ब्लड फ्लो 100, द सिट्रेट डोज विल बी अकॉर्डिंग टू द ब्लड फ्लो. Additional feature we having warmers, this is called dialysis warmer and substitute warmer. So what is warmer is doing? So warmer क्या करता है, बेसिकली जो फ्लूइड हम पेशेंट के बॉडी में इंसर्ट कर रहे हैं, जो डायलिसिस है, जो सब्स्टिट्यूट है, वो पेशेंट के बॉडी टेम्परेचर के हिसाब से इंसर्ट होता है. जैसे कि पेशेंट के बॉडी में इंसर्ट कर रहे हैं हम, ठीक है. सो दीज आर द वीनस चेम्बर, दीज आर द सेफ्टी फीचर. एयर डिटेक्टर, अगर कुछ एयर वगैरह सर्किट में आए तो यहाँ पे मशीन अलार्म देता है. अगर एयर अगर फॉर एग्जांपल है तो डायरेक्टली ब्लड पंप स्टॉप हो जाता है. तो टेक्नीशियंस को अलार्म आते हैं कि फर्स्ट रिमूव द एयर, देन आफ्टर स्टार्ट द इनिशिएट द थेरेपी अगेन. ओके. सो करेंटली वी आर यूजिंग Zika therapy. So this is AV600 which requires our ultraflux dialyzer. The surface area is 1.6 and it is hydrophilic filter. So we are doing Zika therapy, as sir told. There are 2 types of citrate anticoagulations. One is isotonic and second one is hypertonic. So we are using hypertonic solution, 4% citrate. We are using, it is a 1.5 liters bag. So how it is working? Can you help? So for example, this is the patient. So this is the artery line. So artery line में क्या करते हैं हम, यहाँ से citrate infuse किया जाता है. फिर आफ्टर दिस डायलाइजर में जाएगा, डायलाइजर के बाद विनस चेम्बर में जाएगा, विनस चेम्बर के बाद पेशेंट के बॉडी में रिटर्न आएगा. लेकिन यहाँ पे और एक लाइन है, वो है कैल्शियम. तो यहाँ से हम जो सिट्रेट इन्फ्यूज़ किए जाते हैं वहाँ से हम कैल्शियम बैक इन्फ्यूज किए जाते हैं। इससे क्या होता है कि कैल्शियम कॉम्प्लेक्स जो हम बोलते हैं कि बैलेंस किया जाता है। इसमें एडिशनल और एक है कि बर्लिन प्रोटोकॉल। अभी बर्लिन प्रोटोकॉल मतलब क्या? बर्लिन प्रोटोकॉल बेसिकली क्या है कि जो हम जो सैंपल्स लेते हैं जैसे कि पेशेंट्स के थ्रू, अगर हम सिका थेरेपी चालू कर रहे हैं तो बेसिकली हमको इनिशिएट करते टाइम 5 मिनट्स में, विद इन 5 मिनट्स वी नीड टू चेक द पोस्ट आयनाइज कैल्शियम, बिकॉज हम जो सिट्रेट दे रहे हैं वो एक्यूमुलेट होता है, उसके बाद हमको सिट्रेट का डोसेस देखना पड़ता है। तो यहाँ से हम एक सर्किट का एक सैंपल लेते हैं और एक पेशेंट का सैंपल लेते हैं, तो हम देखते हैं कि एक्चुअली में वर्किंग है कि नहीं। आफ्टर एवरी 4 आवर्सली और 2 आवर्सली, फर्स्ट इनिशिएट 2 आवर्सली वी विल टेक अ सैंपल, आफ्टर दैट एवरी 4 आवर्सली वी विल मॉनिटर द आयनाइज कैल्शियम। हियर यू कैन सी यहाँ पे जो वैल्यूज़ है बेसिकली, तो वैल्यूज से हम जो एबीजीज है, एबीजीज और ये वैल्यूज, फॉर एग्जांपल हमारा जो सिट्रेट है फॉर 1.21 टू 1.35 के अबाव है, तो हम जो एबीजीज है वहाँ से करेक्शन कर सकते हैं। तो यहाँ पे लिखा है कि रिड्यूस 2.0 mmol, ठीक है। तो यहाँ पे हम एडजस्ट कर सकते हैं। सिमिलरली टू सिट्रेट, यस, सिमिलर टू सिट्रेट यहाँ पे हम एडजस्टमेंट कर सकते हैं। फॉर एग्जांपल अगर हायर सिट्रेट डोज जा रहा है मोर देन 0.35, तो यहाँ पे इंक्रीज 0.2 mmol कैल्शियम यहाँ पे अलार्म दिया जाता है, ठीक है। इसमें एक हमारा एक स्पेसिफिकेशन जो है कि हमारा ओपन कनेक्टोलॉजी है। तो ओपन कनेक्टोलॉजी में क्या फ़ायदा होता है कि इन केस अगर डायलिसिस क्लॉग हो रहा है तो मशीन अलार्म देता है, प्री फिल्टर विल बी इंक्रीजिंग, विनस प्रेशर विल बी इंक्रीजिंग। बिफोर क्लॉटिंग वी कैन चेंज द डायलिसर एंड रिप्लेस द विथ न्यू डायलिसर, क्लॉट होने से पहले। तो ये क्या होता है कि पूरा सर्किट अगर लेंगे तो एक्सपेंसिव पड़ जाएगा, लेकिन हम डायलिसर लेंगे, डायलिसर चेंज करके थेरेपी फिर से चालू कर सकते हैं। इन केस अगर हमें सिका थेरेपी चालू है एंड वी वांट टू शिफ्ट टू नॉर्मल कोर्स हिपैरिन और विदाउट हिपैरिन, वी कैन चेंज फ्रॉम हियर। So in this we can switch to the modality. Okay, so we can change the modality to switch off anticoagulation Sika and we go to the normal course heparin. Similarly, treatment interruption कई बार होता है कि सीटी स्कैन के लिए ले जाना पड़ता है पेशेंट को, या फिर मेजरली उनको स्टॉप करना पड़ता है। वो टाइम पे हम कर सकते हैं कि पेशेंट्स को सर्कुलेशन मोड में डाल सकते हैं पेशेंट्स। तो इंटरप्शन, जो थेरेपी इंटरप्शन है वो थोड़ी देर के लिए हम रुक सकते हैं, फिर उसके बाद रीस्टार्ट कर सकते हैं। तो यहाँ पे जो डोसेज है यहाँ पे हम यूएफ सेट करते हैं। फॉर एग्जांपल 50 ml पर आवर, सब्स्टिट्यूट ऑलरेडी सेट है। डायलिसिस 2400, हिपैरिन हम यूज़ नहीं करें इसलिए हिपैरिन ऑफ रहेगा। सो एडिशनल इसमें हम क्या कर सकते हैं, अगर इन केस कुछ पेशेंट रहते हैं कि सेप्सिस में रहते हैं, रेब्डोमाइलिस के लिए केसेस रहते हैं, तो वो टाइम पे हम इमिक-2 भी यूज़ कर सकते हैं। जो मायोग्लोबुलिन रेप्सिस वाले रेब्डोमाइलिसिस के जो केसेस रहते हैं, तो इमिक-2 इज़ अ वेरी गुड ऑप्शन फॉर यूज़ दिस। सो इट हैज़ पॉलीसल्फोन, इट इज़ मटेरियल इन पॉलीसल्फोन और इसका सरफेस एरिया ही 1.8 मीटर्स है स्क्वायर है। तो ये केसेस में हम यूज़ कर सकते हैं सेप्सिस में। वन मोर फिल्टर, सो ये लो फ्लक्स मल्टी इक्वल टू लो फ्लक्स कार्बन डाइऑक्साइड रिमूवल। तो बेसिकली ये जो फिल्टर है ये हम लो फ्लक्स जैसे कार्बन डाइऑक्साइड रिमूव के लिए यूज़ कर सकते हैं। जनरली दिस इज़ नॉट अ इथमो बट इट इज़ अ ब्रिज ऑफ इथमो। जनरली हम विन ऑफ के लिए कर सकते हैं, अगर पेशेंट को वेंटिलेटर से बिफोर ARDS के केसेस में हम कर सकते हैं, मल्टीपल ऑर्गन फेलियर्स में कर सकते हैं, COPD केसेस में कर सकते हैं, जहाँ पे अगर पेशेंट्स को हमें विन ऑफ करना है वेंटिलेटर से, तो बिफोर दैट वी कैन यूज़ दिस फिल्टर एंड दिस वी कैन यूज़ ऑन 4000 ATS, 5000 ATS and also in CRRT. But it requires additional filter like you can use F6 dialyzer also or any dialyzer you can use. Yes. Thank you. Any questions? Okay, thank you.
Thank you, sir. Now we are forwarding to our next scientific session. It is my pleasure to introduce our next speaker, Dr. Shailesh Kakade sir, consultant nephrologist at Jupiter Hospital, Pune. May I also request, please come on the dais for their session chairpersons. SD Kulkarni sir, Professor Nephrology at MGM Hospital, Chhatrapati, Sambhajinagar. Dr. Anant Kadethankar sir, Senior Physician at Chhatrapati, Sambhajinagar.
People are not coming forward for donation. I think everybody
so go
has.
ahead with your presentation.
Yeah. So now I think everybody knows that this was the first transplant which has been seen. So deceased donor or something which is not to be thought to be which was thought really long time back. And this is the next important slide, which is telling us what happened usually. This is a very common unfortunate problems which happened in the road traffic accident, and outcomes are like patient dying, but the most outcome is they are being buried, and which can be changed. That is an important thing which we have to learn. So what is the gap? Why the thing is? So if I was recently in a conference where I was asked what is the most important change you will like to see in a transplant program. So, and that was the main answer from the audience, and also I also gave that we should increase our deceased donor program, because this is the really a big gap which is there. If you can see, less than one deceased donor per million population is something, the data from India. And there are many other countries which are ahead of us, and 90% of the kidney transplant plus more than 90% are still the living donor program. And in the other part of the world, many of them are the deceased donor program, and living donor program is less actually. So I think this is a and the most important thing is that the bottleneck is, it is not the surgical incapacity of the people over here, it is the donor supply. So we don't have a donor. That is the most important thing. For reasons this anchors the program is to reaches the unreachable. So whenever there is a O blood group recipient who is highly sensitized and all these things, they will be helpful with this program. It will reduce the ethical and legal exposure if anybody is trying for illegal or unrelated transplant. So this can that will take more time if it is something unrelated. Multiple institutional values, and it will build the volume and accreditation for the institute also. So that is again the important thing, that why everybody should have a deceased donor program in their transplants. So what is the deceased donor statistics in India? If you see, the number of donors in 2024 in Tamil Nadu is around 268, and if you see Maharashtra is around 172, but it is all around 200, all the south states, Telangana, Karnataka, Maharashtra. And the number of donors, actually we are also having a good number of donors. So this is the 62% of all deceased donor in 2024 came from just 6 southern states. That is again important thing to know. So if anything, why, though I think everybody knows why we require it is a definitely need of the hour. And what is the steps, what we should do, how to build up a deceased donor program. So if you see over here, so the first thing is registration. I think register a transplant center. I think anybody who has been registered for living donation transplant has a registry, can also enroll for the deceased donor. If anything is different, you can we can have anytime interaction or anything. Anybody can stop me at that time. ZTCC or SOTO enroll. I think we have here in Maharashtra, Sambhajinagar has its own ZTCC committee, and ICU and OT certification will be there whenever we have a living donor transplant program. So the other important thing for this thing is the transplant coordinators. So we have to have a core team for it. So who are the transplant coordinator? They should be dedicated, trained in brain death identification and family counseling, the single highest leverage to hire. So this is an important person in our transplant program. So if anybody, transplant coordinators are good hired, they will be definitely helpful in counseling better. And also the brain death panel. So neurosurgeon, neurologist, and even intensivist certified to declare brain death as per this thing. 2 physicians repeated after 6. So this is the brain death panel should be there. It should be discussed in the institution. It should be discussed among your meetings so that the things can be well versed. Retriever surgical team. So if either the in-house team should be there or it should be on call via ZTCC. This is again been thought in Pune ZTCC. Shall we do this or we should be sending our own thing, or empal and available, which should be available 24/7. And transplant nephrology and physician, I think they are without availability, it is not able to happen. And standardize the ICU brain death protocol. Proactive screening should be done. So everybody who has a severe brain injury, traumatic brain injury, CVAs, post-anoxic ICU admission is screened against a standard checklist. So everybody who is admitted to the ICU, so there should be a checklist. Are they fitting in this protocol? If they are fitting, they should be really thought in a different way, and then the next step should be taken in. So the clinical examination by physician, 6 hours interval, and confirmatory examination of the brain dead should be done, and then declaration and the donor maintenance should be done. So donor maintenance is another important thing. Many times we see a donor has been there and we have a donor within for 2 hours or 3 hours. No sir, he does not have any pulse. Now he's pulseless. So that is again important thing. So as soon as the donor is identified, there should be a team of doctor or team of people who are well versed with management, all these things should take care of that thing, because he is going to give the life to next 6 people. That is again important. So hemodynamic support, hormonal replacement therapies, and ventilatory optimization protocol should be done. The important thing is counseling. As soon as the donor is identified or we think that he is a brain dead, so family counseling should be structured. So separate delivery of the bad news from the donation request. And the treating clinical team delivers the prognosis, death news. A trained coordinator, not the treating doctor, raises the donation and only after. So there should be 2 teams who are actually doing the work. One is to declare that patient is brain dead, and the other team should be talking about the donation. If it is a single person who is talking about both the things, patient usually the relatives usually does not get counseling. They will think there is some problem. So please try to have 2 different people who are not, and the other persons who are going to counsel should not come in the picture at all in the previously. So they should be always coming only after that the brain death is. Or there is a concept of other people that they should be keeping on seeing or talking to the relatives, but there are these are 2 different thoughts. Few people agree with it, few people don't agree. And the approach only after brain death certified, use a structured counseling script, give family time, privacy and room for one questions, document consent as per ZTCC or requirement. Retrieval team, ZTCC allocation and green corridor, these are the important things. I think everybody knows about it. Keep the transplant recipient ready. This is a nephrologist job, and I think we should have a good waiting list, and if the waiting list initial 4 to 5 patients should be worked up thoroughly and should be kept for the transplant ready. If today transplant come, that recipient should get a organ, or he should be fit for the taking the organ, that is an important thing. So what I do at my center is first 3 to 5 patients should be thoroughly worked up. Later on patients can be asked to see after 3 months or 6 months, and then they can be worked up. Anyway, working them up is good because we could find out sometimes new things which we actually need a treatment, and his health itself can improve by doing that thing. So as soon as the offer is received, should we check the match, recipient recall, cross match confirm, and the operation theater should be ready. So, and what happens? So we should always track the outcomes and audit it rigorously. So there should be a transplant registry, graft and patient survival tract per case reported to ZTCC, and also mortality and morbidity if anything happens. So we should be thinking about why the morbidity and mortality happened. So it should be regular structured review, and outcome should be given directly to the NABH quality metrics, and program credibility will be more. So now there is a notos autos which are taking the data. Sorry. Financial thing, I think if you see the per organ cost is typically lower than the living donation because donor side surgery is avoided in the donor hospital, and no donor medical workup, but actually we have to work up the deceased person. So that I think has to be free of cost only. New cost line budget, coordinator salaries, on-call surgical team, and ICU donor maintenance resources. These are the extra cost to the hospital which the living donation will not have. If you start one program, then the multiple specialties will join to us. If you start the kidney, liver, heart, cornea, everything can be together, and the hospital also can have a good number of patients because of this. So what should be the timeline? First we should think about starting the registration part. Once the registration is done, the phase 2 should be thinking about the protocols, staff training, counseling pathways. Then it should be the retrieval time, and phase 1 we should start talking to the taking the calls and starting the program. So common barrier and how to mitigate them: missed potential donors, low family consent rate, delayed retrieval logistics, and staff unfamiliarity with the process. So these are the usual barriers to the program which we should mitigate. So in summary, a deceased donor program is built, it should not be declared, and we should have a regulatory registration before anything else, trained coordinators, and ICU screening protocol should be set in, and we should start the audit doing of all these programs. Sir, any comments on this?
Actually, I am a physician, and some of the physicians, they do not know all these things. So there should be awareness amongst physicians themselves and who are running the hospitals.
Yeah, so that is the most important thing. Why the thing is required that anybody who is having the disease, any donor which is a suitable donor, should be told to everybody in the thing. It is very important to train or to tell everybody that by doing a deceased donor transplant, it is going to help a lot of in the community, everyone. Sir.
Tomorrow is the Indian Organ Donation Day, 3rd August, because the first heart transplant was done on 3rd August. World Organ Donation Day is 13, so 13. We should be active between 3 to 13, make more awareness, make more donors. Myself, Sachin, and Dr. You should be there. We were the witness for first cadaver transplant in Aurangabad. We were sitting in MGM office up to 12 o'clock. Who to give kidney? It was that way illegal. अवैध म्हणतो ना तसं. कारण त्यावेळी ZTCC नव्हती. There was no ZTCC. But still we got a green signal from higher authority. Go ahead. What happens we'll see later. Because we can't waste organs. Principle is don't waste organs. So any brain dead should go for cadaver donation. Sometimes the relatives are insisting. but there is apathy from hospital and doctors. So
Yeah,
that apathy is to be removed. Recently, Makaran, where is Makaran? So they did cadaver donation and then they got bill of about 3 lakhs retrieval charges. And we have fixed retrieval charges cannot go beyond this. Somebody may charge 5 lakhs. So that is not a money-making business unless you do multi-organ. Same hospital uses kidney, liver, as Bajaj has done. They use liver as well as kidney. If you get one kidney out of one cadaver, it's not going to be cost-effective for that hospital. So it is like a social cause. You have to do it like a social service. So many patients are dying without because of lack of organs. So it should be taken agitation, jantar mantar agitation. So there should be some agitation for organ donation. Otherwise,
I think so.
Donor rate cannot increase. So I am still happy that last 10 years we have done at least 46. So average 4 per year. And every hospital average is 3. I'm not going to tell the names who has done the maximum, who has done 1 or 2. But I think corporate hospital should go ahead. One thing we are very proud that the government colleges, Nanded, Latur and Aurangabad, they have done 2 each. So that should be the important, all government colleges, all civil hospitals. We have given lecture on civil hospital with civil surgeon, make it as an NTRC. We should promote more NTRCs around Kolhapur if there are some big cities and some good ICUs. Try to make NTRCs. We have made Parbani, Jalna. So more and more NTRCs should come out. So all nephrologists or corporate hospitals should try to make NTRCs and increase the donation rate. Thank you.
Thank you.
Thank you, Dr. Kakade, for nice presentation.
Thank you, sir. May I now request Dr. Ujjwala Zawar Madam to felicitate our chairpersons for the session. Thank you so much. Now we are moving our next session. It is my pleasure to introduce our next speaker, Dr. Sachin Soni sir, transplant physician at Medicare Hospital, Chhatrapati, Sambhajinagar. I also requested, please come their chairpersons for the session, Dr. Avinash Tribhuvan sir, senior physician intensivist at Asian Hospital, Chhatrapati, Sambhajinagar, Dr. Manoj Munde sir, internal medicine and physician nephrologist at Krishna Hospital from Bid, Dr. Nikhil Pathak sir, consultant pediatrician at Kamalnayan Bajaj Hospital, Chhatrapati, Sambhajinagar.
Right, yeah. Okay. Good afternoon, close to evening, and thank you Samir, Nikhil and team Bajaj Hospital for inviting me. I think we must give credit to them. I never thought such kind of program can be conceptualized and then get executed. Like you have conducted a full day CME on extracorporeal therapies, which is the need of the hour. And the time I received the invitation and detailed program, I had a thought in mind, by the time I will speak, I will see only speakers, chairpersons and organizers in the hall, and that is not untrue now. So I will be very quick. Although I have been given 20 minutes, I will try to kind of be fast and cover it in maybe 10 minutes, because now I see most of the nephrologists here. and very few physicians. These were tailored for physicians. So these are various terms, plasma exchange apheresis, plasmapheresis, TPE, therapeutic apheresis, and plex. They all mean the same, although they are used interchangeably, but the term means same. It comes from the Greek term, and which means to remove forcibly. So plasmapheresis can be plasmapheresis and cytopheresis. Plasmapheresis is what we are going to talk about. Cytopheresis is something which blood bank does. So it, like creation of platelet bags or single donor platelet is by this technique of plasmapheresis. So these are various details. Now I think, although I had a plan in mind to talk more about them, but we will go quick on this now. So plasmapheresis, as I said, is plasma separation. How it is done? It is done by a centrifugal method, and second is a membrane filtration, which is what we practice the most. Like for a nephrology team, that is the type of plasmapheresis we are using, and centrifugal is used by blood bank. What principle is followed by centrifugal separation is based on the specific gravity, and these are various specific gravities, and based on these specific gravities, the centrifugal machine achieves the separation of various components, and these components can be removed. Like you can remove plasma. So even the FFP bag which we get, so blood bank does this FFP creation using this method. So this is the Cope spectra machine, which most of the blood bank have. They have the centrifugal system, and that centrifugal system works on this principle, so they can separate various blood components using this method. So that is cytopheresis. Now I'm going to talk about plasmapheresis by filter. So plasmapheresis by filter is the what we most of us are practicing. It is a hollow fiber membrane. Again, like a dialysis membrane, it is made up of polysulfone. Only thing is that like the pore size and the cutoff is such a way that it can remove larger size molecules. So using AI, I have created this difference between hemodialysis filter and plasmapheresis filter. Probably the font size is smaller, so may not be visible from the distance. So hemodialysis filter is removes smaller solutes, and it has a smaller pore size of these fibers, whereas plasmapheresis filter has a larger pore size that is between 20 to 100 nanometer, which is almost 20 to 100 times that of a normal hemodialysis filter. And that is the reason. So what hemodialysis filter is removes is our uremic solutes like urea, creatinine, and uric acid, whereas what plasma filter removes is large size molecules which we want. So the basic is, it is extracorporeal separation of plasma from cellular blood components, and with removal of, or the treatment of plasma. Either you remove plasma or you can remove components of plasma, which we are going to discuss. Rationale is you want to remove unwanted substances from your blood. What type of substances you can remove is autoantibodies or immune complexes. You can remove cryoglobulins. You can remove protein-bound toxin. I think some time back there was a discussion about poisoning. So there are certain protein-bound toxins. They can be removed using therapeutic apheresis. Then paraproteins like in myeloma. So it is only effective for substance with large molecular weight, low volume of distribution, and a long half-life. Low volume of distribution means the molecule doesn't go out of circulation and gets attached with the cells. If that is the so, it cannot be removed. That molecule needs to remain in intravascular space to be removed. In therapeutic plasma exchange or plasmapheresis, which we practice most commonly, in that situation plasma is removed and it is replaced. Whereas in apheresis, just like in cytopheresis or selective apheresis, you remove only the desired component using a specific type of filter. It is a bridge and not a cure. So quite frequently, plasmapheresis, particularly in nephrology practice, we use for immunological conditions, and in that situation, this therapy has to be combined with immunosuppressive medicines. So frequently, you identify a protein target. Protein target generally is antibody. So antibody in circulation you remove, but at the same time you have to stop formation of those antibodies, and for that you need to use immunosuppression. Quite frequently it is rituximab, which is an antibody suppressant, like it reduces production, and then there are other immunosuppressive medicines. And now I don't need to tell this to my nephrology colleagues that this is the extracorporeal circuit. So it is just like hemodialysis. So this is one important point. So when you do plasma, how much plasma you remove, and what is the effect of removal of one plasma volume. So one plasma volume is roughly calculated as 40 to 60 ml per kg of the body weight. Generally we presume that it is around 60 kg person. Then if you are doing at least 2.5 to 3 liter of plasma, that is one plasma volume. So one plasma volume if you are doing, you are removing 63% of the offending agent. You are not removing everything. You are removing nearly 63% of the element which you want to remove. What you can see is, like, if you increase plasma volumes, that increment is not that great, and the amount of work you are required to do is huge. And then you remove, say, for example, if you are removing 1.5 plasma volume for a 60 kg person, it would come something around 4 liter of plasma, and then that removed plasma to be replaced with any kind of replacement, either with the plasma or albumin, it will be a Herculean task, and the benefit achieved through that excess is not great. That's why in general most of us practice one plasma volume removal. So what is a typical prescription is one plasma volume removal. How frequently we should do, that is the next question. Like if you do a plex, what is the next plex you are doing? It depends on the type of condition you are treating, what is the indication, what is the type of molecule which is being targeted. So it depends on many of those things. So generally in some situation it is daily, but quite frequently it is the alternate day plasma. And one of the reasons, like if I want to talk about the logic why alternate day is used, so most of the antibodies which we desire to remove are IgG type of antibodies. IgG type of antibodies are more in interstitial space. They are less in circulations. And you need time for them to come back to intravascular space. So if you kind of do a plex today and plex tomorrow, maybe it is not beneficial because your target is not there in intravascular space. So that's why if IgG is the target, IgM on the contrary remains in circulation, and you can do it daily or quite frequently because it is in intravascular space. A single plex session also removes a significant portion of IgM, and that is sometimes used in Waldenstrom, hyperviscosity syndrome. So replacement fluid, again, it depends on what you have, what kind of cost matrix is there. Preferred is albumin, but cost will go very high. So most of the time we are using fresh frozen plasma. And there are certain conditions like TTP, HUS. If you are doing for that condition, then FFP must be used because you want to because FFP replacement also acts as a therapeutic tool in that. About ratol poisoning, we have been frequently using with very good outcome ratol poisoning. If there is a liver dysfunction, use plex. It works wonderfully in that group of patients. So now even my gastroenterologist or physician, anyone under whom the patient is admitted, as soon as there is a derangement of liver enzymes or PTINR derangement, they themselves want plex to be done because it is delivering good result. Then familial hypertriglyceridemia presenting as acute pancreatitis is another condition which I have been exposed to use plex, and there are certain drug intoxications where you can use. This is one of the picture which few days back I put on a physician group. So this is a patient of familiar hypertriglyceridemia presenting as pancreatitis. So on the left, this is the pink colored plasma which came out after the first session of plasmapheresis. This patient had initial triglyceride of more than 1500, and you do plex till your TG goes less than 500. So this was the second session. You can see there was improvement in plasma color. So, and then Samir wanted me to also speak about immunoabsorption. So immunoabsorption is generally a selective filter adsorption. So you are removing a part of the thing, not entire plasma. So it is selective removal. Although I was not in the hall, I was following all the lectures online, and I know two previous speakers already spoke about cytosorb, oxyris, toramycin, Seraph, HA330, so I'm not going to talk about them. So these are the filters which are used in sepsis situation. Then this is like HA230, sometimes we are using in patient with sepsis, as well as in poisoning. HA230 is commercially available in Sambhajinagar also. We have successfully used in organophosphate poisoning also. And apparently now we don't have any case control or that level of data, but it apparently works in that situation. So maybe Avinash have more opportunity to use these kind of filters, and he may be already using. I know they use a lot of cytosorb. They have used a lot of cytosorb in past. Then this is another thing which we are doing not frequently because it is very expensive, immunoadsorption in ABO-incompatible transplant. I spoke about being used, plasmapheresis being used in ABO-incompatible transplant, but there we are using removing entire plasma and replacing it. Again, I think because nephrology crowds, I don't need to explain it much, but whenever we are doing ABO-incompatible transplant, we are looking at the titer. So if a B donor is donating to O recipient, we are looking at anti-B titer, which is very well measured. So, and we generally want that titer to be less than 1:16. Some program are happy with 1:32, and in that way. So when you do one plex, for example, your initial ABO-incompatible titer is 1:128, say anti-B titer. One plex generally reduces it by 1 log. 1 log means it brings it down to 164. 1:64, then it goes down to 1:32. So it needs more than one plex session in that situation. Whereas something like this, the immunoabsorption, so there is a column, staph column, which is coated in a filter, which is immunoabsorption. It only specifically removes that antibody. So, so glycosorb A will remove only A, glycosorb B will remove only B, and AB will remove both A and B. So that, and there are many other, the glycosorb is one example which I have used. There are other makers in market. It needs 2 machines in series. This is one of the examples of our one patients. So on the left side of the skin, there is a plasma filter. So this is the plasma filter on the top. So it is separating plasma, and that separated plasma is passed through another circuit. Like there is a small filter on the right top, and that is a glycosorb, and that small filter at the right top costs nearly 3 lakh rupees. But it selectively removes, so it reduces risk of multiple plasma infusion, and it leads to significant drop. Like in 1.5 hours, it can reduce 1 log. So if you run the system for say 6 hours or 9 hours, it can reduce by 6 logs. And when we handle patients with very high titer, we tend to use this. So I think that's all. Bell has already rung, so I will stop.
It was a very informative one. Being a pediatrician, we face a lot of these issues. We don't do more of kidney transplant, but cytopheresis we do a lot. With sickle cell anemias, we have treated patient, and we have done. So it's a very good thing, and it's a very good modality. And today, Sachin sir has enlightened us more with that, and hopefully we can incorporate it in our practice. Thank you.
Very nice and elaborative session in short span of time. Anybody is having some questions? So we already using cytosorb and plex, but definitely he enlightened us many more indications where we can definitely use the plex.
Yeah, there are a lot of filters in market now. There is HA230, HA330, HA380, and there is HA130. Now, there is a lot of experience coming about HA130 use in early sepsis. And quite frequently, the thing which happens is many of times, which is true also with CRRT, that when we incorporate these filters, say cytosorb or any kind of extracorporeal filter which is late in the stage of the disease, when patient is really bad, and in such situation it is very difficult to, I remember in COVID era, like we used lot of cytosorb for cytokine storm. Some of the patients improved and some of the patients didn't improve, in spite of that time we were monitoring IL-6, that time we were monitoring TNF-alpha, and a single session of cytosorb will almost normalize IL-6 levels. But whether that normalization, biochemical normalization translates into clinical efficacy, that always remains a question. So not all patients with normalization of cytokines get benefited. There are many, I think, very complex topic. I think Vinod Gosavi and Dr. Srikanth spoke about it. Results are not consistent in all, and I think body is very different than what biochemical lab can tell us.
That's true, and the patients are usually multifactorial to deteriorate sometimes. Thank you for the knowledge.
Thank you, sir, for your valuable insights. May I now request our respected chairpersons to felicitate our speaker, Dr. Sachin Soni, sir. Request Dr. Geeta Ferwani Madam to felicitate chairpersons for the session. Thank you, madam. Now we are forwarding to our next scientific session. It is my honor to introduce our speaker for the next session, Dr. Samir Mahajan sir, consultant nephrologist at Kamalnayan Bajaj Hospital, Chhatrapati Sambhajinagar. May I also request respected chairpersons for the session, Dr. Ujjwala Jhawar madam, senior physician at Jhawar Hospital, Chhatrapati Sambhajinagar, and Dr. Shekhar Shiradhonkar sir, senior nephrologist and HOD of nephrology department at Dhoot Hospital, Chhatrapati Sambhajinagar. May I also request Dr. Geeta Ferwani madam for the chairperson. May I also requested Dr. Sandeep Deshmukh sir for the chairperson for the session.
Good evening, everyone.
Let me talk something.
Yes, yes.
I congratulate Samir for organizing such a great meeting and enlightening about the various extracorporeal therapies which are available and which we are able to use in our future practice also. And I think it is a concluding lecture.
This talk and then 4 case discussions.
Yeah, okay. Panel discussion.
15-20
okay.
minutes, yeah.
So I request Samir to enlighten us about dialysis to transplantation navigation.
Thank you, sir. As Dr. Sachin Soni told that there are hardly, all the crowd is only of nephrologists now. So probably this talk may not be that relevant now. So I'll try to wind it up fast. So, yes, ma'am. So when we talk about dialysis to transplant navigation, so basically the approach, how we look at a patient who comes to us with CKD stage 5 or end stage renal disease is changing over time. So there was a time when end stage renal disease CKD meant death. Then there was a time when dialysis rationing was done, where only acute kidney injury patients were dialyzed and CKD patients were treated conservatively. Probably Kulkarni sir has seen that era. Then there was a time when dialysis was considered as the treatment of choice and the survival tool for patients on with CKD, end-stage renal disease. And now there is a time where transplant is the norm, and unless there is a contraindication, we should go for transplant for each and every. So changing times, changing strategy, approach. So I'll just go through that strategy. So when the kidneys fail, when they ask help, by definition, renal failure is TKD stage 5D, rather when GFR is below 15 and with uremic symptoms, the mortality increases as well as window of opportunity. Early recognition of this window before catastrophic decompensation. So when to act? So the time to act is not when the patient comes with symptoms. Time to act is when the patient comes at least at stage 5, we should act. That is GFR 15 before the patient gets uremic symptoms. What is justice? Justice is when people receive what they are due. So in CKD, there is a lot of injustice. I always say there is a lot of injustice because it is a burden of dialysis, high cardiovascular risk. So it's not only medical injustice, but the patient has got a lot of injustice in terms of the expense, the hospital visits. It's like practically thrice a week dialysis. So half of the life is spent in dialysis unit. Plus one family person also goes to hospital almost half of the month. And plus job loss, plus societal impact. So it's like a curse in a way, if we see. So end-stage renal disease, a patient with end-stage renal disease is at crossroads. And there are different directions where the patient can go. Of the directions, the first and most common is dialysis, hemodialysis, peritoneal dialysis. Then other option is conservative care, which nowadays probably is not required that much, particularly when patient needs some renal replacement therapy because of availability as well as state support, facilities, affordability of the treatment, and universal availability. Probably at taluka places also nowadays government has initiated dialysis units. Then another choice is kidney transplant, and then obviously with it comes kidney transplant therapy planning, which is a teamwork. So the patient needs to know that he's not alone, and we walk with the patient every step of the way. Yeah. So dialysis is considered as bridge to transplantation, and the bridge to life is beyond dialysis. So dialysis is not the destination, it is the waiting room. Dialysis modalities, assessing patient fitness, hemodialysis, peritoneal dialysis has been discussed in detail. I will not go into the depth of that. Obviously, when we talk about dialysis, the most important crucial point is access formation, ultrasound mapping, access creation, and then cannulation of the fistula, and handling that arm or those vessels with care is most important thing which is required. Dialysis treats kidney failure, it does not restore health. This is something which all of us should know. Removes toxins intermittently rather than continuously, because most of the time, even now, patients coming to OPD, they always compare dialysis and transplant, and actually there is no comparison. It cannot fully replace endocrine kidney functions, fluid electrolyte fluctuations contribute to cardiovascular stress and progressive frailty. Dialysis is a life-sustaining therapy, not a life-restoring therapy. And if we go into evidence, this is data from USRDs from 2013 to 23, and obviously mortality rate in dialysis, mortality rate among patients on dialysis is much higher than those who underwent transplantation. In fact, dialysis survival can be compared to common cancers, and unfortunately, it is somewhere between colorectal and lung cancer in males as well as females. So though we have a lot of good centers for dialysis, but universally if we see, dialysis survival is not that great. Another evidence, strong evidence in favor of transplantation is BMJ systematic review. This is the latest evidence and meta-analysis 2022, where we see 92% of studies in this meta-analysis showed transplantation improved long-term survival. And hazard ratio is 0.45, that is kidney transplantation reduced long-term mortality by 55% compared to those remaining on dialysis. So when I talk about crossroads, what is the best exit? Best exit is something where we have a VIP pass, like we have a VIP darshan pass for Shirdi. So preemptive transplant is best exit. But not everyone takes that exit, obviously. Because, and why we say that preemptive is best? Because preemptive transplant which is performed before dialysis, and it is associated with superior graft survival, reduced cardiovascular morbidity and improved quality of life. Patient avoids the physiological toll of dialysis, then a lot of cost is saved, vascular access complications are avoided, fluid shifts and chronic inflammation is avoided. Definitely outcomes are consistently better than transplantation after a period on dialysis, particularly when the dialysis vintage is longer. Now, there can be missed exits, so missed exit is not the end of the story. First exit, obviously it is preemptive KT. Second exit, we can say early KT, short dialysis vintage, avoid fistula or long-term access. We can just put in a perm cath nowadays and get away with transplant within 6 to 8 weeks. Third exit, which is common, I guess, in this part of the world at least, late KT after a few months, few years of dialysis, large dialysis vintage. And obviously the worst part as of now in this region is fourth, that is no live donor, wait for few years or in fact a decade sometimes for a deceased donor. Missed exit, missed today, whenever we miss a road, it is harder tomorrow. So we should always try, as physicians, we should always try to convince the patient for earlier kidney transplantation and restoration of life rather than going on dialysis for some reasons. Possible reasons of missed exit or missed opportunity is one of the most important reason is late referral by primary doctor or by late referral in terms of in spite of referral late presentation by patients or families, acceptance issues. Then temporary medical contraindication in some cases, donor incompatibility, infection, financial barriers also sometimes cause delay or miss the opportunity of transplant. A missed transplant opportunity does not always mean transplantation is no longer possible. Reassessment can open the next exit always. Correction of the infection, correction of the cardiovascular status, all these things can happen. There can be obstacles. We can always take a detour around the road construction. Obstacles can be overcome, and such obstacles should not abandon the opportunity of transplant. So what are the treatable barriers? Anemia, coronary artery disease, which are like borderline causes where transplantation is delayed. Obesity, active infection, incomplete vaccination, financial planning can also be one of the. This is a famous news. So nowadays we are even thinking about going for xenotransplantation. Pigs who can be cultivated and probably can give kidney, where there won't be any waiting list for kidneys. The ideal world probably. Transplant evaluation, rigorous screening, medical eligibility, psychosocial, multidisciplinary team, and legal issues. In terms of disease donor transplantation, allocation logistics, ZTCC has its own rules, and particularly patients on longer dialysis vintage get additional points, and there is a scoring system for failed transplant, for donors, additional scores for donors. Living versus deceased donor pathways. Obviously, living donor transplantation offers the shortest wait, best graft survival, and the option for preemptive surgery, which is not available for deceased donor transplantation. But ideally, deceased donor transplantation has its own importance because a living person, ethically, it is more superior than living donor transplantation. Technical aspects. Life after transplantation, obviously long-term stewardship, lifelong medication adherence is required. Managing adverse effect, quality of life and rehabilitation is much better after transplantation. So, last few slides, every dialysis patient deserves a transplant conversation. So, every patient who comes to a physician's clinic or a nephrologist clinic should be assessed in terms of why this person can't get a kidney, why this person can't be transplanted, because we are nowadays crossing all barriers. Few years ago, there were a lot of contraindications for transplantation, which are becoming indications nowadays, like ABO incompatible transplant, transplantation of recipients above 60 years of age, transplantation after a coronary event. So there are a lot of things which are changing, and so in each patient, the question that should first come to our mind is why this patient can't be transplanted. So every dialysis patient deserves a transplant conversation. It's a journey, not just a treatment, obviously. Dialysis sustains life, navigation creates opportunity, and transplantation restores the possibility. So obviously there's no comparison. It's a slow process of navigation from dialysis to transplantation. In disease donation, we should always ask this question to the society. One of these two will get your organs. The society is to decide, and our doctor fraternity also. Conclusion, optimizing the renal journey. Physician call to action means all of us, obviously. Refer for transplant evaluation for a CKD patient at GFR less than 20 ml per minute, not at dialysis initiation particularly. Means we should not wait for the uremic symptoms to occur or the patient to go into pulmonary edema before referral, because then at least the first exit is lost, that is preemptive transplantation. Advocate for preemptive transplantation wherever clinically feasible. Engage early with the multidisciplinary transplant team. Educate patients on living donor options and the transplant pathway. So early referral saves grafts, integrated care saves lives. So this is all about it. Thank you. Open to questions if any.
Yes, sir, it is actually a very good guide to all physicians also. So most of the time we see CKD patients, the creatinine keep on rising. That is for 2 creatinine, 3 creatinine, we just consider it as a number, but in terms of GFR, that is almost 50-60% renal function down.
Good branch. Initially it was just cardiology, gastrology. Now very meritorious students are coming to nephrology. In Abdar, he is from PGI Chandigarh. To get selected in PGI Chandigarh is an honorable. Another thing why this is flowering is there are so many interesting trials coming in nephrology. Initially there were mainly hypertension, cardiology. There are very few trials in nephrology. And I request all hospitals to participate in nephrology trials. We have at present 3 trials. I will communicate to all nephrology. I request even one patient is important. So globally they want 80 patients, and we have almost 8 centers in India. One of them, luckily, we are participating in very global trials. We have lupus trials, we have FSGS trials. So please participate in international trials. It is an honor to Aurangabad. It is not only MGM. So I request all nephrologists to be part of international trials. Okay, thank you. Samir, nice presentation.
Thank you, sir.
Thank you, sir, for your valuable insights. May I now request our respected chairpersons to felicitate our speaker, Dr. Samir Mahajan, sir. I request Dr. S.G. Kulkarni sir to kindly felicitate chairpersons for the session. Thank you, sir. Thank you so much. Now we are forwarding to panel discussion. I would like to invite Dr. Gauri Kulkarni. Dr. Gauri Kulkarni Madam, Consultant Nephrologist at JJ Plus Hospital, Chhatrapati, Sambhajinagar. Dr. Bhagyashri Patil Madam, Consultant Nephrologist at Hedgewar Hospital, Chhatrapati, Sambhajinagar. Dr. Rahul Ruikar sir, Consultant at Medical Hospital, Nephrologist, Chhatrapati, Sambhajinagar. And I would like invite moderator Dr. Samir Mahajan sir.
I'll just dictate the हा मी तर करतो ना, पण ठीक आहे आता येऊन जा ना, अरेंज ऑलरेडी. नाही तुम्हाला मॅक देऊ ना, माईक कोण हा तुम्ही बसल्यानंतर एवढे उंच नाही आहात. तुम्हाला मी केस सांगेल ना, डोंट वरी. पॉवर पॉइंट PPT पॉवर पॉइंट दिया शंकर PPT कुठे तो PPT घेतलाय का नाही तुला दिलेलं. स्लेड वर CRT वर टाकलेलं. स्लेड वर CRT डाउनलोड्स मध्ये नाही CRT मेल ओपन आहे का? करने किया होता CMA मेल काढा नाही, ती नाही मेल आयडी. हा या मेल आयडी वरून खालच्या हेच इथूनच ओपन करा. इथे नाही दिसत. ठीक ठीक ठीक. So this is not a talk or lecture. Basically, we'll just concluding session where we discuss few cases, few practical cases and case scenarios. So a lot of discussion happened today about SLED, HDF, CRRT. SLED अच्छा है या CRRT अच्छा है, and plus pros and cons of SLED and CRRT and all those things. This was a study I presented in 2016 maybe, 10 years back, where we did compare CRRT, CRRT versus SLED, that is PIRRT or SLED, whatever you say, and the conclusion was like adaptation of PIRRT, that is SLED, which was relatively newer concept, resulted in 37% reduction of utilization of CRRT, because that time the concept was like CRRT was being utilized a lot, but it was very costly and typical pros and cons of CRRT, and SLED was a newer concept, HDF was very new. So adaptation of PRRT resulted in 37% reduction of utilization of CRRT. That was a great achievement, and the mortality was better. I mean, there was no much mortality difference. So practically we could not find any particular modality better over the other one when we compare for dialysis. So from that to now there are changing concepts over the last 10 years. So SLED versus CRRT, which patient needs which modality? Let's keep it practical and short. So I'll present few cases to the esteemed panel and let us have their opinion. So case 1, basically the decision framework when SLED, when CRRT depends on hemodynamic stability and vasopressors, neurological status, fluid overload and mechanical ventilation, acid base and hyperkalemia, and resource availability. Going to case 1, it is a post-CABG cardiogenic shock. Patient history is 68-year-old male. Post-op day 1, emergency 4-vessel CABG was done. Difficult CPB weaning. LV ejection fraction before surgery was 40%. Post-operatively, the patient was in AF, so could not be evaluated. Vitals, very high dose inotropes, triple vasopressors on, mechanically ventilated, anuric AKI. So labs not that important, but anuric AKI, potassium of 6.7, severe acidosis. So basically needs renal replacement therapy. Fluid overload of 5 liters. So what is the choice of therapy? Panel discussion depend whether we go for SLED or CRRT.
Right, sir. So good evening, everyone. As Sudhir sir has mentioned previously, that obviously if PD should be the first priority in such cases, and but currently in this case where the triple vasopressors are required and acidosis is severe, so we can either go for SLED or CRRT. But CRRT, if it is available in the institute, then I think CRRT should be used in view of severe acidosis, that very high vasopressor support, and the fluid overload is also there. So I think CRRT would be better if it is available, or else we can go for CRRT.
Any other opinion, point to add?
Yes, we agree.
Mike.
So CRRT is definitely better because it will give a sustained flow for the dialyzer, and it will cause less hemodynamic instability, especially in CABG. Why CABG patients? Because if the surgery is on pump, already kidney has received so much damage because of inflammatory markers, and the time of the when the patient is on pump also matters. So kidney is going already through especially through inflammatory damage, and on that top of it, if we give hemodynamic instability, it will again increase the load on kidney. So CRRT is better in this case.
So I agree. The modality selected was CRRT, and few points. Profound cardiogenic shock and triple vasopressor support requires optimal hemodynamic tolerance. I think this is exactly what Madam has told. Continuous correction of severe acidosis and hyperkalemia is required, and that can be done well with CRRT. Gentle continuous fluid removal even with patients on double or triple vasopressors, and flat trajectory continuous ultrafiltration prevents hypotensive crisis. So clinical pearl, optimal support modality in highly unstable post cardiac surgery patients. CRRT is probably treatment of choice. Case 2, it is a recovering, yes sir.
The outcome of the patient will be decided by what was the morbidity, why he went in AKI, why he went in cardiac shock, what was LV function, whatever modality.
Agreed, sir.
The basis of the recovery or the factors which will lead to recovery is what is the cause, why he went in cardiac shock, triple vessel disease, operated. Usually they do off pump. Now nobody does on pump, or it was on pump.
No.
Off pump. So it is like a minimal invasive surgery.
No,
Usually 4 grafts are there. It may be on pump. Possibility of on pump.
It was on pump. You are not sure.
No. She had the case.
Actually, it was your case.
On pump, difficult to wean the pump, sir.
Yeah,
Difficulty to wean the pump.
weaning was difficult.
So he has a very bad LV probably.
Yes, sir.
No,
so that's
40% was the LVF. 40% before surgery.
So what was the reason why he went in cardiac shock, AKI?
I agree, but I would put it in different way. I agree that the underlying cause for AKI will decide the mortality.
Correct.
But with RRT in such case, I usually think that we are just buying time for the underlying cause to recover. And probably in such situations, CRRT will buy more time than SLED. Okay. This is what I feel.
Don't be too optimistic about CRRT. I am not negative. The AKI mortality with CRRT is 50 to 80%. Because you choose very bad patients. The cause is
Agreed.
For CRRT, you choose very bad patients. So in spite of CRRT, AKI progress is still bad. It is 50 to 80%. So if the underlying cause is treatable, otherwise patient will recover. Otherwise, the progress is very bad.
Agreed. APD can be done.
Yeah. When I was in Bombay Hospital, such high-risk patient, they used to do PD catheter on table. Before patient comes out of hospital, they used to put PD catheter. So we can start PD immediately next day in case patient goes AKI. So that time CRR was not there. Even SLED.
Even now, we use APD for such patients in some cases.
So such high-risk patient, ask them to put PD
Yeah.
on table itself. So your job is easy.
Thank you, sir. Next case, recovering CABG patient. Post-op day 4, elective CABG extubated already, improving cardiac function, minimal vasopressors, persistent oliguria, moderate fluid overload, mild acidosis, potassium of 5.4, and probably sepsis related acute kidney injury. So, what is the option, what is the choice here? SLED versus CRRT.
The choice.
SLED, sir.
So, anything you want to elaborate, or I should
Just
go
for
ahead?
the control of the fluid, and there is no risk of any cardiogenic shock or worsening of any hemodynamics on SLED, and patient is also free. So,
Yeah.
stable.
So basically, even here, we won't go with intermittent full dose hemodialysis. We would choose something of SLED versus CRRT. And obviously, we will select SLED here. Hemodynamically relatively stable patient, already extubated. Effective fluid removal and correction of azotemia and electrolytes in terms of SLED. Less resource intensive, obviously less cost, and excellent ICU throughput. I mean, utilization of manpower, logistics, everything is here. So, SLED can be the ideal bridge therapy for recovering ICU patients with persistent renal failure, and mostly oliguric or non-oliguric AKI, ATN in such cases. Case 3 would be a complex neurosurgical patient. Patient history says complex spinal surgery, posterior fossa decompression, CKD stage 4. So underlying CKD was there and septic AKI. So basically AKI on CKD, normal ICP, moderate norepinephrine and fluid overload. So basically shock but not very bad. Neurosurgical case, stage 4 CKD, and on top of that acute kidney injury which was related to sepsis. So what is the choice of therapy here? Elaborate.
Yes, sir. SLID as ICP is normal and the vasopressor support is also not much. So I think SLID would be appropriate in this case. CRT would be luxury. So I think SLID would be can be done in this case. Yes, sir.
मराठवाड्यात लक्झरीची सवयच नको.
त्याच्यामुळे SLID is good enough, sir.
So as Rahul has rightly said, we will choose SLID, and because there is no raised ICP, no cerebral edema, it allows necessary neurological assessments between dialysis sessions because it's not a continuous therapy, 6 to 12 hours, mostly 6 to 8 hours as everyone does. Adequate hemodynamic stability, better tolerated than standard intermittent HD while remaining cost effective. So recent neurosurgery alone does not mandate CRRT. So this was the point to be highlighted here, because every CABG or every neurosurgery does not mandate a CRRT when there is a renal failure, particularly AKI. Next case, SAH with raised ICP, day 5 after aneurysmal SAH, post-coiling procedure, post-procedure, external ventricular day in situ, cerebral vasospasm, map target 90 to 100 mmHg, hyperkalemia was there, pulmonary edema, anuric AKI, so obviously fluid overload, hyperkalemia, metabolic acidosis, all those complications, and ICP of 20 to 25 mmHg, high risk of osmotic shift. So can you highlight the way we go?
Of choice would be CRRT. That is because
Any
of rapid
justification or?
Yes, since the patient is having raised ICP, there is high chance of increasing cerebral edema by the intermittent dialytic therapies. CRRT would be better. It will avoid that rapid shifts, and it will help in recovery also.
So I agree. In fact, madam is seeing probably most neuro and neurosurgical cases related to nephrology here. So obviously, there are clear multiple indications where CRRT would fare slightly better than SLID, at least if available and if affordable. So CRRT avoids rapid osmotic shifts and cerebral edema inherent in intermittent therapies. I need not go into the depth because it has already been discussed a lot throughout the day. Preserves critical cerebral perfusion in the setting of vasospasm and raised ICP. Continuous, highly controlled fluid removal and potassium correction. So CRRT definitely would be selected as a choice of therapy here. The universally preferred modality in unstable neurocritical care patients rather. So it's like a, I can compare it to an equalizer where we, in sound system, we use the equalizer. So we need to, there's no black and white, it's all gray zone between SLID and CRRT. So we need to see the hemodynamics, we need to see vasopressors, we need to see neurological status or cardiac status of that patient, LV ejection fraction, patient trajectory and fluid target. And depending on the point where we are in these 4 or 5 parameters, we can probably tilt the curve towards the SLID or CRRT. So practical decision algorithm, again the same thing more or less. So basically hemodynamic status, neurological status, fluid balance target, severe electrolyte derangements, vasopressors and local expertise and resource availability. So these are the points which we usually consider and then take a decision about choosing CRRT or SLID. Any particular points the panel wants to highlight, they can. Questions from the audience, if any?
I think, sir, RRT should be offered. Like all post-op reversible cases, RRT should be offered. Sometimes prolonged intermittent RRT does perform well.
Yeah.
If CRRT is not available, even then 6, 8, or even 12 hours of SLID can do wonders. So it should be offered. Patients.
Many times we use it as a mini CRRT, cost-effective mini CRRT.
And there are a lot of patients who are baseline CKDs and who will have those stressors and they'll end up with AKI, fluid overload, some metabolic problems. It is just a bridging and they should be offered.
Ideally, practically we don't have ultra pure facilities and practically we are not doing HDF yet in our town. But once we start adding the convective clearance, probably the gap will be even lesser in terms of PIRRT and CRRT. So even I agree with the same thing. So thank you panelists for sharing the session. Yeah.
We're very patient listening. Really, really patient listening.
So thank you all. Yeah.
So when the road is safe, whether it is nano or it is Mercedes, you reach the destination. There may be a time lag. I mean, the road is bad, whether it is nano or Mercedes, you will have an accident. So it depends on what patient you are treating rather than what modality you are treating.
Thank you, sir. May I now request respected Dr. Anil Joshi, sir, Professor of Medicine at Hedgewar Hospital, Chhatrapati, Sambhajinagar, to kindly felicitate panelists. Thank you so much, sir. As we come to the end of today's CME program, I would like to express my heartfelt gratitude to everyone who contributed to its success. I sincerely thank you, KBH Hospital, for giving me the wonderful opportunity to serve as the Master of Ceremonies for today's academic program. I truly been an honor and a valuable learning experience. I extend my sincere gratitude to our CME Organizing Chairperson, Dr. Samir Mahajan sir, and our CME Organizing Secretary, Dr. Nikhil Ingle sir, for their constant guidance and support. A special thanks to our Director of Academic and Research, Dr. Milind Vaishnav sir, for his encouragement and continuous support. I would like also express my heartfelt gratitude to my HOD and Manager of the Research Department, Mrs. Sheetal Anandgaonkar Madam, for her trust, guidance, and for giving me this wonderful opportunity. Thank you. Now we are forwarding for vote of thanks. I hand over mic to Organizing Secretary Dr. Nikhil Ingle sir.
So we conclude today's program with the vote of thanks. Firstly, I would like to thank all the honorable dignitaries and the delegates and the chairpersons who could greet the event. Secondly, I would like to thank the Chief Executive Officer of our hospital, Dr. George Fernandez sir, the Medical Director, Dr. Ajay Rote sir, and our Academic Director, Dr. Milind Vaishnav sir. I would also like to thank all the chief guests, the guest of honor who could grace the event. I would like to extend a sincere gratitude to our industry partners. Last but definitely not the least, I would like to thank all our team members, including the marketing team, the research department, and our transplant coordinator. Finally, I would like to sincerely thank Dr. Samir Mahajan sir, Head of the Department Nephrology, Kamalnayan Bajaj Hospital, who envisioned this academic extravaganza. His constant support and guidance make this program a true success. Thank you everyone and see you soon.